Check. Hello, test 1 2 3, check. Check, test. Hello, test 1 2 3, check. Hello, test 1 2 3, check. Ranjit, light again குறைச்சிக்கங்க. Check. Hello, test 1 2 3, check. Hello, test 1 2 3, check. Mic test. Hello, test 1 2 3, check. கரெக்டாக இருக்கு. Hello, check, test 1 2 3, check. Hello, test. Check. Hello, test 1 2 3, check. Test 1 2 3, check. Hello, test 1 2 3, check. Check, test. Hello, test 1 2 3, check. Check, test. Check 1 2 3, check. Mic test 1 2 3, check. Test 1, test 2, test 3. வேற ஒரு லேப்டாப் போட்டு செக் பண்ணி பார்த்து தெரிஞ்சிடும்.
இல்லை வந்துச்சு,
இல்லை ஜம்ப் ஆகிறதுக்கு சொல்கிறேன். Check, test. Hello, test 1 2 3, check. Hello, test 1 2 3, check. Check, test 1 2 3, check. Mic test 1 2 3, check. Hello, test 1 2 3, check. Mic test 1 2 3, check. Check, test. Hello, test 1 2 3, check. Mic test 1 2 3, check. ரஞ்சித் உள்ள ஸ்பீட் பேக் ஆகுது. Hello, test 1 2 3, check. Check, test. Hello, test 1 2 3, check. Test 1, test 2, test 3, test 4, test 5, test 6, test 7, test 8, test 9, test 0. Hello, test 1 2 3, check. Check. Hello, test 1 2 3, check. Check, test. இல்லை உங்களுக்கு இந்த சோர்ஸ் பாருங்கள், டேட்டா போகிற சோர்ஸ் பாருங்கள், ஜம்ப் ஆகலை பாருங்கள். டேட்டாவில் போகிற சோர்ஸ் ஜம்ப் ஆகலை பாருங்கள் உள்ளார. அது கரெக்டாக இருக்குல்ல, அதான் ஏன்னா இங்கே அவுட்புட்டில் கரெக்டாக இருக்கு பாருங்க, ஜம்ப் ஆகாமல். Check. Hello, test 1 2 3, check. Check, test. Hello, test 1 2 3, check. Mic test. Hello, test 1 2 3, check. Check, test. Hello, test 1 2 3, check. Hello, test 1 2 3, check. Check, test. Hello, test 1 2 3, check. Check, test. Hello, test 1 2 3, check. சார் இதுக்கு பவர் எங்கேருந்து சார் வருது எல்இடிக்கு? அங்கே சோர்ஸ் வந்து அதில் லாக் ஆகிடுச்சு. செக். ஹலோ, டெஸ்ட் 1 2 3, செக். டெஸ்ட் மைக் டெஸ்ட் 1 2 3, செக். ஹலோ, டெஸ்ட் 1 2 3, செக். டெஸ்ட் மைக் டெஸ்ட் 1 2 3, செக். ஹலோ, டெஸ்ட் 1 2 3, செக். ஹலோ, டெஸ்ட் 1 2 3, செக். ஹலோ, டெஸ்ட் 1 2 3, செக். மைக் டெஸ்ட். ஹலோ, டெஸ்ட் 1 2 3, செக்.
Hello, check, hello, check, hello, check. Check, hello, check. Hello, Ranjit?
இதான் அண்ணா கேட்குதாண்ணா? குமார்ண்ணா, இது ஆக்ஸ் வச்சுருக்கீங்களா பாருங்கள். ஆக்ஸ் வச்சுருக்கீங்களா பாருங்கள். நான் பேசின்னு தானே இருக்கேன்.
ஹலோ, ஆடியோ கேட்குதா?
ஹலோ
மைக் செக்.
அண்ணா இப்போ கேட்குதா? அண்ணா கேட்குதாண்ணா?
ஓகே கேட்குது.
ஓகே, நம்ம இதில்
இது வந்துருச்சா? மிஷின் அவுட் வந்துருச்சா?
இல்லை, மிஷின் அவுட், ஒரு மிஷின் அவுட் வந்துடுச்சு.
சரி ஓகே, நான் அந்த கேமரா செக் பண்ணிட்டு லைனில் வரேன்.
கேமரா செக் பண்ணிட்டு கேமராவை கனெக்ட் பண்ணுறேங்க.
ஓகே.
அப்படியே மைக் செக் பண்ணுங்க. மாஸ்கை கழட்டி பேசுங்க.
ஹலோ 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 ஹலோ
ஹலோ ரஞ்சித்.
சொல்லுங்கண்ணா.
ரெட் மைக்.
ரெட் மைக் இப்போ நீங்கள் பேசுறது?
ஆமாம்.
கரெக்டாக இருக்குண்ணா.
ஃபீட்பேக் எதுவும் வருதா?
ஃபீட்பேக்கு லைட்டாக. ஹலோ,
கம்மி பண்ணிட்டுமா?
ஃபீட்பேக் நீங்கள் கம்மி பண்ணுங்க. சரி பேசுங்கண்ணா.
ஹலோ செக் செக். ஹலோ ஓகேவா? நான் கம் பண்ணணுமா?
செக். இந்த ஆடியோ இல்லை, அந்த ஆடியோ.
செக் செக். மைக் செக். 1 2. ஹலோ செக் செக். ஹலோ ஹலோ ஓகேவா ரஞ்சித்?
உங்களுக்கு கரெக்டாக இருக்குண்ணா.
ஓகே. ஹெட் மைக் இது.
ஓகே, கரெக்டாக இருக்குது.
இது கேமரா மட்டும் காமிச்சிடுறேன், ஒரே நிமிஷம். கேமரா ஒரு சோர்ஸ் வருதா பாருங்க. இங்கே உள்ள மாஸ்க் போடுங்க. மாஸ்க்
சரி அண்ணா, 2 டிவிஐடி 2 சிக்னல் கனெக்ட் பண்ணிட்டாங்களா குமார்ண்ணே?
எஸ்.
2D மிஷின் ரெண்டுமே ஆனில் இருக்கா
சார்? எது ஆனில் இருக்குது சார்?
2D மிஷின் ஒன்று தான் ஆனில் இருக்குது.
ஒரு சிக்னல் தான் வருதா சார்? ஒரு சிக்னல் தான் வருது.
சென்ட் ஜூட் மெடிக்கல்.
அது காமிங்க.
கேமரா ஆன்ல இருக்கு.
கேமரா இன்னும் ஒன்று தான் ஆன் பண்ணியிருக்கேன்.
இல்லை, அங்கே ரெண்டுத்தையும் லைனை கொடுத்துட்டிங்களா?
கொடுத்துருக்கேன். 2 லைனை ஆன் பண்ணி தான் இருக்கேன்.
2 ஆன் பண்ணி தான் இருக்குது. இல்லையா? வரல. எந்த சிக்னல் வந்து இங்கே செக் பண்ணுறேண்ணா. அங்கே பின்னாடி சுவிட்செல்லாம் ஆனில் இருக்கான் பார்த்துக்கண்ணே.
ஆனில் தான் இருக்கேன்.
இந்த சென்ட் ஜூட் மெடிக்கல் இருக்குல்ல, அது வெளியேந்து வர சிக்னலா உள்ளேருந்து வர சிக்னலா?
எது எது ரஞ்சித்?
சென்ட் ஜூட் மெடிக்கல்னு இருக்குல்ல.
ஆமாம்.
அது வந்து உள்ளே இருக்க மானிட்டரா வெளியே இருக்க மானிட்டரா?
உள்ளே
இருக்குது. அப்போ வெளியே இருக்கிறது வரல.
வெளியே இருக்க வரலையா? அந்த இது சார், அந்த இது ஆன் பண்ணி தான் இருக்குது சார்.
இதை செக் பண்ணுறேன்.
ரஞ்சித் ஒரு நிமிஷம் இருங்க. ஆன் பண்ணல சார்.
ஆன் பண்ணலையா?
கேமரா கனெக்ட் பண்ண சொல்லுப்பா. இப்போ பாருங்க ரஞ்சித்.
வரலண்ணா.
வரும் கொஞ்சம் இப்போ தான் ஆன் பண்ணியிருக்காரு சார்.
ஓகே.
அந்த வெளியே இருக்க இது போட்டிருக்கல. ரஞ்சித் பாருங்க.
இல்லை ஒன்றும் வரல.
இப்போ தான் இல்லை சார் அது. ஹலோ இப்போ தான் சார் ஆன் பண்ணியிருக்காரு. வரும். இல்லை சார் அந்த பாருங்க மேலே ஒரு சிக்னல். ரஞ்சித் கொஞ்சம் வெயிட் பண்ணுங்க. ரஞ்சித் கொஞ்சம் வெயிட் பண்ண சொல்கிறார் சார்.
ஓகே ஓகே. Check this. Check this. This. Check. Check this. Check. லேப்டாப் வரலன்றாங்களே, டிஸ்கனெக்ட் பண்ணிருக்கீங்களா?
இல்லை, கனெக்ட் பண்ணி தான் இருக்கு.
கனெக்ட் பண்ணி தான் இருக்காமே.
வேற லேப்டாப் போட்டு செக் பண்றோம்.
எடுத்துட்டு போட்டீங்களா? எடுத்துட்டு போட்டீங்களா?
வேற லேப்டாப் போட்டு செக் பண்றேன். அந்த ஃபிளிக்கர் ஆகுதுல, வேற லேப்டாப் போட்டு செக் பண்ணுங்க.
லேப்டாப் மாத்தனீங்களா?
வேற லேப்டாப் போட்டுருக்கேன்.
வேற லேப்டாப் போட்டுருக்கீங்களா? அது சரி ஓகே. நீங்க கனெக்ஷன்லாம் முடிச்சிட்டு சொல்றீங்களா? செட்டிங்ஸ் மாத்திக்கிறேன்.
நீங்க வாங்கலாம். ஏன்னா அந்த ஃபிளிக்கர் ஆகுதா, எதனால ஃபிளிக்கர் ஆகுது? இந்த இன்னொரு லேப்டாப் போட்டு செக் பண்றேன். அதுக்காக தான். லேப்டாப் ஏதாவது இஷ்யூ இருக்கான்னு. அப்படியா சரி சரி ஓகே. இல்லை அந்த பழைய லேப்டாப் போட்டுருக்கான். அவன் தான் இன்னொரு லேப்டாப் போட்டு செக் பண்ணுறதுக்காக தான். ஏன்னா அவர் தான் சொன்னார் இன்னொரு லேப்டாப் போட்டு செக் பண்ணி.
நம்ம நேற்று செக் பண்ணும்போது இது பண்ணி செக் பண்ணோம். அது வச்சாச்சு. நம்ம பிபிடி ப்ளே பண்ணி செக் பண்ணோம். இந்த வெறும் டிஸ்பிளே வரும்போது நமக்கும் நேற்று அந்த பிரச்சனை வந்தது. அதுக்கப்புறம் பிபிடி ப்ளே பண்ணும்போது சால்வ் ஆயிடுச்சு. அதுதான் நான் இப்போ கூட பண்ணுவேன்.
அப்படிங்களா? அப்போ நான் இதே எடுத்துடலாம், விட்டுறோம். இதான் ஆமாம், செக் பண்ணுறதுக்கு அது டிஸ்பிளே ஃபிளிக்கர் ஆகுது. வேறு லேப்டாப் போட்டு செக் பண்ண அவர் பக்கத்தில் இருந்து சொன்னார். அதனால தான், வேறு எதுவும் இல்லை. இதுவும் செக் பண்ணி சும்மா அந்த ஃபிளிக்கர் எதனால் லேப்டாப்னாலே இல்லை, இது உங்கள் டிஸ்பிளேனாலே செக் பண்ணிடலாம். அதனால தான். ஜஸ்ட் வியூ தான். நான் அந்த ஃபிளிக்கர் ஆகுதா இல்லையான்னு பார்க்கணும் நான் எதனாலன்ட்டு. சிறப்பு. சரி நீங்கள் இதே போட்டுங்க, விட்டுருங்க. இதே போடுங்க. வேணாம் விட்டுருங்க, இதே போடுங்க.
செக் டெஸ்ட். ஹேண்ட் மைக் எப்படி இருக்கு? செக் டெஸ்ட். அது பேசுறதை வச்சு கரெக்டாக இருக்கும்.
அது வந்துச்சு.
இது பின் பண்ணல.
டெஸ்ட் செக் டெஸ்ட் செக் டெஸ்ட் செக் டெஸ்ட். எவ்வளோ வருது? நான் இப்போ போடியம் பேசுனேன். இப்போ செக் பண்ணுங்க.
Hello, test, mic testing 1 2 3. Podium mic testing 1 2 3.
அப்படியே இருங்க.
Podium mic testing 1 2 3. Test. Podium mic testing 1 2 3 3 2 1. Hello. Test. Test mic. Test mic 1 2 3 3 2 1. Hello. Test. Clear இருக்கா? Test mic. Test. 1 2 3 1 2 3. ரஞ்சித் கரெக்டாக இருக்குங்களா மைக்கு? ஹலோ மைக் டெஸ்டிங் 1 2 3. ஹலோ டெஸ்ட் 1 2 3 3 2 1. ஹலோ ஃபீட்பேக் வருது பாருங்கள் கொஞ்சம். ஹலோ டெஸ்ட் மைக் டெஸ்டிங் 1 2 3. டெஸ்ட் mic testing 1 2 3 3 2 1. Hello. Test. Mic test. Hello. Test. Hello. Testing 3 2 1. Hello. Mic testing. Okay va? Testing 1 2 3 3 2 1. Hello. Testing. Hello, test. Mic test 1 2 3. Hello. Test. Okay. Clear? Test. Mic testing 1 2 3 3 2 1. Hello. Ranjit, audio okay va? Hello. Test mic test 1 2 3. Hello. Test. Mic test 1 2 3. Hello. Testing 3 2 1. Hello. Test. Mic test. Okay. ரெக்கார்டிங் கம்மியாகுதா? கண்ட்ரோல் ரூமில் தான் கொடுத்துருக்கீங்களா? ரெக்கார்டிங் கம்மியாகுதா அப்போது? அது வழியாக கொடுத்து கட் பண்ணி கொடுத்துட்டாங்க உள்ள அந்த மைக் ஒயரை. எது? ஒரு நிமிஷம் இருங்க. எதுங்க? இல்லை அவங்க அதை எடுத்து அந்த ப்ராசஸரில் கொடுத்து அது மூலிமா எடுத்து இது கொடுத்துருக்காங்க அவங்க. கட் பண்ணியிருக்காங்க. அது ஏற்றின இதுவாகிடும் ஸ்ட்ரைட்டாக கொடுத்தா. ஹலோ டெஸ்ட் மைக் டெஸ்டிங். ஹலோ இப்போ ஹலோ டெஸ்ட் மைக் டெஸ்டிங் 1 2 3. ஹலோ இல்லை இங்கே பக்கத்தில் நின்று பேசுகிறேன் நான். ஹலோ மைக் டெஸ்டிங். ரஞ்சித் ஆடியோ கரெக்டாக வந்துச்சுன்னு சொன்னீங்களா அங்கேயா? ஹலோ டெஸ்ட். ஹலோ மைக் டெஸ்டிங் 3 2 1. ஹலோ
கரெக்ட் அதில் தான் இருக்கு. அது இல்லைன்னா அவுட்புட்டே வராது. அதில் வராது. இல்லை வராது. 60 அவர் வச்சுட்டாரு. எது ரெக்கமெண்டடோ அது மட்டும் தான். 50 மேலே.
ஹலோ டேஸ்ட் டேஸ்ட். இப்போ பாருங்கள் கொஞ்சம். ஹலோ டேஸ்ட் டேஸ்ட். ஹலோ ஹலோ. அந்த டிபி இப்போ கொஞ்சம் பாருங்கள் சார். ஹலோ டேஸ்ட் டேஸ்ட். ஹலோ ஹலோ டேஸ்ட் டேஸ்ட்.
நம்ம ப்ளே பண்ணும்போது
6 dB வருதுங்களா இப்போ? ஹலோ டேஸ்ட் டேஸ்ட் டேஸ்ட். மைக் டெஸ்டிங் 1 2 3. ஹலோ ஹலோ டேஸ்ட் டேஸ்ட். இப்போ போடியம்ல பேசு.
செக் செக் 1 2 3 செக். மைக் செக் செக் செக். ஓ செக் செக் செக். ஓகே செக் செக். வருது அப்போ. Check 1 2 3 check 1 2 3 4 5 6 7 8 9 10. Check 1 2 3 4 5 6 7 8 9. 1 2 3 1 2 3 4 5 6 7 8 9 10. 1 2 3 4 5 6 7 8.
ஹலோ டேஸ்ட் 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 டேஸ்ட். ஓகே அப்படி இருங்க. போடியம் பேசு.
Check 1 2 3 check check 1 2 3 check 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 1 2 3 check.
12 இன்ச் மைக் இது.
Check 1 2 3 check.
பேசுங்க.
Check 1 2 3 4. வருது. Check 1 2 3 4 5 6 7 8 9 10. 1 2 3 4 5 6 7 8 9 10. அதுக்கு மேலே வேணாம் வராது.
நார்மல் கேபிள் மைக்ல பேசுங்க. சார் நார்மல் கேபிள் மைக்ல பேசுங்க. கேபிள் மைக்ல பேசுங்க. கேபிள் பாருங்க. கேபிள் மைக்ல பேசுங்க.
Check 1 2 3 check check 1 2 3 4 5 6 7 8 9 10. 1 2 3. அண்ணா இங்கே அவுட்புட் லெவல் கம்மியாக இருக்குண்ணா. Check check 1 2 3 check 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 check. Check check check. இவ்வளோ கிட்ட வச்சு பேசுவாங்க. Check check 1 2 3 check check. HDMI புரியலையே.
HDMI to Cat 5 இது வச்சுருக்கீங்களா இல்லையாம்மா? நெட்வொர்க் கேபிளுக்கா?
பேசுவா. Hello, hello. Hello, hello. Hello. Hello, hello. Mic testing. Hello, hello. Test, test. Hello, hello. Hello, hello. Mic testing 1, 2, 3. Hello, hello. Hello, hello. Mic testing 3, 2, 1. Hello, hello. Hello. Mic test, mic test. Hello, mic test, mic test. Hello. Test, test. ஒரு சேனல் தான் கேக்குது இல்ல? ரெண்டுத்தையும் கொடுத்தாச்சு. அங்க ரெண்டு கேபிளும் கொடுத்துட்டீங்களா நீங்க? ஹலோ ஹலோ ஹலோ. பேசுவா. ஒன்று தான் கேட்குதா? ரெண்டு கேபிள் தான் போட்டிருக்காரு ஆடியோ. Hello, hello, mic testing, mic testing. Hello, hello, test, test, test. Hello, hello, mic test, mic test. Hello, 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 mic testing. ஹலோ ஹலோ. இல்லை முதல்ல இருந்த மாதிரியே கொடுத்துங்க சார். கொஞ்சம் தானே கம்மியாக இருந்தது. டோட்டலாக இல்லைன்னா அப்புறம் ஒரு மாதிரி ஆகிடும். ஹலோ 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 ஹலோ. மைக் டெஸ்டிங். ஹலோ 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 ஹலோ. டெஸ்ட் 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 டெஸ்ட். Hello, hello, hello. Mic testing, mic testing. ஹலோ எபி பேசு. எபி மை எபி போடியமில் பேசு.
ஹலோ மை செக்கிங். ஹலோ
பாருங்க.
ஹலோ ஹலோ
ஹலோ ஹலோ ஹலோ ஹலோ. டெஸ்டிங் டெஸ்டிங். ஹலோ டெஸ்டிங் Hello, hello. என்னது?
Hello, my testing. 1, 2, 3. Hello, 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 hello. Hello, my testing.
டிவி ஓகேவா? ஆர் பேசு. வந்துட்டார் ஒரு வந்துட்டார். அது ஓகே இல்லை டிவி இது ஓகே இல்லை உங்களுக்கு இன்கேஸ் ஆச்சு இல்லை சரி இப்போ எல்லாம் டிலே வருது இல்லைங்க டைமிங் 2 கேமரா வச்சுக்கலாம் டிலே வருது எல்லாமே
ப்ரெசன்டேஷன் அவ்வளோதான் வரும். பாருங்க. எம்டி ஸ்லைடு தான்.
A very good morning to you all. We are delighted to welcome the honorable dignitaries, electrophysiologists, cardiologists, EP fellows and residents and members of this industry on the second day of the second National Physiological PACIng Symposium. It's my pleasure to invite Dr. Ulas M. Pandrangi, Head of Department Cardiac Electrophysiology and Pacing, Arrhythmia Heart Failure Academy, the Madras Medical Mission, onto the stage for the welcome address and inaugurate the session. Welcome, sir.
Good morning, ladies and gentlemen. It is just a great honor and a privilege to have all of you. Thank you so much for taking your time out and to attend this symposium. I remain grateful to you. I can promise that in the coming 2 days, we are going to learn lots about conduction system pacing because we are having amidst us the stalwarts, the masters of conduction system pacing. Last evening, we had some great talks by the international faculty and our own grandmaster, Dr. Shanmugasundaram. It is my pleasure to reintroduce the international faculty, Dr. Harun Buri from the University Hospital, Geneva, Switzerland. Madrasi by birth. He takes pride in saying that very often. It is such an honor, Dr. Buri, that you are here. Last evening, I'm sure many of us here heard your great talk, and then we are stimulated a lot, and I'm sure your technique of implantation would be at display very soon. Ladies and gentlemen, we have had this privilege of actually seeing him yesterday even though he arrived late in the night, early morning, he came, and then as a test run, he was there in the lab. Thank you, Dr. Harun Buri. It was wonderful to have you. We are going to be missing another international, most accomplished figure in conduction system pacing, Dr. Zakari. He is from the Imperial College London, UK. The passing of the Queen affected his visa issue. The British Embassy was busy with receiving the dignitaries, and we are devoid of our own dignitary. He couldn't get the visa slot. However, before Harun Buri is in action in the lab, Aparna is going to be putting up Zakari's talk, which is video recorded. It's very kind of him. Both of his presentations, he actually got it recorded for all of us. I had gone through that. I'm telling you that we may miss him physically, but the presentation, what he had sent to us, I think is going to enlighten us. So, ladies and gentlemen, Shanmugasundaram, as usual, you had been always kind. The country is so very proud of you. We are so very much proud. I don't think anybody across the globe is as much published, as much cited as Dr. Shanmugasundaram. I have this privilege of asking him to come in and then just get into the lab, and we all learn from him. So Harun Buri and Shanmugasundaram, the master skills, we are going to be witnessing in the coming 2 days. Some 6 cases we have lined up. So, ladies and gentlemen, I'm again thankful to all of you. You have brought some sense to this symposium. I'm so very delighted to have all of you. Enjoy times. If there is anything that is required, I have got a whole team. Please ask them. And let's start the session. May I request Aparna to escort Dr. Harun Buri to the lab? And something else you would like to do? So we'll start Dr. Zakari's the video. All right, so ladies and gentlemen, welcome again. Ladies and gentlemen, excuse me. I forgot to introduce another important faculty today, Mr. Greg. Mr. Greg is from Micropace and from Australia. He actually, for the first time in the country, is going to be showcasing a system which is like portable EP and an ECG machine, so that we should be able to do the conduction system pacing outside the EP lab. No more such elaborate EP system to make the conduction system pacing possible. So Greg, thank you very much. He also had some visa issues, but he somehow managed to come. We hope to display his equipment during the second or the third case today, and definitely tomorrow morning. So welcome, Mr. Greg. So we should start.
Hello, my name's Zach Winnett. I work at Imperial College London. It's my great pleasure to join you from sunny London, and I'm just sorry I wasn't able to join you in person. I'm going to talk to you today about the evolution of conduction system pacing. These are my potential conflicts of interest. So we know that the cardiac conduction system has evolved over millions of years to be a highly efficient system which controls both the heart rate and cardiac activation. However, the conduction system is vulnerable to conduction system disease. And this conduction system disease may cause bradycardia. And this is, of course, was the thing that initiated the development of pacemaker therapy. But it can also lead to less efficient cardiac activation, which means that patients may have an indication for restoring more physiological activation with the aim of improving heart function. And therefore, pacing therapy has, of course, also evolved to target conduction system disease that impairs ventricular function. The aim of bradycardia pacing is to take a patient who has conduction system disease that causes bradycardia and decreases cardiac output, and to correct that with pacing therapy. Now, this, over the past more than 60 years, has predominantly been with right ventricular pacing, which results in improved cardiac output and improves symptoms. However, right ventricular pacing, whilst it's very effective at treating bradycardia, we know that it doesn't restore normal physiological activation. And this is something that was ignored for many years, and it's quite understandable because when investigators first looked at patients who had profound hemodynamic consequences as a result of bradycardia, they saw that with ventricular pacing, so VVI pacing, they were able to improve acute hemodynamic function immediately with turning on pacing therapy. And therefore, for many years, we've accepted right ventricular pacing. But what's become apparent is that this non-physiological activation that we're used to seeing with right ventricular pacing can have important consequences. So famously in the David's trial, which looked at the impact of ventricular pacing in patients with pre-existing left ventricular impairment, they found that patients who received ventricular pacing had significantly worse outcomes compared to those who had backup pacing only. So this showed for the first time that ventricular pacing can be harmful and increase the risk of death or heart failure hospitalization. And even patients who have pre-existing normal ventricular impairment can be susceptible to developing right ventricular pacing-induced cardiomyopathy. And the more the more ventricular pacing there is, the greater the risk of developing pacing-induced cardiomyopathy. So this has led to the stimulus to try and develop alternative pacing approaches through which with the aim of trying to avoid developing pacing-induced cardiomyopathy. Initially, biventricular pacing was thought to be the solution because biventricular pacing can deliver a slightly more physiological activation pattern compared to right ventricular pacing. And in patients with AV block and an EF less than 50%, the block HF study did find some benefit of delivering biventricular pacing compared to right ventricular pacing. However, we know that biventricular pacing doesn't restore normal ventricular activation. So if you deliver biventricular pacing to patients with narrow QRS, you see that it causes unwanted lengthening of ventricular activation time. And of course, it delivers non-physiological ventricular activation. So this has been the driver for alternatives. And importantly, we see that this non-physiological ventricular activation that we achieve with biventricular pacing can have important consequences, as was shown in the ECHO CRT study, in which biventricular pacing delivered to patients with narrow QRS actually increased the risk of mortality. So we know that physiology and that the heart has developed a sophisticated way of activating the ventricles using the cardiac conduction system. And this has led us to begin to target the conduction system as a pacing location. Now, of course, there are several different places that we can potentially implant a lead on the conduction system. So there's the His bundle, and then we can target more distally with the left bundle branch location. So the first area that was targeted of the conduction system was the His bundle. And the His bundle seemed ideally suited because we can position a lead and capture the conduction system proximally so that we can get normal physiological biventricular activation. And Dr. Deshmukh was the first investigator to show that permanent His bundle pacing was technically feasible. So in a group of patients, so 18 patients who had persistent atrial fibrillation and a dilated cardiomyopathy, he attempted direct His bundle pacing. He used a mapping catheter to help locate the His bundle and used a normal stylet-driven lead without any additional tools to implant the lead on the His bundle. And he showed that it was technically possible. So he was able to implant a His lead acutely in 12 out of the 18 patients. And therefore, this was a success in that it showed it was technically feasible. However, the procedure time was very long, not surprising given that it didn't have dedicated tools. And therefore, there wasn't an immediate uptake in His bundle pacing as a pacing approach. However, with time and the development of dedicated tools, the His bundle pacing approach was taken up by several investigators worldwide. And now the most commonly used lead for His bundle pacing is the Medtronic 3830 lead, which isn't a lead that was developed specifically for His bundle pacing, but has many characteristics, which means it may be potentially useful. So it's a lumenless lead, so it has a relatively small diameter, so 4.1 French diameter, and the helix is forms part of the electrode. And this combined with a sheath that helps deliver the lead to the His bundle area. So initially, the first sheath that was used was a C304 deflectable sheath, which allowed deflection but didn't have a septal curve. And this was then followed by the development of the C315 sheath, which was has both the primary curve to deliver the leads to the level of the His bundle, and the secondary curve to allow the lead to be implanted into the myocardium, so perpendicular to the myocardium. And we see that having dedicated tools does make a difference. So if you look with the advent of the C315 sheath, implant success rates improved, capture thresholds were also improved as well with the advent of having this relatively simple new tool for allowing the lead to be implanted. And it does seem to have made a difference having these dedicated tools. So if we look at the same population of patients that Dr. Teshmuk targeted, having the tools, these relatively simple tools, improved implant success rates to about 95%, as was shown in these two case series. So what about outcomes? So first of all, if we look at the electrocardiographic response, so His bundle pacing allows us to deliver a very different QRS complex to right ventricular pacing. So the QRS is much narrower and it looks very similar to the QRS that we obtained during normal physiological activation. You may have a non-selective capture, which provides a little bit of a delta wave, but the vast majority of the ventricular activation occurs via the conduction system. There were studies which showed that His bundle pacing allowed coronary perfusion to be preserved compared to RV apical pacing. And we performed a direct within-patient comparison of RV pacing versus His bundle pacing, and showed that there was significant hemodynamic benefit to delivering His bundle pacing, and therefore maintaining normal physiological activation. So what about the feasibility and safety of His bundle pacing? Well, we have data from two relatively large registries. There's the registry from combines Italian experience with some of the US operators, so Francesco Zanon and Pugal and Vijay Raman. So this was include 844 patients, and then we had a European experience which we published, and that was from just 530 patients. And so what information do we get from these registries? Well, there is a clear learning curve with His bundle pacing, and we found that fluoroscopy time reduced as the operator gained more experience, and around 40 cases the learning curve seemed to begin to plateau, and implant success rate also seemed to improve with greater operator experience. We have relatively few prospective studies of His bundle pacing. The IMAGE His bundle pacing study was a relatively small study which recruited 69 patients, but it gives us good information about prospective implant success rates. And these were relatively experienced, or in some cases very experienced implanters, and they showed that the His lead was successfully implanted in about 88% of patients, and they had quite strict criteria for His bundle capture. And according to those criteria, 75% of patients had protocol-defined success, implant success. So not 100%, but relatively high implant success rates with the currently available tools. Now, capture thresholds on the His bundle have been found to be higher than what we typically see for right ventricular pacing. But the major sort of Achilles heel, which with His bundle pacing using current tools, has been the need for lead reintervention due to rises in capture threshold. So using the 3830 lead, the macro displacement rate is very low, but reintervention rates from the long-term observational studies range between 6 to 10%. And now, again, this is data from a further registry, again showing around 7% lead-related complication rates. So this is higher than what we see with right ventricular pacing. But actually, whilst we always think that lead revision rates are relatively low with RV pacing, if we look at big registries, we can see that actually it's not insignificant, even with RV pacing. And there are, of course, other complications which we're potentially more likely to get with RV apical pacing in particular compared to the His bundle pacing location. Now, the R-wave sensing is typically lower, also in the His bundle region, which is a further potential drawback. The R-wave amplitude is typically less than 5 millivolts, which can lead to some issues with programming. You need to have special consideration for programming the device when pacing from this location. Now, one of the things that many of us have changed in our practice for His bundle pacing is to target the more distal His bundle. Initially, we thought it was a good idea to target more proximally if possible, because it seemed very attractive not to cross the tricuspid valve. We've generally found that targeting more distal has some advantages. Typically, the R-wave tends to be a bit bigger in that location, and we're more likely to get non-selective capture, which has the advantage of allowing a sort of backup pacing because we have local myocardial capture in case of loss of His bundle capture. So what data do we have of clinical outcomes of His bundle pacing? There are not many or any large randomized controlled trials, but in terms of the bradycardia indication, we do have this nice registry from the Geisinger group in the US. So this was a non-randomized observational cohort study, and it compared to two linked hospitals, and all the patients in one hospital with a bradycardia indication had His bundle pacing attempted, whilst in the other hospital they all had RV pacing attempted. And they had a nice high His bundle pacing implant success rate in the His bundle pacing group. And what they found was that the primary outcome of death, heart failure, hospitalization, or a need for upgrade to biventricular pacing was significantly lower in the His bundle pacing group compared to the right ventricular pacing group. And this effect, as you'd expect, became even more pronounced in the patients who had a higher ventricular pacing requirement. So this was a very encouraging result for His bundle pacing. It suggests that we can potentially prevent adverse outcomes with conduction system pacing. But there are, of course, some limitations, as I've mentioned, with His bundle pacing, mainly focused around the difficulty at implant, the learning curve, and the rise in thresholds in some patients. This then led to the trying to target the conduction system more distally with left bundle branch or left bundle area pacing. So Weizhen Huang from Wenzhou in China was the first to report a transeptal approach to target the left bundle branch. And his description is was to target the proximal left bundle, close, it's about 1 to 2 centimeters after the branch where it branches off from the His bundle. And the lead passes very deep through the interventricular septum with the aim of capturing the left bundle branch. So if we look at the electrical response to left bundle branch pacing, it's possible to achieve very narrow QRS complexes with rapid left ventricular activation. But typically we do see this R prime in lead V1, and this represents the delayed right ventricular activation, which occurs when we're stimulating and there seems to be significant missed potential with respect to ventricular resynchronization when we deliver it to patients with left bundle branch block. So conduction system pacing has been investigated as a method for delivering more effective ventricular resynchronization. And it's possible in patients with left bundle branch block to deliver His bundle pacing and to essentially correct the left bundle branch block. And this is because in many patients with left bundle branch block, the conduction system disease actually occurs in the His bundle. So if we deliver pacing beyond the site of block or pace sufficient energy to overcome the block, we can correct the activation, restore normal physiological activation. In this very nice series from the Chicago group, we see that in their patient population, the investigators they found that in just under 50% of patients, the conduction system disease was within the His bundle or proximal left bundle. So how does His resynchronization compare to biventricular delivered resynchronization? Well, we looked at this in an acute hemodynamic study where we delivered both His bundle pacing and biventricular pacing to patients, so within the same patients. And we found that we're able to deliver a significantly greater reduction in QRS duration with His CRT compared to biventricular CRT. And when we looked at the activation pattern using the Cardio Insights system, we delivered a significantly greater reduction in left ventricular activation time compared to biventricular pacing. And interestingly, this translated into a significantly greater improvement in acute hemodynamics. So the improved ventricular resynchronizations at least translated into greater acute improvements in hemodynamic function. What about longer term outcomes? So we have some randomized controlled trials comparing His CRT versus biventricular CRT, although relatively small numbers of patients. The first was performed by Professor Lustgarten, which was a small crossover series, again, basically showing feasibility of His CRT. Then there was the His Sync pilot trial, which recruited 41 patients. Now it was a little bit limited by crossover, both between both arms. So some patients with His CRT attempted His CRT crossed over to biventricular pacing, and actually some of the biventricular pacing patients also crossed over to the His group. And then we had another randomized trial comparing His CRT versus biventricular pacing from Denmark, which recruited 50 patients. And then most recently, we've had this trial from Spain, which recruited 80 patients. And essentially, what we found from these studies, the outcomes from these studies were that from an intention to treat basis, His CRT delivered significantly greater reductions in QRS duration. And in terms of outcomes, there was no significant difference in outcomes, so longer term outcomes, but there was a trend for a greater improvement in ejection fraction measured using echo in the His CRT group compared to the biventricular pacing group. So these randomized studies, whilst none of them are large enough or powered to detect superiority, they do suggest that His CRT is a viable alternative to biventricular pacing, and there is the potential that it may deliver improved outcomes because it's able to deliver shorter QRS durations. And there's What about left bundle branch pacing for CRT? So we know that we can deliver more effective. We can also shorten QRS duration with left bundle area pacing. And we have this nice, again, a non-randomized, this is an observational study, which recruited principally, well, essentially all patients with non-ischemic cardiomyopathy and a broad QRS. And what we found was that it's possible to deliver ventricular resynchronization in the vast majority of these patients using left bundle area pacing. So a very high implant success rate in this group of patients. And it led to improvements in echo parameters compared to baseline, suggesting that left bundle area pacing may be an effective way for delivering cardiac resynchronization. There's a further observational study which included patients with ischemic heart disease as well, so it was a slightly broader population, and found that implant success rates were a little bit lower, given that there was a slightly broader population. The main reason for inability to deliver left bundle area pacing was inability to penetrate the septum, particularly in patients with more dilated ventricles. And then there was the inability to deliver ventricular resynchronization, and this was principally in patients with intraventricular conduction delay. We also just recently published this paper, which compared His bundle pacing versus biventricular pacing in patients following AV node ablation. So patients with reduced ejection fraction, permanent atrial fibrillation, and it was a crossover study. So all patients had both a His bundle pacing lead and biventricular pacing lead, and they were crossed over to 2 9-month treatment periods. And the primary outcome measure was change in left ventricular ejection fraction. And what we found was that both during the biventricular pacing period and the His bundle pacing period, there was a significant improvement in ejection fraction, but there was a modest but significant additional improvement in ejection fraction during the His bundle pacing period, suggesting that His bundle pacing may be an effective way for delivering pacing in this group of patients. And most recently, which just been published in JACC, was this study which recruited 40 patients with non-ischemic cardiomyopathy, and they were randomized to either left bundle branch pacing CRT or biventricular pacing CRT. There were a small number of crossovers between the two pacing approaches, but excitingly, both groups showed an improvement in ejection fraction, but there was a significantly greater improvement with left bundle pacing CRT. So in summary, His bundle pacing and left bundle branch pacing have now become established as ways for delivering conduction system pacing. His bundle pacing has the advantage that it delivers physiological biventricular activation, but it has the drawback that capture thresholds are higher than RV pacing, and there is the problem with reintervention rates of up to 8%. You can deliver optimal ventricular resynchronization in many patients with left bundle branch block, so it's a viable alternative to biventricular pacing for cardiac resynchronization. Left bundle branch pacing delivers physiological left ventricular activation, albeit with slightly delayed right ventricular activation, has low capture thresholds, and importantly, they're stable over time, overcomes the problems with sensing, so has typically high R wave values, and we're still awaiting longer term data regarding lead performance. So both techniques are very exciting. Of course, we are awaiting further large randomized controlled trials, which some of them are already underway. Thank you very much for your attention, and again, I'm sorry that I wasn't able to be with you.
Thank you, Dr. Zachary, for giving you valuable insights on the evolution of conduction system pacing. The lab, as part of our proceedings of this day, we will move on to the live cases. I take this opportunity to present the first case of the day. May I have the slides, please? I think we are live now. The first case of ours is a 63-year-old male with diabetes mellitus, who's a known case of ischemic cardiomyopathy, who had undergone coronary artery bypass graft surgery in 2008 from our institution. He now complains of dyspnea on exertion in YHA class 3 and episodes of giddiness. He was at least admitted 3 times for heart failure in the past 2 years. The ECG showed atypical right bundle branch block, northwest axis with a QRS duration of 170 milliseconds. The echo revealed severe LV dysfunction, moderate MR, and he has a current EF of 23% with a septal thickness of 9 millimeter. His plan is conduction system pacing optimized CRTD. Over to the live, please. Next slide. This is the ECG. Yeah. Yes, sir.
Good morning, Dr. Haranpuri. Can you hear me? Anand, can you people hear me? I think I can see Dr. Anand, Dr. Anindya are around to help Dr. Haranpuri there. We have some fantastic cath lab team there. I wish I start hearing from them. Anand, can you hear me? Benji, Sangeeta are around. Yeah, I think some technical glitch there. I hope we'll be connected to them, audio. I think half the show is already through. I just was wondering, is it going to be used, they are going to be using CS lead or no? We would like to hear from them. So I agree. Would you like to comment on this case?
Yeah, actually, more than a comment, I was hoping to ask a question to people here. Or see, the first thing is the trials and other things. We are looking at physiological pacing as an alternative to CRT. So we are looking at patients of a similar profile: LV dysfunction, non-ischemic cardiomyopathy, left bundle branch block, 170 milliseconds, 150 milliseconds or more. So I want, comments on a patient like this, which is right bundle branch block, not a classical, not even a left bundle branch block. Now, if you want to do a physiological pacing for this, what do you think about the outcomes or the possible outcomes? I want a discussion on it.
Yeah, so I agree, that's a great question. I just was wondering, could they hear at least, if Anand raises his hand, at least we know that this way communication is through. So that's the beginning with the bang. So, Anand, can you hear us?
Yes,
Dr.
we
Puri,
can
can you
hear
hear us?
you, but can you hear us? Hello?
Yeah,
Can you hear us?
Oh, yeah, you know what? We are hearing you better. I think audio people are getting it fine-tuned.
Okay, can you hear us now?
Oh, yes, that's great.
This is good. All right then. We
Okay.
hear you, but a bit faintly. And can you see us as well? Do you see the screen?
Yes, the electrograms are quite beautifully seen. The review screen, I can see.
Okay. So
I can see the fluoro.
okay, you can see the fluoro. So what we've done is there have been 4 venous accesses placed, and we quickly mapped the His with the first of all from an EP catheter from the groin, and then what you see on the tracing on the left is using the 3830 lead. The HV interval is long, around 90 milliseconds, and what I've done is I've taken a still of the His lead position in RAO 20 degrees to give me an anatomical landmark. So I always look for the His, but I don't spend too much time, 2-3 minutes, and then that's it. But it also gives me, when I'm looking for the His, a good idea of where the tricuspid annulus is, looking at the electrograms and looking at the behavior of the guiding catheter. So you can see the landmark, I think, of where the His is, and you see the electrograms. And now what we'll do is we'll go into the ventricle, and there's a sort of a far-field His on the live, but I mean the His catheter's moved a little bit, but it's fine. We've got the landmark. So now what I'm going to do is I'm going to bring back the lead into the guiding catheter. Can we have fluoro, please? Okay, so I'm just going to bring it back because this lead is, gets very easily snagged. So I'm just going to move into the ventricle. This is a little bit high. I'd like to go a little bit lower and towards the apex. So I'm just going to do some rotations. This is good. That's fine. So you see the lead gives me an idea of distance. So from the tip of the lead, from the screw to the base of the ring is about 15 millimeters. And I aim to go about 20 millimeters from where the His is, where the landmark is, and that's more or less where we are now. So you see I now have on the electrogram the unfiltered signal, which shows me a little bit of current of injury. I'm just going to bring out the lead a little bit more. Can you please? Yeah. So now I have contact. You see the lead tip moving. And can we do some pace mapping here, please? So I just want to check the pace map and see what the QRS looks like. Ideally, what we want to see is positive in 2, negative in 3. Yeah, do we have, otherwise a skin clamp? We can usually use a skin clamp. I don't see any pacing spike at all. Yeah, there's a problem with the connection then. It's the connections because we don't even see the pacing spike. So what I ideally want to see is positivity in 2, negativity in 3. Sometimes it's negative in 2 and 3. That's also okay. I mean, it's a combination between the fluoro position and also then the electrical. So here what we have is, doesn't look like, yeah. So we have like isoelectric or slightly positive in 2 and slightly negative in 3. And we have a nice notching in lead V1. The notching, it's nice when you have it. If you don't have it, you can still get a good position. So it's good to see. Can we move now to LAO, please? About LAO 30. And can you tell me what the impedance is now? Is how much? 820. 820, okay. So can we, okay, very good. Can we screen? Okay, so I'm just going to move this over. So that's a relatively good orientation also. What you want is, compared, with respect to the horizontal plane, it should be about 10 to 40 degrees pointing upwards. So now I'm going to disconnect my lead because you need to disconnect to screw this in. And can we have some fluoroscopy? And I will actually screw it in. One does very rapid rotations. You need to get the lead moving into the septum. There, it's moved forward. You need to look out also for fixation beats. Now, I can't look at the screen and the fixation beats, so it's useful if you have someone who's there to look, but I'm going to now check the electrogram. Okay, so we have a nice current of injury. Can we pace? Okay, it was still very far away, it's still very negative, so I need to go forward more. How much is the impedance now? 790, so we've still got a long way to go. Fluoroscopy, please. There. It looks like it's moved a little bit forward. These forward movements can be very subtle, so it's good to check. Again, please, pace. Okay. No, it's exactly the same. So it doesn't look like we're moving forward very much. So what you have to be careful of is known as the drill effect, where you're basically not advancing very much and you're just drilling a tunnel instead of screwing the lead in. Okay, let's pace now, please. Yeah, still not very much. It looked like it was moving forward in the fluoroscopy, but no change in the ECG at all. So that's something I'm a little bit concerned about, is the drill effect. Okay. Okay, and the other thing you have to be careful of is not to get any torque build-up. If you get torque build-up, you have the entanglement effect. Can we pace now? Yeah, it's not changing at all. Can we go to RAO? I think I'm going to relocate the lead. And it's always been the same RAO projection as where you have the hiss initially. Okay, so you can see that the lead is actually coursing anteriorly. Okay, so it may actually be in the septum, but it's going oblique and anterior. And that could explain why we're not getting the positivity in lead V1. Okay, so I'm now going to unscrew the lead. I'm just pulling it out. It's actually well fixated, so I did not have the drill effect. I'm pulling on the lead, just tugging on it. It's well fixated, but it's going really oblique, so I'm unscrewing it. Now, when you reposition, you really need to check that there's no biopsy. So you need to clean the screw. And there's a little bit of biopsy there, but I'm just cleaning off. So the lead is now clean, and they'll go back in. And this time I'm going to be careful to start off really with the lead perpendicular to the septum. The 3D curve with that distal posterior bend is so important. And I think it's actually very difficult to do LBBP without that. Oh, he's screening. Okay, can you screen now again? Okay. So we have the landmark. I'm going to go back down, somewhere around there. Okay. So we've repositioned. Can we pace here, please? Okay, can you maybe pace it to faster rate? Yeah. So again, it's positive in 2, sort of isoelectric in 3, and we have a W pattern in lead V1. Okay, so I think we'll screw in here. If the notch is better now, it was already very notched before. Can we go to LAO? And sometimes I don't have the notch. I don't have that W pattern, and still you get a good response. So when you have it, it's good. If you don't have it, don't despair. Okay. Can we check now in LAO? All right then. Good. So again, we have a slightly more vertical orientation, but that's fine. So I'm screwing in the lead again. trying to move it quickly. There are template beats. I saw it moving forwards as well. It's very useful to have someone give you the template beats. Can we paste? No, it's positive. But you see it's changed. It's become more positive. What's the impedance now? 700. Okay. And the R-wave peak time is still very long in V6. Can we do fluoro? Okay, I'm moving forward cautiously. There's some extra systolic beats there, but very wide. So the template beats, you need to have the morphology that you would like to have with the QR. So let's see what this gives. Yeah. Yeah, there, no, I think that's, yeah. Yeah, it is, it's still W. Okay, so it's still very, very negative. It's changing. The R-wave peak time looks very long in V6. Could you just measure it? I mean, this patient's HV interval was also very long, so I'm not expecting, and he has left anterior hemiblock, 100 is very long. Okay. And the impedance was how much? Let's just connect up again. So you need to keep really track of the impedance, and when you get close to 500, be a little bit careful. 740, okay. Okay, let's keep fluoro again.
Are there any potentials on the lead electrograms?
Haran, can I ask you something?
Sure. I'm just going to readjust my guiding catheter because you want it to be aligned. You don't necessarily have to have the guiding catheter up against the. Sometimes as you push the lead forward, the guiding catheter comes back. So a little bit of torque build-up. That's something you don't really like seeing. Okay, can we paste here? Looks like the current of injury also is going down, so that's also something one needs to be careful about. Okay.
No caption, no caption.
How much is the impedance now? 660. The impedance is coming down. Can you stop pacing?
Haran, here the distance between the spike and the
Okay.
QRS is
So the current of injury in the unipolar has really come down a lot, and that's something that I'm concerned about. It's something that Shanmugan has described, you know, is much bigger on the ring electrode. Oopla, there we go. Now I'm connected to the ring electrode. It's much bigger on the ring than it is on the tip. And this is again back on the tip. And these are one of the signs that it's going to be impeding. And if you look at the electrograms, there's a potential there that's like a fascicular potential. You see within, you see that, you see it as well now on the still. That's inside the ventricular electrogram. No, not on the still here. If you do it now, if you freeze the screen now. Yeah. No, you can bring it down a little bit. I think you see on the very first beat, there's probably a potential within the electrogram. So it just shows there's very delayed conduction there. It could be a potential, or it could just be fragmentation, but it looks very much like a potential. So we're probably very close to the endocardium, and I think in the subendocardial layer, because we have the current of injury which goes down. The impedance is still quite high, but yesterday we saw that there was a difference between the impedance when you use the splitting, and if you do it directly, it's lower, I think, right? If I forget. So it should be actually lower than this. So I think we're pretty close, and we still don't have a nice LBBP morphology, even though I think we're very close to the subendocardium. If I keep screwing, I think...
Haran, the distance between the stimulus and the QRS is interesting. Is it that we are getting selective?
Can we pace again? Pacing is at very high output, so unlikely to be a selective. Can we have an LVAT at high and low output?
Yeah, here the stimulus to the QRS gap is suggestive.
So usually the selective capture transition occurs at a near threshold value. So if you're looking for a selective capture threshold, usually it occurs at an output of less than 1 volt. So if at the time of implantation, immediately after implantation, you can see the transition at 2 or 2.5 volts. But over 5 or 10 minutes, it usually comes down. And usually it occurs at probably less than 1 volt. So if it occurs at higher output, then maybe we have to think of some scar effect having an exit block. So So here, getting a short and constant LVAT will help, because if it is short and constant, I think this is the best result which we are going to have because of chronic long-standing dilated LV and scarred ventricle.
So I think you are right. If you look at the basal ECG, it's like an intramural conduction defect. Okay, see, the HV interval, it wasn't extraordinarily long, if you see. So the Purkinje system seems to be intact. It is the cardiomyopathy conduction defect. So I do not think we'll be achieving a great QRS today. Dr. Haran, there are discussions here, like what was the HV interval and what is the intrinsic Purkinje, health? We can't hear you. There's a issue, some audio issue. Shanmuga, you know what? I think you.
So it is actually. I think still we are capturing the conduction system only. We just have to see the constant LVAT. He has classically shown the progression of that notch going up and forming in QR pattern. Only thing is that it's going to be a mixed conduction system disease with some sort of disease distally. We cannot have the classical beautiful looking 110 milliseconds ECG. We may have to most probably accept this result if you are going to show low on output. Yeah, and see the capture transition if there is any, like any non-selective to selective or non-selective to septal transition. Yeah, so usually the S is seen in more of a 40% of LV septal pacing. It usually won't be seen in LBP pacing. The S in terminal S in V1. But many a times with a scarred ventricle, it is pure for it is for a pure left bundle pacing without any scar. So in this patient post CABG, we can expect some deflections.
Shanmuga, one more thing is the septal thickness was 7 mm.
9 millimeter, I think.
Yeah, right. So how comfortable would the operator be about, or how careful should you be about?
Yeah, so we may not go exactly at a 0 degree plane. So even if you are seeing everything and going perpendicularly, many times the lead will go obliquely. So we have seen in CT, so many times the lead would have got, even in the echocardiography, it would have got deployed in a oblique manner. So we can always add 1 or 2 millimeters. But more than that, what we usually look for is this template beats or fixation beats with the QR morphology while deploying, and unipolar pacing impedance. Like he was rightly pointing out, once you are nearing a value of 500 ohms, you have to be very careful. We never accept a unipolar impedance of less than 450 ohms. So many times your tip might have got perforated. So that is more important rather than the septal thickness. So you can even deploy the lead in 6 millimeter or 7 millimeter septum. All you have to go is go little obliquely. Just pull the sheath back and go little obliquely.
Something you should ask yourself. So it's quite interesting. What we see is here we're pacing at what, 5 volts, right? You're pacing at 5 volts? Upper neck, 5 volts, right? Okay, now back down to 4. Okay, and now go to 3 and see what happens at 3. And now we're pacing at 3 volts, and you see the interval between the pacing spike and the onset of the QRS is huge. Here we're getting selective capture, but with an extremely long interval. Now we're losing capture. Here we've lost capture. So there's a very, very, very long latency there. So we were transitioning to the selective capture, but with a really long interval, and here we've lost capture. So I think this we need to reposition. The threshold is high because I think I have perforated, and there's just partial perforation, just a screw which is just out. So we're going to reposition here, and it just shows us that with this very long HV interval initially, you know, sometimes with LBBP you just don't get a nice ECG, and that's why in the MELOS trial we had a lower success rate with LBBP. It was 82 or something like that. So I'm just going to reposition. We'll go back to RAO. And we'll try once again. But this confirms that I really was in the subendocardial area. I think that was a delayed potential that was within the V that we saw initially. So here it's clean. I cleaned off the tip. That's fine. Always check that there's no biopsy.
Hello, hello.
So when I see these very long HV intervals, that's something which makes me feel a little bit unhappy when I start off my LBB case. Okay, so we'll go off again here. Can we just centralize the image so I can see the apex, please? Move the table the other way, this way, so we have it. Good, all right. So we'll try once more, but it's unlikely that we'll get a nice result in this patient, I think, because of the very severe infranodal conduction disease.
Dr. Buri, can you hear us?
Yes, I hear you well now.
Okay, there had been some questions here.
Yeah?
It is the
Duro?
Is the existing the conduction disease peripherally?
Yeah.
And are you really very optimistic in this substrate, looking at that basal HV interval and looking at the ECG morphology? Like, are you really very optimistic to achieve the fantastic QRS today?
Not really when I have these long HV intervals. But you know, the only thing is you have to go and try. Looking at the ECG, when I have someone with ischemic cardiomyopathy, the first thing I ask myself is, does he have septal scar? Because that can make it difficult. You can stop the fluoro. It can make it difficult to penetrate, but I don't think this patient has septal scar. If you look at the ECG, he's got right bundle branch block, and he's got a small R wave. That initial R wave tells me that the septal activation is happening left to right, and there is viable tissue in the septum. If you have a proximal LAD occlusion and right bundle branch block that results from a very proximal LAD occlusion, then you have a sort of a QR pattern in V1. It's an atypical right bundle branch block here. It's an R prime. So this made me feel good initially to say, and also this patient has got a bifascicular block with left anterior hemiblock. I mean, it's something which you think could possibly be resynchronized. But then when I see the HV interval 90, it told me this is going to be challenging. And as with the non-specific intraventricular conduction delay, sometimes with LBBP, the paced ECG is simply not nice. I think in the previous try, it was probably the best that we could achieve.
Yes.
As we even got selective capture and all that, and we had a potential within the V. But let's try again. I mean, that definitely was, in my mind, not an acceptable result.
So the baseline ECG
it's extremely long. I think there's some sort of decremental. The question here was, how do you get I've never seen such a long stim to QRS, never. I mean, it's like, even with his, but then there may be some decremental conduction because the baseline HV was like 90.
Yes.
So the potential to V should be shorter. It's simply that we're arriving, I think, in a delayed, you remember that the potential was within the V, okay? So you need to add that because I think it's coming around. So I'm pacing from that potential, and for it to exit, we'll need extra time. And this probably explains why we have such a long potential to V. But it's unusual. I mean, I've never seen this long. It looks like, you know, even someone was asking, is this not the atrium? But I mean, we were really far away from the atrium, and there's absolutely no atrial eclacuram. But that's obviously the question you're asking. It looks like a PR interval almost.
Okay. So Dr. Buri, looking at the clinical profile of ischemic cardiomyopathy and a very large heart, and then we know there was a scar in the septum, and now this baseline ECG. I just was wondering, from the point of view of case selection for some pacing, this I thought it should be optimized with the CS lead if you are trying to achieve a good QRS. Is that what you agree with?
Yeah, I think it's a difficult case because I would have definitely tried LBBP as a first, like what we're still going to try, but I think it's worthwhile trying and see what resynchronization effect we can get with that. And ideally, it would have been just to implant an LBBP lead because this patient doesn't have a QRS that looks like it's going to respond very well to CRT.
Yes.
If you look at the R-wave peak time in V6, you see it's pretty short, right? So I don't know to what extent we'll really be able to resynchronize the left ventricle, but there's also left anterior hemiblock, so there may be a little bit more up, like anterolateral, there may be, there may be some regions which are delayed, and then it's with the CS lead that we'll know if they're delayed there or not. But it's the sort of patient you're telling yourself it's going to be challenging to resynchronize. So the strategy is start off with LBBP, and if you don't get a good QRS with that, I think you would need the CS lead in addition. But even then, you don't know what the clinical outcome is going to be. Hopefully good, but uncertain. So let's try again a third attempt at the LBB. The first one, you saw the lead was going a bit off course anterior, and I don't want that to happen again, so I'm going to really orient my guiding catheter in a manner that it goes perpendicular to the septum. The second case we achieved, but the QRS was really not nice. Can we go now LAO again? How many times? It depends how much I really want and how I think that this patient is going to benefit. So if I think he's going to benefit, I can go 10 times. If I think, yeah, with the same lead, as long as I'm not damaging it, where I'm, over talking it and all that, yeah.
See, the question here is.
So here again, we're having good orientation. Let's just do some pace mapping here. Can you just pace map? It'll probably look very similar to the previous one. We're not getting any signal. Is that the anode? Yeah, wires. You need to really put the wires away, otherwise we'll get a lot of. That's another little thing. If you have.
We'll disconnect that for a while. Yeah. So the
remaining frontier.
Yes. Yeah. So, sir, I think we should.
I think the right bundle branch block patients are the remaining frontier. You have a solution, perfect solution for a nano QRS. You have a good, very good solution for a left bundle branch block with CRT indication. But RBB actually, mechanistically you see, how do we resynchronize for the RV, RV which is delayed to come up? And
resynchronization therapy in a
frontier,
right bundle branch block.
English professor.
Sir.
We are simplifying it too much. We are going by the pattern, not by the block. The electrical in RBB, you will not have a very wide RSR dash pattern. Initial R is wide. The first R is wide, going slow. Where is this RBB? So from the very beginning, it is indicative of not a classic bundle branch block. It is all distal block, all fibrosed.
Yeah. Yeah. So it is the biggest challenge in achieving resynchronization in patients with an RBBP. So always it is going to be a challenge. In fact, the ideal strategy, if you ask me an ideal strategy for a resynchronization therapy in RBBP, it should be a Hismond pacing, because where you'll be able to correct it perfectly. So I think the trials have shown that. I think Dr. Parikshit had an article on resynchronization therapy with the Hismond pacing in RBBP. With left bundle branch, still you can achieve a good QRS. In fact, in our collaborative study, which we published in Heart Rhythm O2, so the QRS duration was reduced from 158 milliseconds to 150 milliseconds. So that minimal reduction, though it was a very minimal reduction, we could show that the EF improvement was there. It was not a head-to-head comparison. It's just a patients who are undergoing left bundle branch pacing for RBBP. So what you can do is either you can get the help from the anode to mask that RBB pattern, or you can put a lead in the RB septum. So it can be an ICD lead, putting it in the mid septum or outflow tract septum to narrow it. I don't know how the CS lead is going to give additional benefit, because you have already generated RBB pacing the left bundle. So getting the help from the anode, if it is not much scar, if there is a scar, I think anodal capture is going to preserve the QRS morphology. If you don't have a scar, the anodal capture will still help. Otherwise, you can put the lead in the septum, mid septum or outflow tract septum, and get it fused with the QRS from the left bundle branch pacing lead and make it a palatable QRS. Another thing regarding this patient, I think there was a selective transition from non-selective to selective capture, but it occurred at a higher output. The only worry was such a long stim to QRS onset that even I have never seen such a long stim to QRS onset. Had it been a short, probably I would have accepted this, because This non-selective to selective capture transition occurs only if the lead is sitting on the top of the left bundle. We have not seen this transition if the lead has perforated it. So even if it is a micro perforation or macro perforation, usually this selective transition will not occur. In fact, I have demonstrated after getting a transition, if I'm going to give additional turns, it will perforate and the transition will not be seen. So at the time of implantation, due to current of injury and local injury, the transition may be seen at, that's what I was discussing few minutes back. The transition may be seen at 2.5 volt or 3 volt, and the threshold may be like a 2.5 volt. But if you wait for some more time, that transition will gradually come down along with the threshold. So at the end of the procedure or at the end of 5 or 10 minutes, the threshold will be like a half a volt or 0.75 volt. The transition will be seen at a less than 1 volt. But this is such a long stem to QRS. I think we may have to look for some other good area. But that would be the that might be the maximum QRS which we can generate from this case. We can get the help of a lead from either CS or RV septum to just fuse it and to get a good QRS.
In our clinical practice, I just wanted to know the thoughts of people here. So this patient has got a very long HV interval. So pacing his, and he is also not classic right bundle branch block. There is some intraventricular conduction problems with fibrosis, ischemic cardiomyopathy. So if you are, is putting a CS lead and then high septal pacing, like a multi-site pacing where you're trying to achieve a better where we started, would that be an option?
Fluoroscopically looks like it is still at the proximal His. Probably if you even just get the His catheter by few millimeters in, you can get a short HV. That we have seen many number of LB, even in LBV patient. I had a case where the HV was 85 milliseconds, and when it just landed up in the distal His, the HV was 45 milliseconds. So probably in a few millimeters difference, you can get a good HV. So again, like Dr. Upadhyay, what he has shown, many a times the block will be intra-His, whether it is an RBV or LBVB, though he has seen an LBV patient. But still probably we can map the His, but again, there are a lot of challenges with the His bundle pacing, lead dislodgement, that thing.
No, what I'm trying to ask is, would you go purely by that you have captured the left bundle, or would you go by the QRS duration? So if you are trying to achieve a better QRS duration, would you try to sort of improvise, see various combinations? So, I mean, at the end of the day, you want this patient to benefit rather than just pace the His or left bundle. So would you try to put a CS lead and see the combinations that you're pacing parahisian or somewhere in the left bundle region? See, if you're not able to exactly capture the left bundle.
Exactly. So even in this case, if you're demonstrating all the captures of left bundle, I think the QRS will not be that great. The LVAT will be, most probably will be more than 90 milliseconds. In that case, that is our cutoff. If it is more than 90, 100 milliseconds, we'll always go for a CS lead additionally. Let us see how good we are going to get.
Sure.
I'm not getting one point here. I mean, we're talking of resynchronization in this patient again and again. You're assuming there's something to synchronize within the LV. So, I mean, what is the evidence for that? I mean, if you put in a CS lead and you show Q LVAT, Q stimulus to be high, then you know that there is some masked situation on the. But here, I mean, what is the evidence that there is something to resynchronize? Yes, no, I'm not, so yeah, there is obviously some kind of a distal block somewhere because of fibrosis, but whether you can resynchronize the electrical therapy to achieve a mechanical benefit of increased EF is something I'm not very sure.
That's an assumption based on which the whole therapy. Can we go back to, we'll carry out the discussion. Let's hear from what actually is going to tell it. Dr. Buri, we are with you.
Okay, very good. Yeah. So we're capturing. So in fact, what I did was I repositioned the lead in a new position, a more basal position. Can you do fluoroscopy? You see I'm in a lot more basal position compared to before, because I was telling myself I've tried twice in more or less the same spot, and the electrical result was not better. So let me try and go a little bit more upstream, more basal. You can see now the EGM of this basal position. When I was screwing it in, there was no potential, and you can see here there's a small fascicular potential there. And there's also like a far field A. So I'm probably getting a left-sided His because where it's not the right-sided one because the spot where I was screwing in, there was no fascicular potential or His potential, anything like that. I did screw it in, it went in quite deeply. Here you have the electrogram which is showing a current of injury in the distal electrode. Now I'm going to connect it to the ring electrode. So I connect to the ring, you see there's a current of injury there. Can we pace now, please? This is pacing from the ring electrode. And this was the electrogram we had when we screwed it in, okay? So you see this notching again, W, and so this tells me that I'm deep in. I knew I was deep in because I could see the lead progressing when I was pacing. Now I'm going to pace from the tip electrode, okay? And the QRS is a bit more narrow. It's not a fantastic QRS, but it's narrower than what we had before. And what we did was we also did a threshold test, and there was no transition in the QRS morphology. So even though we see a sort of a left-sided hiss, I don't have proof that I'm capturing it because I don't see any transition in QRS morphology. The R-wave peak time in V6 is still long. It's something like 110. Maybe you could measure the QRS duration here. The total from the stim to the end, you can see in lead 1. Yeah, so it's how much? 180. So, you know, it's a wide QRS. It's not such a great QRS. Because I don't have conduction system capture, what I'm going to do is I'm going to screw the lead in a little bit. How much is the impedance here? 620. Okay, so I have to be careful because I know that I'm very close to exiting. So we'll just go LAO again, and I'm just going to advance it a little bit more, but just like one turn. Can we go to LAO again, please, for the fluoroscopy? I mean, it's not a very nice QRS, so I think we need to... The intrinsic QRS, can you just mention now the intrinsic QRS while I'm positioning? Okay, fluoroscopy here. Okay. So you see where my sheath is, so I'm in quite deep. I'm just going to go just a little bit. And I feel a little bit of torque build up. This is a more fibrous region. Okay. You think it's better? For me, it's the same. It's still there. It hasn't changed much. Can we pace at 5 volts? And I think we're just very distal because this is a sort of there's probably some intra-Hissian conduction delay as well, because in the proximal hiss from the right side, it looks short. Oh no, that was there was fusion there. From the intrinsic one, you see the HV was 90, and here the potential to V is much shorter. So I think, and further down where we were before, the potential is within the V. It just shows you how delayed it is. Okay, I don't think we'll get any. This looks like very similar to what we had before. What's the impedance here? 640. And can you, this is at 5 volts, right? Can you go to 2? Okay, I think at 1 we had a loss of capture. Try 1. Okay, go back to 2 and then go down. Yeah. Yeah. Okay, so the threshold is 1.1, and there was no transition at QRS. So again, I don't have proof that I'm having conduction system capture, which it sort of defeats the purpose. So I'm going to still go, I think, a little bit, do a bit more. But even then, because of the conduction disease, I don't know to what extent we will help out. Okay, it doesn't look like it's changing much at all. Okay, there's still that same potential there. Can you pace at 5? Oopla. And how much is the impedance? 720. It's not changing much. And I can feel some torque build up here quite a lot. So I think we're more or less to the end of what we can achieve here. I'm not going to do any more because I think it's a lot of this torque build up. So now the question is, we also need to look at the sensing here, because if we're going to do lot CRT with implanting this lead in the RV port, the PACENS. We need to have a really good sensing bipolar, because this is an ICD, right? We can't compromise on the sensing. So I've connected it up, 4.5. And it's a pretty clean signal. I mean, that far field hiss is not going to interfere with sensing. It's just too small. We have 4.5 sensing, which is acceptable. So I think now the thing is, what do we do? Do we implant an LV lead or not? Because this QRS is not that... we can try with the LV lead in and then see how the QRS compares. We need to put an RV ICD lead as well, and then look at the BI-V paced QRS with the ICD lead and with the LVBP lead, or I would say the left hiss lead, and see which gives the better option, and then we can see.
Dr. Buri, I was wondering, how about the fusion beat with the intrinsic? Would you like to do some fusion testing here, the atrial?
Yeah. Now, the thing is that all the fusion algorithms of Medtronic, right, the adaptive CRT, are really geared to left bundle branch block. Here, I can anticipate that from the, what's interesting here, normally with right bundle branch block, your RV, if your lead is in the right ventricle, you will get the local sensing very late in the QRS, okay, because it's so late. And you see here, it's early. It's simply because I think we're on the left side and we're still relatively early there. So this is not too bad. It could work out because of this RV lead position and adaptive CRT that it may give something meaningful, but that's something we need to really, test out in the end. No, I would put the LV lead in, that's for the fusion, yeah, with that, and then you will have to do it. But I think the next step would be to put in the LV lead. Yeah. Do you want to do it, or you go? No, go ahead. Whatever. Yeah, absolutely. So we'll let you continue the talks there. We're going to put in a CS lead here. Are there any questions from the audience? What I just want to do here is I'm going to test the stability, but this is going to be stable. Okay, so now I'm moving this. You see the hinge point. The hinge point is really, this is a left hiss, huh? This is a left hiss. So you see the hinge point is there, and okay. Can you go to, just do a threshold now, to like 1.5 and then go down? Because it's intrahissing conduction delay. For such a short distance, you have such a long delay. And then it still gets delayed further down, because where we were, it may be a retrograde potential or something which is so delayed that it's within the V. There was a potential there, you saw it as well. And that's what that explains also why we're capturing selectively the potential, and by the time it goes around and gets out, it's super long. Very interesting. Yes, and then exits. It goes through the conduction tissue, and by the time it exits into the myocardium, it's such a long delay. I've never seen this like this. This is incredible. But then we were getting the selective capture, and that's it. And yeah, okay, well, this doesn't look actually too bad, but okay. So how do you want it, because they're going to go live, you want to do it, or you want me to stay and do the LV, or whatever? I'll stay with you if you want, then we'll try that one. Oh no, I go just with the CS extended hook. I would just go, no. Here you re-sterilize them, right, so the patient doesn't pay for the decapolar, yeah. But he pays for the guide wire we have anyway, so. Extended hook, if you have extended hook. And there was a nice posterior vein there, posterolateral vein.
Dr. B, can you hear me?
Yeah, so this and this. The count of injuries coming down. That's normal.
Hello? Hello?
Yes? Yeah, we hear you.
Dr. Bree, there's some discussion going on here.
Yeah?
We do not really are very optimistic, even if you put in that CS lead.
Yeah.
Are going to get some cosmetically great looking QRS with an underlying RBBP. I just was wondering, anyway, we are considering a defibrillator for him.
Yeah.
And so how about fusing the left bundle with your RB apical? Do you think that makes any sense?
I mean, it could. I think there's no certainty in this case. Whatever we do, I mean, it could work out.
I agree there's no certainty.
And then afterwards, there are also other considerations. So it's really your call. So I'm also okay with that.
See, I just was wondering, how about placing, the atrial lead as well as the RV coil, and then try to fuse and check how things are?
That's something we could do, but then afterwards the constant fusion will be, we could do that. But then, and then you're talking about the adaptive CRT algorithm to see how that works out, because then there would be a CRTD device. But then I would guess it would be like we're talking about a dual chamber device, right? And then we just program the fixed AV delay. We could do that. That's also an alternative. Okay, let's do it that way then. Well, took that out, but yeah. No.
No, we use the CRTD device. I agree.
Then we're using an IS1 on the LV then. Is that right?
Yeah, so let's do the RV apical pacing fuse, and then we take a call.
That's also an idea. I myself, I'm not at all sure that the CS lead is absolutely necessary, to be honest. Yeah. Okay. Let's do it that way then. Yeah. Okay. Yeah.
We have right bundle branch block, very wide QRS, and a prolonged PR interval. Now, we know that patients are otherwise are not good candidates for CRT, but MADID CRT data show that patients who had a prolonged PR
But the PR is not very long here.
had some benefit.
Can you measure the PR interval?
CRT may be useful. But if you look at the QRS axis, it's a northwest axis, which in itself is a poor prognosis.
Measure the PR interval. It doesn't look like it's long.
We do a device or we do not. Now, once we have planned for conduction system pacing and we
No,
find
it's
that
not.
despite
No, it's not.
left bundle conduction system capture, your RV peak time in V6 is quite delayed. That means that you have a myocardial disease in the LV, and it's not conduction system disease, it's a myocardial disease, so your conduction system is not likely to benefit much in this case. And CS lead in that scenario may be actually better. Plus, the QRS is very broad even with left bundle capture. Despite right bundle branch block, which may be there retrogradely as well, your R-wave peak time lead V1 is relatively stable and short, meaning that your RV conduction is still preserved despite a right bundle branch block with left bundle capture. So I would say that CS lead may still be beneficial, and with correction of AV synchrony by shortening the AV delay, you may still get some benefit. But again, as everybody agrees, it's a challenging case, and we don't know what the clinical outcome would be. But one thing is sure that you will need an RV capture either by an ICD lead or anode of the left bundle lead to have a cosmetically looking good QRS. And in most likelihood, you are not going to get a cosmetically good QRS in this case, whatever configurations that you may use. That's my take on this, but we don't know what we are going to get in the end.
Since you said this, how many of these RBB with possible time conduction or distal conduction disease have actually improved long term on YV?
My numbers are small, but sometimes we do get unexpected good clinical outcome. But whether it is because of the CRT or is it because of just improvement in AV delay or
high doses of beta blockers once we have a device in place. So that may be the reason why some patients do improve. But looking at the evidence, MATTED CRT shows that only patients with prolonged PRN, which in this case I think there is. Yeah, prolonged period. Sorry? Okay. Oh.
Dr. Buri, the consensus here anyway is to look at the result what you achieve with the CRT device using the LV, the left bundle lead and the RV coil. You may actually shorten the AV delay.
Yeah.
And then,
We can even test with simultaneous.
The device we test.
Yeah.
The device we test and then we'll see whether we should use the same.
Yeah.
That's the consensus.
Okay.
And we think we will carry on with some discussions here. By the time you start, you are going to be.
Yes, we're going to be placing the RV lead now.
I mean, once you people are ready with the device connected, we'll get back to you.
Yes, perfect. And the RV, yeah. So you can go to the apex now. No, we won't connect the device. We'll test here. Yeah. Actually, I'm stupid because it's true that we have to use a CRT device because you can't pace from the RV and the LBBP. You need to have two different channels anyway. So that was the thing. Yeah.
So we'll be moving on to the presentation sessions of today. Before moving on to that, I would like to invite the esteemed members of the chair, Dr. Daljit Kaur, Dr. Divedi, Dr. Mohan Naya, and Dr. Shanmugasundaram onto the stage, sir, please.
Yes.
It is a privilege to invite onto the stage Dr. Raja Selvaraj, Professor, Cardiac Electrophysiology and Pacing from JIPMER Pondicherry to share his thoughts on conduction system anatomy relevant to physiological pacing and identifying the level and extent of the block. We welcome you onto the stage, sir.
So, good morning, everyone, and we've had a great start to the day with a very interesting and case with a lot of animated discussion. So, I have been asked to talk on the anatomy, specifically pertaining to conduction system pacing, and also some points on level and extent of block. It is a little bit of a difficult topic because we're usually discussing more on the techniques of conduction system pacing, and this is not what we discuss a lot, and it's not something that I know a lot about. But I think I'll try to keep it interesting and focus on the relevant issues that we need to know. Definitely, the physiology and anatomy form the underlying basis as we are entering a new technique like this. So I'll first part of the talk I'll discuss on anatomy and specifically relevant to conduction system pacing, and on the second part I'll bring up some points related to the extent of block and the level of block that you see in patients with left bundle branch block. So anatomy is interesting with understanding the historical background. And it was in the late 19th century that there was an interesting debate going on between Kent and Hiss. So it was known by this time that the atria and the ventricle, as electrical chambers, are insulated for the most part from each other. But there has to be some way for the impulse to transmit from the atrium to the ventricle. And there was a debate on how this happens. Kent thought that there were multiple levels of connections between the atria and the ventricles, that there were connections at multiple places. So even though we typically call the accessory pathways today as Kent pathways, it was not the abnormal pathways that he described. He actually described what he thought was the normal way of conduction between the atrium and the ventricles in every person. Whereas Hiss instead said that there was a single strand of specialized myocardium which conducts the impulse from the atrium to the ventricle. So these were sort of two schools of thought. And the real towering figure when it comes to anatomy related to the conduction system was Sunao Tawara, who was born in Japan and later went on to work in Germany with Aschoff. And the work he did and the way he described all this is phenomenal. It has been acknowledged by Einthoven as the as inspiring him to go on with electrocardiography. And if you see Dr. Anderson again mentions that the main stumbling block was that the original monograph was in German, and then once it was translated to English, you can see how accurate most of his descriptions were in this. So Aschoff was actually interested in anatomy and abnormal findings as related in patients with heart failure. That's how Aschoff nodules and all that came up. And so Tawara was dissecting hearts in patients with heart failure, but he got interested in the how the conduction system worked. He was able to confirm the findings of Hiss, that there was a specialized strand of myocardium which conducts the impulse from the atrium to the ventricles. But he also followed this backwards and forwards. So went back from the Hiss to find that there is a specialized atrioventricular node, which actually later transforms into the bundle of Hiss, and also went forwards from the Hiss bundle towards the bundle branches and connecting up with the Purkinje fibers. So a lot of the way we see the conduction system today is based on the original description by Tawara. So the way we understand it today, we have the compact AV node, which is, as you know, within the triangle of Koch. And from the compact AV node, there is a transition into the bundle of Hiss. And typically, this is said to begin where it penetrates the central fibrous body. So the central fibrous body is the central part of the fibrous skeleton of the heart. And this, the cells from the AV node, as they penetrate this forms the penetrating portion of the Hiss bundle. And then it enters the membranous septum. And as it exits towards the ventricle, there is a non-branching portion of variable length. And then it reaches the crest of the ventricular myocardium, and there it splits into the bundle branches. Now, we all know the triangle of Koch, which forms a very important landmark in relation to the conduction system. And traditionally, we talk of the AV node as being located in the apex of the triangle of Koch. But there has been studies which show that there is significant variability in the location of the AV node within the triangle of Koch. So while it might be superiorly placed very close to the apex in many hearts, it may also be variably displaced inferiorly in the triangle. That is something which is also relevant to us as electrophysiologists. We know that we can get AV block sometimes while ablating in the postroceptal region. And here what this happens, like this is one heart and this is another heart. And in this first heart, it's more superiorly placed, and in the other heart, it's more inferiorly placed. The more inferiorly placed it is, you have more, a thicker atrial muscle overlying the bundle of His, which makes it a little more difficult to penetrate and reach the bundle. And whereas if it is more superiorly placed, the amount of muscle overlying is less. And depending on the placement, the length of the penetrating bundle is also varies. And also this study by Dr. Anderson's group, they showed that the penetrating bundle location in relation to the tricuspid valve leaflet is very variable. In the top row, you can see this is the insertion of the septal leaflet of the tricuspid valve. Here you see this CFB is the central fibrous body. You can see the part where the AV node starts penetrating into this and then is completely encased within the central fibrous body. That is the penetrating part of His bundle. And here you can see it's well atrial in relation to the tricuspid valve. So this might be very much on the atrial side in relation to the tricuspid valve, whereas in this case it is almost at the level of the tricuspid valve. And in this case, you can, in the last one, you can see that the penetrating bundle is caudal to the connection to the tricuspid valve, or more apical. So, which you saw the slide before also of how His bundle placement can sometimes be more on the atrial side, can sometimes be more on the ventricular side. So you might have to cross the tricuspid valve, and this might be related to the anatomy of the heart in question itself. And when you're more ventricular, there are some advantages, especially in relation to sensing of the ventricular signal. Another thing which was appreciated very early from the anatomy studies, and actually Tawara, even though his primary studies were anatomical and histological, based on the anatomy, he was able to infer the kind of conduction velocities which were seen, because it was previously thought that the His bundle conduction was very slow, and that accounted for the delay between the atrial and ventricular depolarizations. But Tawara saw that when you're within the AV node, the left side is the AV node. Within the AV node, you have these any collagenous fibrils are there in, like you can see, they're like whorls and they're not organized. But as they transition into the His bundle, these are seen in a parallel orientation. So even though the His bundle is one single bundle, it's really, there are strands of collagen going longitudinally throughout, so that it's like separate insulated cables. So it's like a pacing lead. You think of one lead, but it actually has inside the two separate cables which are insulated from each other. So this also means that fibers which are predestined to form the left and right bundles are separated out in the His from the very beginning. And this provides the anatomical basis for longitudinal dissociation and our understanding that what is seen as bundle branch block might be due to disease within the His itself. Once it penetrates the central fibrous body, crosses the membranous septum and reaches the apex of the interventricular septum, as you see here on the left side, and then as it comes down, it divides into the right and left bundle branches. The right bundle is relatively simpler structure, going along as a single cord as it goes down to the moderator band. But the left bundle is more complex, and we all have seen Tawara's original images. And you can see that even though we oversimplify and talk of fascicles as 3 fascicles or 2 primary fascicles, it really is a totally interconnected branching network of fascicles that you see on the left side of the septum. And there have been attempts to classify this into type 1, 2, and 3, but depending on whether the septal fascicle arises from one of the anterior or posterior fascicles, or whether it arises from both. But the basic idea is that you have an extensive network of Purkinje fibers overlying the whole of the left ventricular septum, which is why left bundle pacing, you don't really need to target a particular area, but just reach the right depth, and mostly you will reach some part of the left bundle. So when it comes to bundle branch block, even though we talk of things as bundle branch block, we have to understand that the two bundles and what is seen as block is really a reflection of the relative conduction times within the two bundles. So even in the last case where you have a right bundle branch block does not necessarily mean that the left-sided conduction is normal. It only means that the right bundle is conducting slower than the left bundle, and you could still have additional left bundle delay. And similarly, in patients with left bundle branch block, doesn't always mean that the left bundle is blocked. It means that the left bundle is conducting slower than the right bundle in that particular patient. So how often is it blocked really, and what are the levels of block? Now, when I say delay and partial block, we first think of incomplete LBBB, which is usually defined as a QRS duration more than 100 but less than 120, and showing a morphology like a left bundle branch block. But this is understood now is not usually a conduction system disorder, doesn't really represent delay in the left bundle, is usually more likely due to delay at the level of the myocardium and distal conduction disease, typically seen in left ventricular hypertrophy. So it's usually not a conduction system problem. But what we call as typical as complete left bundle branch block, because the QRS duration is more than 120, proportion of them might not really be complete. So there was a theory that a complete left bundle branch block should really have a left axis based on where the right bundle normally inserts and how activation of the whole heart would take place from there. And that whenever you see a left bundle branch block with a normal axis, as we see most of the time, that it is actually a delay and it's not a complete left bundle branch block. And one way to find out if you can delay the left bundle further is by putting premature atrial stimuli. And if the FRP of the AV node is short enough to allow you to produce further delay, you might see this kind of situation where when you put PACs, you can see a change in the axis, lead 3 becoming more negative, so a more leftward axis. And so in this study, they suggested that a significant number of patients with left bundle branch block might really have an incomplete block and progress further with this. So just as a concept, it's useful to understand for some this. When it comes to level of block, the classic study is from Dr. Tung's group, where they put a multipolar catheter along the left side of the septum in patients with left bundle branch block. Now, they had a few controls, patients with narrow QRS or right bundle branch block. Now, this on the left, you see the patient with a narrow QRS, and proceeding from the His signal, where you also have an additional His, as you go, you see a orderly progression through left bundle on towards the Purkinje fibers and conduction to the muscle. Whereas in some patients, even though there is left bundle branch block, you see there is no block itself in the left bundle, and these patients are labeled as IPA or intact Purkinje activation. So the Purkinje activation itself is intact. You can see a continuous progression from left bundle towards Purkinje fibers. Whereas in some other patients, there is block actually in the left bundle. Now this left bundle block can again be, depending on the level, can be within the His. Like in this patient, you can see there is still an atrial electrogram at the level at which the signal in the conduction system disappears. So this block is within the His itself. So this is an intra-Hisian block, or it can be beyond the level of the His. It is in the bundle itself. So a narrow QRS, you have normal His Purkinje activation. In a wide QRS, which we typically call LBBB, some patients could have an intact Purkinje activation, and some patients could have block, and the block can be within the His or can be below the level of the His in the bundle itself. So how common are each of these variants? Localized conduction block in patients with an ECG finding of left bundle branch block was found in the majority. So it's about 64%, so close to 2/3. Whereas the other 1/3 do not have conduction block and really have intact Purkinje activation. So the appearance of block is due to distal conduction delay. In those with block, the majority the block is within the His bundle. So that's again sort of very interesting finding, which suggests that His bundle pacing can actually correct most of these patients who have an LBBB. And in the others, it's in the proximal left bundle. So this has value when understanding what is the response rate that you would expect from His bundle pacing. Obviously, those where intact Purkinje activation is there, His bundle pacing is not going to change anything, so they don't have any response to His bundle pacing. Whereas those with block, if the block is intra-Hisian, the response is better. 94% of them have QRS correction. Whereas if the block is beyond the His in the proximal left bundle, QRS correction falls. There are reasons why you can still correct it from a His bundle pacing, but the correction happens in only 62%. So the key then here becomes, can we identify these two different variants, intact Purkinje activation versus localized conduction block by ECG? And the answer seems to be that there's no foolproof way to identify this on the ECG. Although there are certain markers which help. The longer the QRS duration, the more likely it is due to complete conduction block than due to delay. So these patients, that's why they respond better to all forms of resynchronization therapy. Presence of QRS notching, again, favors conduction block. And using the Strauss criteria, which is a bit more strict, again, favors conduction block. Now, again, like these were experiments in dogs where they mapped the septal myocardium and then produced a block of the left bundle, proximal left bundle. And then what happens is there is delayed activation of the septal myocardium, but the delay is uniform across all areas of the septum, which basically, and the delay is uniform, and also they find that even though you block the left septum, whenever you record an electrogram, there is a Purkinje potential preceding the myocardial activation. So what this suggests that if you just do a simple transection of the left bundle, the activation goes down the right bundle, crosses over, activates the distal Purkinje system in the left bundle, and the rest of the LV is not, the whole LV is not activated by muscle-to-muscle activation. So there is cell-to-cell myocardial activation as it crosses the septum, but then it engages the left conduction system, and most of the left ventricle is activated through the conduction system itself. But these experiments in canines are with a normal heart, whereas in patients with left bundle branch block, there might be additional conduction system abnormalities which can result in further delay contributing to the left bundle branch block. So if you think of it in left bundle branch block, the QRS duration reflects transseptal conduction time, total endocardial activation time, and transmural activation time. And you can have delay in any of these contributing to the width of the QRS in a patient with LBBB. So when mapping patients with heart failure and left bundle branch block, what was found is, one is that you see a sort of two families of the transeptal time, which suggests that in some patients the transeptal time can be fairly short because some of it is contributed by specialized conduction tissue itself. So some fascicles of the His Purkinje system might help cross the septum faster, whereas in others where that is not there and the whole transeptal conduction time has to go through muscle, it takes longer. And then these patients also might have additional delays in LV endocardial activation. So basically, even in those with a proximal left bundle branch block, there might be additional delays in the distal conduction system which can contribute to further delays in dysynchrony. So these, while conduction system pacing will address this transeptal delay, it might not address some of these distal delays which are distal to where you're pacing from. And in addition to delays due to conduction system disease, you might also have abnormal delays and conduction block, which might be primarily functional, which was shown in this study published in Circulation using non-contact mapping, where they showed that if you map the LV activation during left bundle branch block, you tend to have a sort of wavefront which rotates around the apex with a certain line of block which prevents it from conducting it uniformly. But this is considered to be primarily functional, depending on where the breakthrough of the LV endocardial activation happens in the presence of LBBB, and it's likely that this kind of conduction blocks will be corrected with conduction system pacing. So in terms of practical implications of what we have discussed, I think a good understanding of anatomy is important, but it's more important for His bundle pacing than for left bundle pacing, where it's relatively, the implications of anatomy are lesser. In terms of His bundle pacing, I think the primary takeaway points are that there is significant variability in anatomy of the conduction system, and therefore the location and the difficulties, the extent of overlying atrial muscle, and the relative location of the penetrating part, whether it's more ventricular or atrial, really depends on each individual patient's variability. And the level of block explains how conduction system pacing works, that most patients with left bundle branch block have a discrete interruption in left bundle, and most of them, this interruption happens at the level of the His rather than at the level of the bundle itself, and that explains why His bundle pacing works, at least in 3/4 of these patients. And definitely, left bundle pacing has advantages here because you're pacing a little more distal in the conduction system, so it's more likely to narrow the QRS in a larger proportion of patients. But many of these patients with left bundle branch block might have additional distal block, and therefore proximal left bundle pacing may not correct in all. And this kind of additional distal conduction abnormalities are raise the point that an additional CS lead might help reduce the delays that come because of this distal conduction disease. Thank you.
Thank you, Raja, as usual. Brilliant talk and wonderfully described. So the more I see and read about the conduction system, and the more we are going into selective conduction pacing, do you think they used to do this in the early studies, if you see, of CRT? Do you think there's any role for a pre-implant conduction system mapping study, so that you know what you're in for? Right. You know, you put a His bundle electrogram, you map the left side, you see the intrahisian block, interhisian conduction delay. Then you kind of sit down and plot those numbers and say, this is what I'm going to do in this patient. And that's it. And you are from a top university and you're the professor in charge. You should be doing those things a little bit. I can't force you, of course. I mean, in private practice, let me tell you, I mean, the most important thing is to get the patient lie down and pay and see that he has paid already. So I'm out of this, but this kind of thing actually makes me think whether I should get back into some Jimma Pondicherry or anybody which is, you know. Yeah. Yes.
I think it's a very good point and important point. So
which point?
Not
no, there were 3
everything.
points. One was to do a conduction system study. Second was to be in private practice. Third was to look for a job in government college. I've got one. The third I've got a government college appointment now. So.
So in that study by the Tung's group also, they discussed this, that because the ECG is an imperfect marker, and really mapping gives you information which you cannot get from the ECG, it would really be ideal to do a map. But obviously the issue is practically how easy it is to do and the feasibility of doing it this on a regular basis. So again, probably this might be one place where if this ECG imaging works with body surface mapping, or that kind of non-invasive things work well, I think they could add information like that. But currently, having to do, say, a full 3D map for everyone before doing this, I think just the technical feasibility. Or even, just if you look at, right. Yeah, I agree. At least as a research study, probably it's worth looking at sometime. Yeah.
So in fact, choosing the right patient for doing a left bundle branch block, left bundle branch pacing, that's what you're asking, sir. So in patients with a typical LBBB, the typical LBB can be this Strauss criteria. So we usually look into 2 parameters which will predict us that whether the patient will respond or not. So one is an ECG. So if there are notches, so leave about other parameters in stress criteria. If you see notches in 1A, VL, V5, V6, even if you see 1 or 2 notches here and there, I think whether it is a left axis or normal axis, many a times, at least more than 95% of the time, you will be having a very good paced QRS. And second important thing which we usually look in our lab is HV interval. That's what you are also telling. Put just a simple thing, spend 2 minutes, put a catheter across the His and usually put an RV backup also. If the HV is prolonged, like more than 60 milliseconds, and ultimately you will end up in getting a good QRS. More than that, so you spend some time in the groin, just push the catheter up and down. If you see 2 different HV intervals, proximal and distal, that all the more favors that you have some intrahisian disease, which will be getting corrected by doing left bundle branch pacing. So these are the 2 important things which you always look before doing a LBBP for LBBP, non-ischemic cardiomyopathy.
Absolutely, great.
No, so it's in 1 ABL B5 V6, lateral QRS. That's what Strauss criteria actually is. No, the QRS upstroke, in that R wave. That's a predict. It's all Strauss criteria.
Yeah.
It's all Strauss criteria.
That's why the Strauss criteria makes it much more
exactly, sir. In fact, the Wong's article where he has quoted 98% success rate, he has taken a strict Strauss criteria. 61 patients were included. All patients fulfilled Strauss criteria. The success rate was almost 98% with 11 branch pacing.
The question here is which one not to be done.
So if you have a Q wave in V1, so if you have an atypical LBBV, Q wave in lead V1.
Which not to become.
Yeah, so choosing the right patient for a BIV or a LOT CRT will be having an atypical form of LBB, where we'll be having an R wave in V1 with a QS. Instead of QS, it's a small R and deep S. R and associated S wave in lead V6. So all these are favoring some sort of atypical LBBV, so where you will not get a good result with left bundle pacing alone.
I'm just talking about non-ischemic cardiomyopathy. If the LV is dilated, echocardiogram wise, say 6 centimeter, obviously, we can, as you suggested all those, in addition to all those points, we can make a conclusion that it's not going to work only with the conduction system pacing, LBB pacing.
Just like a CRT in a female patient, non-ischemic cardiomyopathy, normal coronaries, if the LV dimension is less than 65, so usually they are more than super responders, they are normalizers. So you can have a normalization of LVEF. And even with a pretty badly dilated LV, like 70, 80, we have come across patients who are responding well. In fact, probably in my presentation, I'll show you a case where the LV dimension was 84. The patient had nothing, no money for them. I put a dual chamber pacer. And over 1.5 years period, the response will take some time. So once the LV goes for dilatation, the response to by this left bundle branch pacing takes some more time. So at the end of 1.5 years, his LV was 48 millimeter with a good gaining of septal thickness. He had normalized actually. So all depends on how good LVAT you are going to get during implantation. So I usually go with an LVAT. If I'm getting an LVAT of reasonably good LVAT of less than 90 milliseconds, I usually accept and leave it the dual chamber pacemaker, especially if there is an affordability issue. And rather than echo, I will take MRI as a predictor. If I'm going to see a scar in the basal septum, anterior septum, I usually tell them like, you're not going to have a good response with left bundle, you may need a CS optimized CRT. So instead of echo, probably we can use a MRI, which takes probably 6,000 or 7,000 cardiac MRI to look for scar to predict the response.
This conduction system pacing has to be there. And then you decide whether you want to do CS pacing.
I'm biased, sir.
So just one more comment to Dr. Nayar's question. ECG imaging, as Shanmuga and Raja said, is one thing that being done in Europe and also in US, which will looking at this. The other thing which is coming up and mainly done in China and also I think in US is artificial intelligence and machine learning. Because there are so many clues from the ECG which a human eye cannot read. And with machine learning, they can actually predict, will this patient respond to conduction system pacing? And if yes, which one, even his bundle or left bundle? And whether it will need additional CS lead or not. Yes, because the numbers are huge in China. We can't even imagine the number of conduction system pacing cases they're doing.
That's a good number. Yeah. So maybe you should have a conduction system pacing registry and our own can anchor it. And all the conduction system patient before and after can go in one. And then you can have a machine learning and then you don't need ULAs.
Dr. Haranburi, I think you are there to tell us the progress. Could you hear us, Dr. Haranburi?
We implanted the atrial lead and the RV lead at the right ventricular apex. And then we tried BIV pacing simultaneous using the right ventricular apical lead and the LBBP lead, and the QRS is really not very nice. It was something like 180 milliseconds or something like that. So with simultaneous BIV pacing, not very nice. So what we did now is that we tried fusion pacing. The intrinsic AV delay, sensed AV delay is 200 milliseconds, and we tried 160, 150, 140 with the LBBP lead and with the RV lead. And I don't know if you can see the screen. Yes, you can. On the left, you have fusion pacing with the RBBP lead, which gives a QRS width of how much? 140 or something? 140 milliseconds. Okay, 146 milliseconds. And with the right ventricular apical lead, it was like about 10 milliseconds more or something, 155, yeah. So slightly better with the, and this is the best that we got with both. So this is what we get with fusion pacing with LBBP and fusion pacing with RV pacing. And the narrower QRS and the intrinsic QRS. The intrinsic QRS that we measure here was 160 milliseconds. So, you know, nothing really absolutely fantastic, but probably a little bit better than the intrinsic QRS. So it's sort of, we were debating amongst ourselves, should we try the CS lead or not? And I'll be happy to have your feedback.
So we would like to know, did you use both the leads
Yeah,
and the fused? We want to see that QRS.
Then we can try that. Yeah, that's a good, we can try that one. So we leave the atrial lead on, and then we'll pace from both the leads. We didn't try that because the BIV paced simultaneously on us didn't look that great. Sorry.
Anand, Anindya, you could actually open the device and connect, so it will be much easier for you to.
Well, it's also a question in the end what device the patient will get, right? Because is it going to be a CRTD or a dual chamber? So here I'm connected with the BIV, and we can try at the AV delay, which was what, 140?
Without the device, how they are.
Exactly.
Without the device, you are programming.
Yeah. We're just doing this with the programmer, and
okay.
So it's managed to do it quite well.
Okay.
So now we can try BIV pacing. That's just the LBBP plus RV. I'm connected to both using the same crocodile clips, and connected to the stylet of the RV lead, so it's good contact. And let's try now with fusion pacing with an AV delay of. No. You can pace in DDD. And you can start off with an AV delay of 150 or 140, which was the one that gave us. Yeah, both. No. I have the atrial lead connected, and I've put the crocodile clip on both, the RV and the LBBP. Because we saw that in VVI pacing with the BIV was really not good, and now we're going to do the fusion pacing with BIV. Can we see the live? For the time being, it's ASVS, I think. Oh, but we don't see any pacing. We don't see any pacing. Yeah, I'm in bipolar. It's not pacing. No, there's no pacing. But I am connected here. Oh, I know. I'm going to go, this is bipolar. We have to go unipolar. So there we go. Okay, so this is what,
that's
I think
the
one.
best.
Hang on, it's, so this is the, yeah. Can you check the QRS morphology here? It looks quite good, huh? Yeah, so it's 144. It's pretty similar to the LBBP only pacing. I think we're getting intermittent loss
so
of
actually we are not
structure.
getting a uniform BIV.
But we're getting intermittent loss of the RV. But here I've got a better contact on the stylet. So you see, there we are. Okay, this is LBBP only, I think, and this is the RV as well. Yeah. It's actually quite. It's not bad, huh? And this is the LBBP, which is how much? 134. Yeah. I think you need to go a little bit more to the right. You're being too kind. A little bit more, yeah, that's more like it, I think. So it's like 144 milliseconds. It's just that we have a much more positive R wave in V1 with this, and then with the BI-V, it looks a little bit narrower. Check again, please. Measure the BI-V one. That's 150. It's a bit similar. So this is what we get with the fusion pacing. So the question is, should we try a CS lead or not? I think that's the big question.
Let's take a vote here today. How many of you would like Harun Buri to be there in the lab to try CS also? Is that we would like to learn how does he do, or you think the
patient improves? The patient.
Dr. Buri, we do not want you to get away from the lab. I hope. Did you people do the levo phase of angio? Was it a nice one?
Yeah, there's a good vein.
Very disappointing. All right, so Dr. Harun yeah, you can stay there, and I wish you will get a little better looking QRS, and all the very best to you people. Anand and Anindya, you let us know when you are into the CS, please. Okay. Yeah, so shall we break for the coffee now? Is that okay?
Okay, so we'll go with the CS.
So ladies and gentlemen, while they toil there in the lab, let's have some coffee, yeah?
Might as well try.
So, please.
Okay, so we'll take the CS extended hook.
check this. Hello. No. Check this. Hello, 1, 2, 3, check this. Test. Check. 3, 2, 1. Channel. Test. Check this. Hello, hello, hello. Check this. Check this. This. Check. Check this. Check this. This. Check. Check this. This. Check this. Check this. 3, 2, 1. Three, two, வருது. Check. ஓகேவா? அவளையும் கேட்குதே. Check this, this. 8. Check this, this. Check this. Check this, this. Check. Check this, this, check this, this, check. Check this, 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 check. Check this, this, check this. Check this, this. Check this, 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 check this, this. 8 மட்டும் கம்மியாக இருக்க மாதிரி இருக்கு, லோவா இல்லை கரெக்டாக இருக்கு, விட்டுரு. கெயினை கம்மி பண்ணுற. இப்போ தெரியுதா, நான் நார்மலாக பேசினா கெயின் கம்மியாகும். நான் கொஞ்சம் நல்லா பேசுகிறேன். பேஸை கட் பண்ணிட்டு மிட்டை வச்சுரு. செக் 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 கரெக்டாக இருக்கு. செக். என்னப்பா ஃப்ரீக்வன்சி கையில் எடுத்துக்கிறேன். Check this, check this, check this, check this, check this. Check. 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 Check this. 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 Check this, this. Check this. 4. Check this. Check. test, check, test, check, test, test, check, test, check, test, check, test, test, check, test, test, check, test, check, test, test, check, test, check, test, check, test. Check, check. Hello, hello. Check, test, check, test, check, test, check, test. ஓகேங்களா?
Check, test, test, hello. Check, 1, 2, 3, check, hello, hello. Check. Okay, wow. Check. Check, test, test, hello, hello. Check. Check, test, test, hello. Check, 1, 2, 3, check, hello, hello. Hello, check. Check, hello. Check, test, hello, hello. Check. Check, test, hello, hello. Check. அஞ்சா ஈக்கு தொடாத. Check, test, hello, hello. Check. Check, நார்மலா பேசுகிறேன். Check. Check, test, hello, hello. Check. Check, 1, 2, 3, check, hello, hello, hello. Check, test, hello, hello. Check, check. நான் 3 லைட்டாக ஏற்று, லைட்டாக 3 ஏற்று. Check, test, hello, hello. Check, check. போதும்.
5 minutes you announce. In 5 minutes you announce. No, no, next presentation. Just figure it out with the lab people whether they would like to come. Like, whether they would like to come. In the meanwhile, call from both sides. So, Dr. Haranburi, I know that you have been working hard there. We have had our coffee here, and we are fresh to hear from you. Dr. Haranburi, I hope you hear us. Get the fluoro also on the screen, fluoro image. Yeah, so. Yeah, we could see the LV pacing taking place there. So it's probably quite lateral and apical. Yes. Yeah, so it's quite apical. I thought there was another posterolateral was there, I thought. Yeah. So I don't know why they chose this, but anyway. It doesn't appear to be middle cardiac. It's not middle cardiac. It's a posterior. Yeah. So can we have a connection with the cath lab, please? Dr. Harunburi, can you hear us? Dr. Buri, can you hear us? You can't hear me?
Can you hear us?
Oh, yes, yes.
Oh, good. All right. So we put the LV lead in. It was not very difficult. You know, it's in a posterolateral vein. And this is LV pacing only. And now I'm just going to keep with the LBBP lead. And see, hang on. This is just a little bit tricky because I'm touching both. And this is what we get with BI-V pacing with the LBBP lead. So we get a nice QRS, which is measured at 135 milliseconds. Quite good QRS narrowing. So I'm actually quite happy with the BI-V pacing using LBBP plus the CS lead. And the CS lead threshold is below 1 volt. This is not bad at all. The thing that we can still test is the BI-V pacing with just the RV lead, so that we don't get any abandoned lead.
Dr. Buri, we are a little curious to know, why did you choose that tributary? I thought there was another basal tributary, the posterolateral.
Well, there are two. Can you see the venogram?
Yes, we can see, and then
So
let's have a look at the LAO.
Yeah, this is in PA actually, because it's a very tortuous vein, and this is in PA, and so there's the posterolateral tributary. You have one lateral one, which is around about 3 o'clock, which is very small.
Yeah, we could now visualize it better. So that was the only great vein which you could have tried, right?
Well, I mean, I think there are several options. You have an anterolateral vein. You see all the way on top an anterolateral one, which is there, anastomosing. That would have been a possibility as well. Otherwise, that lateral vein is very small. I used a stability quad. The stability lead, you can actually, it allows you a lot of versatility. It's very good for the big veins because you don't get dislodgements. And it's also sometimes good for the small veins where you can't get the whole lead in. And so you just put the distal electrode and maybe the 2 and 3 which are in, and the screw, you screw within the CS. So this allows also sometimes to tackle small veins. So it would have been a possibility. And we were contemplating that I try another vein, but then when we get the BI-V pacing, it actually looks quite nice with good thresholds, and so this looks actually quite good. I don't know if we will be gaining anything from going in a more anterior position. And the reason why I suspect that this is actually giving, in the end, a good QRS complex is because I think the electrodes are very, very separated. You see, if we go more anterior, I think we'll be a little bit closer. We'll be a little bit more towards the septum, whereas here we're very posterior and have good separation between the LBBP pacing lead and the CS lead. Can we just pace now and try this? Now what I'm going to do is I'm going to do the BI-V pacing using the RV lead, the apical lead. Can we pace BI-V now, please?
So the proximal pair of the quadrupole CS catheter, CS lead you are using, right?
Oh, hang on, I'm doing something.
Looks like they use the distal pair.
I wanted to go with the RV.
Looks like they use the distal. Would you like to tell us what was it with the proximal, the electrodes?
Which?
The CS, proximal 2 electrodes. Which one you paced?
So we paced from 2. We tried one, which was okay. It just had free nerve capture at 5 volts with a threshold between 1 and 2. And then we tried electrode 2 with a threshold below 1 volt and no free nerve capture, and actually a very nice BI-V pace QRS. We tried 4 as well, which also had a threshold between 1 and 2, but the QRS was a bit wider. So can we pace now, please? So now I'm pacing between CS2 and the RV apical lead. And look, it's not too bad either. Can you measure the QRS here?
So this is the conventional CRT now?
This is just conventional CRT. It's a bit wider, 152.
See, the conventional CRT has a role.
It does have a role here. I think it's better than LBBP alone, for sure, or the sort of left hist that we had. But now the question is this better, or is the pacing using the LBBP lead?
Now, we would love to see the 12 lead in some 50 speed. You know, I think that is looking terrific.
Okay.
I think.
So-
I think this is cute, man. Huh?
This is
So
good.
a big applause to the team there. Beautiful. And Anindya, please release Dr. Buri. You know, he requires some rest. Okay. This is a conventional CRT.
No,
Yeah.
So my question is, should we leave it like this, or should we use the LBBP lead?
No, I think RV coil and the CS lead, I think that is what is the best. Yeah, you may actually pull that off.
Okay. Can you show the other one? I thought the other one was nicer.
No, it's okay. You know, let them take it off. Yeah, so it's much better. So, you know, one more thing, what we would like to see is if you fuse with the intrinsic, how does it look, you know? That
Yeah, but that I think we'll have with the device. We'll have the...
It's okay. I think we believe that, you know, the best of the things
Yeah.
had been done for the patient.
So-
and all of them were very, very patient to do this case.
So just right now on the frozen screen, you have with the LBBP
LV and LBBP, yeah.
and the LBBP, which is... So you can, we'll decide between both.
Yes.
Well, I think the BIV is good on the right.
So I think the LV2 and LBBB has a better access, and you know, maybe I think the left bundle stays there.
Stay there so that you have something to do next week.
Yes. So the left bundle stays there. RV coil will be, you know, kept.
Okay. We have good sensing from the LVBP lead with an R wave of 8 millivolts. So
Okay,
that's good.
shall we clap
Okay.
again once more?
Sure, fine. Okay.
Okay,
so
thank
I'll
you,
come
Dr.
back to
Buri.
the-
You know,
I'll
when you
back.
come here, please explain something more about, you know, the
Sure.
challenges, what you faced, etc.
Sure.
Thank you so very, very
Okay,
much.
Thank you.
All right, so we can call the next speaker here.
Can we go to fluoro? So now to slip, now to fixate the lead, what I do is I take the wire out.
May I now invite Dr. Kartikeya Bhagava to deliver his talk on defining physiological pacing in terms of pace QRS morphology.
So, thank you, Dr. Ulas, for inviting me here. And it's always a pleasure to back with Triple M and share and learn our knowledge together. So, I will be talking a lot of ECGs in physiological pacing, and that's my task is. And so, physiological pacing entails capturing the cardiac conduction system, his bundle or left bundle branch, in order to prevent or correct pacing-induced or LBBB-induced electrical and mechanical dyssynchrony. And it may involve pacing the his bundle, left bundle branch, or his bundle along with LV pacing, or left bundle along with LV pacing, LOT CRT, as we have seen in the last case. Now his bundle lead, now it's also very important to understand what structure we are capturing. So his bundle lead, because of its location, can capture the his bundle directly, but can also capture the surrounding RV myocardium, and sometimes, which is unintentional, may capture the atrial myocardium. But one should be aware of that. Similarly, left bundle lead, depending on its location, may capture the left bundle branch trunk, the left anterior fascicle or left posterior fascicle, and along with the septal, left ventricular septal myocardium. And also with the device, it may also capture sometimes the anode, which may lie in the right ventricular septum, and so it may also capture the right ventricular septal myocardium in a bipolar mode. Now confirming CS capture, now we know that conduction system capture results in faster and more homogeneous depolarization of the left ventricle than myocardial only capture, and hence confirming capture of the target conduction system is important to achieve the goal of maintaining or correcting ventricular dysynchrony. And the way we do is primarily by the ECG, and variation in QRS morphology during pacing, especially during implantation, is very important and needs to be recognized promptly. Now, why is the QRS morphology different in conduction system and myocardial capture? Now, we know that the conduction system is a specialized tissue which has a very rapid conduction velocity, and these electrical properties help us in understanding the different QRS morphologies. We all know that rapid conduction results in a narrower QRS width and a shorter RV peak time in the lead V6, which is a surrogate for left ventricular activation in the lateral wall, the epicardial surface. But one sometimes also should understand that the different tissues, the conduction system and the myocardium may have different capture thresholds, and so may differ in the conduction, so with different outputs, different structures may be captured. Similarly, the refractory period of the conduction system tissue may be different from the myocardial refractory period, and so this can be exploited to see a transition between capturing both the tissues and then losing capture of either the conduction system or the myocardium. Now, when we are in the conduction system, it's sometimes very difficult to know whether you are actually capturing the conduction system tissue or it's just the surrounding myocardium. And if we can show the transition at different outputs during extra stimuli and show two different QRS morphology, we can be certain that at least one of them was capturing the cardiac conduction system tissue. And so these transitions are very important to recognize in the ECG for confirming the conduction system capture. Now, how do we do that? Now, during the intrinsic rhythm, if there is native AV conduction, we look at the potentials. His bundle potential is very easy to recognize, especially to the electrophysiologist. We know that it is there when we see it, but when you are pacing, again, it does not necessarily mean that you are capturing that tissue, because we know that at high output it may capture, at low output, despite it being present during sinus rhythm, it may not be capturing. Similarly, left bundle branch or left fascicular potential during intrinsic rhythm may be absent, though it may be seen in some patients with left bundle pacing, but it is usually absent if there is no AV conduction or there is proximal left bundle branch block, and may be seen retrogradely during complete AV block and not seen in the majority of the patient. And in fact, practically, honestly speaking, I don't even look for it. Now, stim to QRS. Now, during selective conduction system capture, the stim to QRS delay is akin to the HV interval in the His bundle pacing and left bundle branch or left fascicular potential to ventricular interval during left bundle pacing. So this is logical. But if there is only myocardial capture, the stim to V interval will be either 0 or very, very short. Now the problem comes when you have capture of both the myocardium and the conduction system. So we look at the paced QRS morphology. If it is similar to baseline and then you are sure that you are capturing the cardiac conduction system,
We look at the QRS duration, which is usually shorter than myocardial only capture. And this may happen with that we may be able to correct the bundle branch block which is present during sinus rhythm. And when we capture the conduction system at a good output, we may be able to correct the bundle branch block. And the presence or in fact absence of notches, slur or plateau in the peaks of the QRS complexes means that you are capturing the conduction system. In fact, if you see a ECG where at high output there are no notches, slur or plateau, but at lower output you see that these appear, then you are sure that you were capturing the conduction system with the non-selective capture, and then later at a lower output the conduction system capture is lost and only myocardial capture is present. Finally, RV peak time in lead V6, as I said, is a good indicator of the conduction system capture, as we'll see later. Finally, as I said, transition in paced QRS morphology, which can be brought about by differential output pacing, programmed stimulation, or burst pacing is in an asynchronous mode is sometimes helpful. So looking at the ECG in his bundle pacing, if there is a selective versus non-selective capture or myocardial only capture, how do we differentiate? Now for a selective his bundle pacing, your stim to V will be same as HV interval, and the stim to QRS end, that's again a very important thing that we often don't measure, will be same as his to QRS end, because sometimes you may not be able to see where the QRS begins and maybe better visualize the end of the QRS. Then your paced QRS duration will be same as the intrinsic QRS duration, and morphology will be identical to the intrinsic. So this is selective his bundle capture. Now what is non-selective his bundle pacing is when you are capturing not only the his bundle but the surrounding RV myocardium as well. And in this case, the stim to V time will be less than the HV. Stim to QRS end will be same as his to QRS end, because not only the myocardium, you are also capturing the his, so the rapid conduction through the his bundle will, though the QRS starts immediately after the pacing stimulus but ends at the same time as the intrinsic QRS would have happened. And the paced QRS duration is longer than the intrinsic QRS, and morphology will show a pseudo delta during the initial part of the QRS, but the latter part of the QRS is similar to or identical to the native QRS. Now in case of myocardial only capture, your stim to V will be absent or will be very shorter than the HV interval, and the stim to QRS end will also be longer than QRS, his to QRS end interval. The paced QRS duration will be longer than the intrinsic, and morphology will be broad left bundle branch block, as typically we see with RV pacing. Now sometimes with the his bundle capture, these are all descriptions when the intrinsic QRS is normal, but if you have baseline broad QRS due to bundle branch block, you may be able to correct the bundle branch block at higher output, and lower output you may lose that correction. So if you look at the different QRS morphologies, you can have different threshold for the his bundle capture, threshold for the myocardial capture, and threshold for bundle branch correction in an individual case. So these are different examples all taken from Dr. Buri's work and Dr. Vijayaraman's work and Dr. Marek's work from Poland. So all these ECGs, in the first example, you see that in the pacing in the very proximal location in the his bundle, there is selective his bundle capture, and that results in all the things that were described in the previous slide. And as the output is lowered, you just see that the capture is lost. So this is a single threshold, which is a selective his bundle threshold. Whereas in the second ECG, what is happening is that you have a non-selective his bundle capture at a higher output, and as you lower down the output, you have selective his bundle capture, the myocardial capture is lost, and further lowering the output, there is total loss of capture. So you have two thresholds here, the his bundle threshold and the myocardial threshold. The third example shows, so this is transition from non-selective his bundle pacing to selective his bundle pacing, wherein you have the his bundle threshold, the myocardial threshold and the his bundle threshold. And the other example could be that from non-selective His bundle pacing, you lose the His bundle capture at a lower output, then you have myocardial only capture, and then further lowering the output, you lose all the capture. So here you have the the His bundle threshold and the myocardial threshold, and then in the fourth example, you see that there is underlying bundle branch block, and when you pace distal in the His bundle, you find that there is at higher output, you have selective His bundle pacing with correction of the bundle branch block. As you lower the output, you still have selective His bundle pacing, but with the same bundle branch block that is present during the baseline. So there is no myocardial capture in this example at all. So you see that the stim to stim to QRS is long and similar to the HV interval at baseline. In the fifth example, you have non-selective His bundle capture with correction. Lowering the output, you see that the QRS changes with selective His bundle capture with correction, so you lose myocardial capture, and then further lowering the output, you still have selective His bundle pacing, but the bundle branch block reappears, so you have selective His bundle pacing without correction. Finally, you can have from non-selective His bundle pacing with correction to loss of correction, and then selective His bundle capture. So there could be multiple types of QRS morphologies that can happen, and that will depend on the underlying AV conduction and QRS morphology, whether there is a bundle branch block or not, the location of the His bundle electrode, whether it is proximal in the His bundle or a little distal, type of His bundle anatomy, the pacing threshold and the output at which you are pacing, and pacing configuration. Sometimes if you pace in bipolar, you may capture the A node as well. So again, showing the same examples, what different thresholds you can have, the His threshold, the myocardial threshold, and the bundle branch correction thresholds, and how the QRS morphology changes by lowering the output during differential output pacing. Sometimes when these differences in the thresholds are not there, that means that when you, from non-selective capture, you lose the total capture if you lower the output. That means the His bundle threshold and myocardial threshold is the same, then you will not be sure whether you are actually capturing the His bundle or not. Then sometimes you can bring about these transitions by programmed pacing, as is shown in this example, that after a drivetrain, you give a single extra, and this single extra shows a widening of the QRS. So that means that you are capturing the non-selective His bundle during the drivetrain, wherein you were capturing both the His bundle and the myocardium, and with the extra, because the refractory period in the His bundle is reached, you lose His bundle capture, but the myocardium is still non-refractory, so the myocardium still captures, and you see a wider QRS. Similarly, you need to look at these morphological features very carefully. That is, when you have non-selective His bundle pacing to myocardial transition, you find that the peak, which was very sharp during non-selective pacing, becomes, in lead 1 especially, becomes a little rounded. The notches which were present in the precordial leads will become, which were absent during non-selective pacing may appear notch or slur in the precordial leads. And finally, the R wave peak time will prolong if there is loss of His bundle capture. Now, these subtle QRS morphology variations can be seen due to distal His pacing or sometimes proximal right bundle branch pacing. As you see in this example, the first example, you see the intrinsic QRS is slightly, there is a slight difference in selective His bundle pacing QRS. And this is because it is basically capturing the proximal right bundle rather than the His bundle itself. And that is also known by looking at the stim to QRS time, which is a little shorter than the intrinsic HV interval. During non-selective capture, you see that there is stim to V is 0, and there is a small delta-like picture, but otherwise the QRS morphology is similar to selective His bundle pacing. In the other example, there is some output-dependent recruitment of fibers. This is a very interesting tracing that Sometimes I have seen this also myself, but you may get surprised that your intrinsic did not have any bundle branch block. When you captured the selectively his bundle, you got an QRS which was identical to your baseline QRS, but at a lower output, sometimes even for a very shorter window, you find that there is development of bundle branch block. Now this, how can you explain this? Now this is again by the same longitudinal dissociation theory, that you know that at this lower output, the branches, the fibers which are destined to become the right bundle branch are not recruited, and hence you are getting a right bundle branch block pattern while selectively capturing the his bundle. So this is very interesting, and one should know to recognize this to understand the these intricacies. Now distinguish non-selective his bundle pacing from myocardial capture. Again, as I said, looking at the morphology patterns in the QRS, you see when you have a non-selective capture, your peak in lead, especially in lead 1, will be very sharp, but as you lose the selective his bundle capture, the peak gets rounded. Similarly, there will be development of notches and slurs in the precordial leads, and the R wave peak time will increase if once you lose the his bundle capture. The other example shows that if you have baseline intraventricular conduction defect, as in our previous case, live case, your selective his bundle casing may not show a very good QRS, and there will be, though despite correction, the QRS may not look that good, and only these variations in QRS morphology, especially during transition, will help you in knowing whether you are actually capturing the his bundle or not. Now this is a slide again showing the R wave peak time in lead V6, which can differentiate from non-selective his bundle from the RV septal or myocardial only capture. Now logically, the R wave peak time will be longer during RV septal capture, and the difference during his bundle pacing is quite large and easy to identify. Whereas if you look at the left bundle pacing, this difference is to the tune of about 15 to 20 milliseconds, and you need to actually measure it to recognize it, and the QRS duration during left bundle pacing will actually not change much between non-selective left bundle capture and left ventricular septal only capture. So this is an important parameter that one needs to measure it to identify that whether there is loss of left bundle capture during transition from non-selective left bundle capture to LV septal only capture. So this was an algorithm which was developed by Marek from Poland, wherein they looked at during the his bundle pacing that if there is QRS notch, slur or plateau in lead 1 or V4 and V6, then this is RV septal pacing only, because his bundle capture should abolish all these notches and slurs. If it is not there, look at the V6 R wave peak time. If it is more than 100 milliseconds, again it is RV septal only capture. And if it is not there, if it is shorter than 100 milliseconds, then it is non-selective his bundle capture. So this is a simple algorithm which can tell you whether you are capturing the his bundle or not. Now sometimes, again, it is important to recognize if you are actually pacing from a very proximal location in the his bundle, you may inadvertently capture the atrium. Now in this example, you are non-selectively capturing the his bundle in the initial, in fact, selectively capturing the his bundle in the initial 4 QRS complexes, but here you lose the selective his bundle capture, but you are capturing the atrium, and this is very well apparent by the P waves after the stimulus, where you see, and then it conducts with the normal AV node conduction system to the QRS, and so there is no his bundle capture here, but only atrial capture, and it is important to recognize, should not take it as his bundle capture. Then there are other pitfalls like pacing artifact. If you are pacing at a very high output, may actually may deform the QRS and may indicate that the QRS morphology is different from the intrinsic.
but that may be just because of the pacing artifact. Or if you're pacing at, in this example, retrograde P wave, if you see at very high output pacing, very interesting tracing from Dr. Bari's paper, where you see that during very high output pacing, the QRS looks quite good. But as you lower the output, you find that there is P wave, retrograde P waves appearing at the end of the QRS. And the reason was that during this high output pacing, the atria was also getting captured. And at a lower output, when the atrial capture was lost, they conducted retrogradely, resulting in a retrograde P waves. Finally, during bipolar pacing, there may be anodal capture, which may again confuse you, but may sometimes be helpful as a part of backup pacing in case you lose the His bundle pacing in a particular case. Now, coming to left bundle pacing, now we all know how to confirm left bundle pacing and what is successful left bundle branch pacing. This is the criteria from the Vijayaraman and Huang's paper. Now we look at the RBBB pattern in the lead V1, presence of LBBB potential, and any three of these following if present can actually tell you that you are selectively, you're capturing the left bundle branch. But again, sometimes it is very difficult to know unless you have a transition in QRS morphology from one to the other. So let's look at a few examples. Now again, where in the left bundle you are pacing will also change the QRS morphology. As Dr. Raja showed, left bundle branch is not a very simplistic model as shown in this diagram, and it's a network of Purkinje or fascicular tissue, and so it's not a small area that you need to target. But in this paper, they looked at pacing in the left bundle branch trunk, wherein you had right bundle branch block with a normal axis and S in AVL and lead 1 similar to that during sinus rhythm. But if you were pacing the left anterior fascicle or the left posterior fascicle, the morphology was slightly different. And in our experience, it's actually quite difficult to get left bundle branch trunk pacing, and most of our patients are fascicular pacing and mostly left posterior fascicular pacing. And so typically we get left axis in the QRS complex during our left bundle pacing cases. I would like to know what the experience of others is in this regard. And so this morphology changes may be slightly different depending on where in the left bundle trunk or left bundle region you are pacing. This paper also showed that left bundle trunk pacing compared to left bundle fascicular pacing results in shorter QRS duration and QRS area as seen in the vector cardiogram, and but this LVAT is similar and the QRS axis is normal, though the QRS transition zone is more rightward. But at 12 months, the echocardiographic follow-up resulted in a similar parameters. So whether one should actually need to target this trunk area is not clearly known. Now, as in his bundle pacing, to confirm left bundle capture, again, we can do differential output, which we typically do during our implant. We can also do programmed extra stimulation and see the transition from non-selective left bundle capture to either myocardial only capture or selective left bundle capture. We can also give single or double extra stimulus and also do burst pacing asynchronous. So this is another example where you find that 3 different examples showing transition from non-selective left bundle to selective left bundle capture. So you see in the first 2 QRS complexes, this pointer doesn't show, I don't think it shows. So you see that when there is a transition from non-selective left bundle to selective left bundle capture, there is increase in the R wave peak time in lead 1, and though the V6 R wave peak time remains same, and there is a broadening of the QRS. In fact, one should remember that selective left bundle capture may result in the widest QRS that you may see during conduction system pacing. And typically we don't see selective left bundle capture or see it only for a very short window of pacing outputs, and there will be changes in the QRS morphology, like there may be broadening, slurring or notching of R wave in lead V1, V2, or there may be the QRS morphology changes may be very subtle, like tiny R wave may appear in lead V1, or there may be discrete potential in the signal that you may see at after the pacing stimulus in through the pacing analyzer. The other thing could happen is when you lower the output, there may be transition from non-selective left bundle capture to LV septal capture, that is, you're losing the left bundle branch capture. And when this happens, again, you are sure that you are actually capturing the conduction system tissue. And this may result in increase in, since we lose the conduction system capture, there will be increase in the V6 R wave time, peak time, and there will be other morphology changes, but the QRS duration changes remain unremarkable. So this is a very important point, that with or without conduction system capture in the left bundle branch, if you are capturing the left ventricular septal myocardium, your QRS duration may remain nearly the same. So just looking at the QRS duration or a narrow QRS doesn't mean that you are capturing the conduction system, but whether it actually makes a clinical difference in the clinical long-term clinical outcome remains to be seen, because there is some data which suggests that deep LV septal pacing with or without left bundle capture may give the same clinical outcome. But how far it is true, we'll still need to see in longer term follow-up. Again, there may be minor morphology changes in lead V1, which may include decrease in R wave amplitude, or a QS may develop in lead V1 when we lose this capture. But these morphology changes sometimes can be very subtle, that you have to freeze this frame and then see whether there was any change or not. Sometimes comparing the R wave peak time during your paced QRS morphology and the native QRS may help. And but one needs to understand that if you look at the R wave peak time, you should be looking from the same parameters. For example, if you're looking from pacing stimulus to the R wave, peak of R wave, then you should measure it during intrinsic from the left bundle potential to the peak of R wave. But typically we don't see the left bundle potential in most of our cases. So if we are measuring from the onset of QRS to the peak of R wave, then we should ignore the delta or the latency from stimulus, and we should only measure the QRS onset to the peak of R wave during this measurement. So the V6 R wave peak time remains same with non-selective or selective left bundle branch capture, but increases in left ventricular septal only capture. But this difference also is not very marked. It's only about 15 to 20 milliseconds. So one needs to measure it carefully with calipers to notice this difference. Lastly, a very interesting criteria which was again described by Merrick, wherein they looked at the difference in the peak time in lead V6 and lead V1. And this has been found to be very useful and ignores or eliminates the limitations of measuring the R wave peak time in lead V6 only. And herein we just need to look at the peak of the R wave in lead V6 and measure the interval from the peak of R wave in lead V1. And since this indicates V6 R wave peak indicates the activation in the lateral wall of the left ventricle, the epicardial surface, whereas V1 peak will indicate the activation of the right ventricle. If your difference is more than 33 milliseconds as per their criteria, it indicates left bundle branch capture. If your interval is less than 33 milliseconds, it means you are capturing only the left ventricular septal myocardium and not the left ventricular or left bundle branch area. Finally, a couple of slides showing how to do program stimulation to confirm left conduction system capture. In this example, a drivetrain of 600 milliseconds followed by a single extra at 300 milliseconds widens the QRS with appearance of notches and slurs in the QRS. And so it tells you that there is a transition from non-selective to myocardial only capture, and that means you were capturing the His bundle during your drivetrain. Lastly, a very elegant slide again from Merrick, wherein you find that how to exploit the difference in refractory periods between the conduction system tissue and the myocardium. So in the first example, you find that there is a short, long, short sequence, and this results in increase in the refractory period of the left bundle branch and shortening of the refractory period of the myocardium. And so there is, from non-selective left bundle capture, you lose the left bundle capture, and so there is LV septal or only myocardial capture. Whereas if you have a long, short sequence, what happens is that the refractory period of the left bundle branch is shortened, whereas that of myocardium is increased. And so what happens during extra is that you lose the myocardial capture and get selective left bundle branch capture. And these changes in morphology tell you that you are capturing the left bundle branch in the first place. And so this is again a very good way, but may take some time in the lab to confirm conduction system capture. So to conclude, the goal of conduction system pacing is to maintain or restore physiological activation sequence of the ventricles. Confirmation of conduction system capture, either his bundle or left bundle branch, is critical during implantation and is guided by QRS complex morphologies. Conduction system capture results in faster and more homogeneous depolarization of the left ventricle than myocardial-only capture. His Purkinje system and myocardium differ in their capture thresholds and refractory nets, and dynamic pacing maneuvers are used to utilize these differences to confirm conduction system capture. Thank you so much. Yeah, so I would suggest that everybody should read these papers by Harenbury and Merrick and Vijay Raman to understand, because it will take time to understand these. These are not simple ECGs that we have learned.
But anyway, Suchit, I think we should start with you. I'm sure you will ask me. You are fresh, then start. So, you know what, actually, I would begin with this. You see, there could be a challenge in the follow-up or in the parameters what you set finally with the device, because at very, very low output, you selectively capture the conduction system, and because you would like to put a margin of safety at that higher output, you tend to capture myocardium. This can be a challenge.
Yeah, so there could be multiple challenges. Again, if you capture the myocardium along with the conduction system tissue, I don't think that's much of a problem. The problem comes when your conduction system capture threshold is higher than your myocardial threshold, and you keep your output between the two. You are capturing the tissue, there is no loss of pacing, so patient will not die because of brady or loss of capture, but it is not going to capture the conduction system and hence will not have the good activation sequence that you actually wanted initially. So in a patient who has been implanted with a conduction system lead, it is always better to record the ECG while you are actually programming and testing the thresholds, at least 1 or 2 leads in your programmer itself. All programmers have that facility to know actually what is happening. Otherwise, you can sometimes get fooled and only realize it when the patient comes with a routine ECG and you find that the QRS, which was narrow initially during implant, is wider. Then you will see that the device rep had actually lowered the output, considering that the threshold was so good, he didn't need to keep that higher safety margin, and so conduction tissue capture was kept. And it happens very frequently actually.
So, Dr. Buri, many of your publications have been quoted today. Some more comments from your side about how do all of us should recognize the conduction system pacing in an easy way, not necessarily in the EP lab. Even day-to-day ECGs, what we see.
No, I think it's fundamental to use a 12-lead ECG for
patients, to follow up patients with conduction system pacing, you have to have a 12-lead ECG. And that slows down a little bit the follow-up of these patients, doesn't it? What we have is we have an ECG belt. So, because we have a lot of patients in the follow-up with conduction system pacing, so we just put the limb leads, 4 electrodes, and then the belt, which has got the 6 precordial leads, you just put it on, and you immediately have a 12-lead ECG. That really speeds up everything. And I mean, it's complex, fair enough, but in most of the cases, it's relatively straightforward. You have a transition for HIS between non-selective and selective, or non-selective and myocardial only, and there are some pitfalls which you very nicely showed here. It's also important for LBBP, but it's a bit easier with LBBP because you don't have those transitions that follow up. You see them in the EP as your implant, because your myocardial current of injury is going to mean that you have a high myocardial capture threshold, and you may see that transition, but at follow-up, it's very rare that you see it. So then you look out really for the QR pattern in V1, but you may not always have it. So 2 reasons why you may not have, or 3 reasons for which you may not have a QR pattern in V1 is, number 1, you've had micro dislodgement and you no longer have LBB capture, or secondly, that the V1, V2 is placed too high, and that makes the R wave disappear. So be sure that it's low enough. And the third reason is that you can actually get physiological pacing, and in some cases, probably because of very fast retrograde conduction via the right bundle branch, you don't have that terminal R wave. You have a very narrow QRS that looks a little bit like his bundle pacing, and that's actually the best. So you may not necessarily have it. So with LBBP, again, it's a little bit easier to do the follow-up than with his bundle pacing.
It's quite easy to find a HIS being an EP, but then sometimes sort of real world cases, it's a bit frustrating that you see the HIS, but there is no capture or there is atrial capture. And below the tricuspid valve, and then you don't capture the HIS. So how often in your experience you actually see the HIS, but you don't capture it?
I think with HIS bundle pacing, number 1, it can be difficult to locate the HIS. Then you have to sometimes pace map to get the HIS. You don't even see the HIS potential. You pace map. The second challenge is to be able to screw the lead in there without it moving a little bit, working, rolling its way. So screwing it in, getting a stable position, getting a good threshold. That's for sure. It's, I think, the challenge with HIS bundle pacing. So it's not because you see a HIS potential that you'll necessarily be able to successfully implant that HIS bundle lead. Conversely, with LBBP, you may see an LBBP potential, and you usually get capture, but sometimes at a high threshold. So don't satisfy yourself just by seeing a fascicular potential and saying, okay, now I'm going to get good capture at a good threshold. You really need to look at the R wave peak times and see if it's different at 5 volts and 1 volt, for instance. And if you see a difference, and that your R wave peak time increases at 1 volt compared to 5 volts, you need to give it a little bit of an extra turn maybe just to get in closer contact.
Sure. We are slightly deviating here, but is it that you use just the C315 or Medtronic sheets, or do you have experience with edgeless sheets as well and the St. Jude about leads?
So yeah, C315 for the Medtronic, the 3830 is very good in the great majority. Sometimes for the HIS bundle, the C304 HIS is a deflectable sheath with the posterior curve, can be useful, but I sometimes have trouble putting in the lead past the distal curve. It sometimes gets stuck and I can't use it. Otherwise, with the stylet-driven leads, I always use the Selectra 3D, the Biotronic sheaths. I don't use the Abbott sheath, the HIS Pro, I think they call it, which is a deflectable, but it doesn't have that posterior curve, which is so important. You saw in my case, twice I had the lead going sort of anterior. In LAO, it looked like it was going into the septum, and in fact, it was coursing anterior, despite that 3D curve. So it can sometimes be a problem, and with just a 2D curve sheath, such as the Abbott sheath, I've never tried it because...
It's not easy. I've tried, but it's never easy. And also your experience with the right-sided implant.
It's a little bit tougher. It is tougher, but it's doable. You can reshape the C315 a little bit to give proximal curve, so it takes that first angle. So you put the dilator in and you stroke the sheath to give it that proximal curve, and it actually works okay. For LBBP, it's also doable, but you get a little bit less backup with those extra curves. So a little bit more difficult, but doable.
Couple of questions, Saran. First thing is, you are the right person to answer this because your paper's on septal pacing. Now, many times we get a very good narrow QRS with septal pacing. It's not consistent, very nice.
Yep.
And those, as he has also showed, there is no big difference if you can get such a thing.
Yep.
Now, actually, I mean, there's a lot of people are learning left bundle pacing with a lot of difficulty and learning curve. Now, over the years, what has been the real challenge of getting a good septal pacing? Why is it that we could not, achieve a uniform and homogeneous septal pacing, although it's as good as?
Well, I think first of all, there's a challenge in getting to the RV septum. Now we're used to looking in RAO, but for many years, people were just looking in LAO and saying this is a septum, it's going towards the spinal column. And if you look in RAO, you're actually anterior. So there's a huge heterogeneity where that lead finally was. And now we're doing it more properly with LBBP. So now we have the right orientation of what we should be using actually for septal pacing, RAO and LAO. But I think you're right. There's a sweet spot with RV septal pacing. I see this with LBB pacing sometimes. In Europe, we tend to go a little bit more in mid-septal than what the Chinese group. So I think Shanmugan also goes sometimes quite basal. Like I ended up like today, I went more basal. And when we place the lead and do pace mapping from the right side, we sometimes get, without screwing in the lead, so we're just pacing from the right ventricular mid-septum, a QR complex in V1, and an R-wave peak time of less than 70, and a narrow QRS. So you're right, sometimes with RV septal pacing, you can get an amazing QRS. I don't exactly know why. My hypothesis is if you imagine the echo that you do in the parasternal long axis, the basal septum is quite thick. You have that bulge, right? And that's where we sometimes go when we go basal with LBBP. We go into that little bulge, so you have to go in quite deep. And then the septum thins out. And if you go there, you're probably very close to the endocardium as well, and you some conduction system capture just from pacing the right side because you're very close, or your helix is in and it's actually capturing. So pacing the LV from the right side.
So can we standardize it? Can we hope, now that we know about the anatomy of the left bundle better, can we standardize the septal pacing much better?
You know, just screw it little more. That's what it's all about.
In the right place.
Yeah.
In the right place.
So I think we're still learning. We're still learning a lot.
We're not daring enough to go with like this now. All this is still driven, or we are forcing it a little deeper. That's what I think.
How many attempts would you make? Is 5 some kind of a goal? How many attempts and when would you say not more and I'll leave it at deep septal?
It really depends how important you think it is for a patient. The case we had this morning was a very good case because it was a really tough case. After the second attempt, when I was actually getting that capture with a long, and I saw the long HV, I was telling myself this is going to be very difficult. So I'm not going to struggle for ages and ages and ages because I'm just going to keep getting a bad result. So we need to find something else. And then we tried the fusion pacing, we tried bifocal RV, the LBBB plus RV. Nothing was working out, and then we went for the CS lead, and it was probably a good decision. But it all depends. How much I struggle is really going to depend how important it is to get there. And let's face it, in some cases, it doesn't really matter because the patient has sick sinus syndrome and is not going to get paced that much, and you can definitely live with a suboptimal result, but the patient still has very good RV thresholds and will be saved from syncope or what have you. And in those cases, I'm not going to struggle for ages.
No, actually, what is our approach for conduction system pacing? That is, initially go for is bundle pacing, and what is your threshold when you move over to the left bundle area pacing?
So I think it's starting off usually with LBBP now, simply because of the electrical parameters and so forth. So if I am struggling with LBBP and I'm not getting necessarily a good result in something, I would then sometimes try more proximal and for the hiss. And then sometimes you're just in there very quickly with a hiss, and then you're happy to have that as a bailout solution. Another instance where I go actually first for the hiss sometimes is when I've got a patient in atrial fibrillation and pure, and I'm trying to sure the conduction system more proximally and to do hot CRT. So really hiss optimized. So for instance, if I have a patient with pure right bundle branch block, this patient did not have pure right bundle branch block, also had left-sided conduction disease. Pace then time the RV pacing with that one with an AV delay and really narrow down the QRS complex, because the problem is not on the left side, it's on the right side. But those are rare instances. I think nowadays most of us really go for LBBP as a first option. The deflectable sheath for the hiss, the C315 works very well. And you can also reshape it a little bit. Sometimes you want to go a little bit higher, so you can reshape it. And to make it go a little bit lower, you can also use what I sometimes do also for LBBP is I use the dilator in there with the guide wire always out, just to straighten it out a little bit and to lock it into position, take it out and put the lead in there. So there are ways of playing around just with the fixed sheath. You can get to many places with just a fixed sheath. And the deflectable sheath is also a good option, but it's just that distal curve. In about half of the cases, I'm unable to get the lead past that distal curve, despite straightening out the guiding catheter from the beginning, and also I don't use it that often. Well, if the RV is very big, I don't know if the deflectable sheath works well. In those instances, I prefer to take a Selectra 3D catheter with the long curve, the 65 centimeter curve, and I can also use the 3830 lead in that one. It works very well. It gives me more reach.
Just one question. Sometimes have you found that while pacing from unipolar, when you come out and connect the box, the morphology changes?
Oh yeah. So with LBBP, it's very often that you get anodal capture. And sometimes that's a good thing, and it narrows the QRS complex, and sometimes it makes it look a little bit wider.
Even at visible voltage, sometimes you can get anodal capture.
Yeah, sometimes at working output at 2.5 volts, you get anodal capture. So for sure. And then in V1, that terminal R goes down. Yeah. So conduction system pacing in children, I think there are some few case reports out there. I don't have a big experience with this. I've done it in teenagers, but I would consider them as being adults. I think it's possible. We're probably better off there with LBBP again, just in terms of long-term. Well, there are pros and cons, because I think the big limitation with the LBBP is if you have to take that lead out one day, it's going to be very difficult. With his bundle pacing, it'll probably be easier. And there are some reports, I think Poogal Vijayaraman did a little case series of taking out the hiss, because you're just screwing in the lead a little bit more superficially into fibrous tissue. There's probably going to be relatively little scar there. Whereas with the LBBP, you're really putting into myocardium, you have a lot of scar, it's very deep, it's going to get difficult to get out. So there are pros and cons, but the long-term performance of LBBP is probably going to be better. I mean, with his, you can be very lucky and have great threshold that just stay great for years to come, as you can also have rising thresholds. So there are pros and cons with both. With children, you will obviously have to measure, you have to take into account the growth. So you will have to put a loop into the right atrium to allow for the growth, and for that, the lead won't stretch, the lead won't grow. So you need to add loops.
Is it right to say that in a teenager or in a younger, the patient selects as compared to the stylet-driven lead?
Yeah. I do. I think the luminous leads are extremely robust. They've got a fantastic long-term durability if you look at the product performance reports. And I've been implanting these leads in children for 15 years or more, since the 3830 came out, and in Gooch patients, complex anatomy. So it's a very good lead. I sometimes do have rises in threshold, but it's probably due to a maturation process and a fibrotic process rather than actual lead damage. So it's very rare to have a damaged lead with those leads. And the other great thing with those leads is that they're just so flexible.
Yes.
So you imagine the impingement on the tricuspid valve, for instance. I've never had a case of SVC syndrome or anything like that in children with that very thin lead, whereas I've seen this happen with standard pacing leads, some catastrophes with pacing in children.
Thanks.
Yeah. So microdislodgement is quite a big, I think it's underreported. It's underreported, and you see that by the loss of the R wave in V1, sometimes in a broadening of the QRS complex. It's something which needs to be systematically followed up. I think that the important thing is recognizing at implantation that the question is, why does microdislodgement occur? And I think most often there are two reasons. One is that you may have a microperforation. That's to say, like the case that we had today, initially I think I had a microperforation. I saw the current of injury going down, and then the thresholds later on went up. So the screw is no longer keeping really the lead in place. It may then withdraw or go forward and have an overt perforation. So you need to recognize the microperforation and say, I'm not leaving my lead in there, even though it's a good capture threshold. It may be good, but then the lead is not held there and it'll go back. And the second big reason is the drill effect that Marek Jelszewski described in the cadaver model, where your lead is basically being pushed in. You're just pushing it in. The screw is not, biting in and pulling the lead behind it. You're just pushing the lead in, and then you're creating a tunnel. And if you pull on the lead, it comes out very easily. It's not stable in there. So if I'm struggling to get my lead, it's not going in smoothly, I don't insist, because I'm going to have a drill effect and then I'm worried about the microdislodgements afterwards. The other thing is I check, recheck, re-recheck, re-recheck all the time to make sure if I have a fascicular potential, I want to see that fascicular potential until the moment I'm going to connect the lead to the box. Because if I lose fascicular potential, that means that the lead is no longer in exactly the same place. And I also very carefully looked at the PACE-QRS complex from the beginning to the end and make sure that I always get the conduction system capture, because if you're losing that, that means that the lead has withdrawn a little bit. You don't see it on the X-ray, but you see it by the end result.
So we'll call Vivek now.
So the entrapment of the septal leaflet, strangely, extremely, I haven't had this, which is very strange. You would really expect it to happen, and I was a little bit scared of this when I started doing. Yeah, it just doesn't seem to be a problem. I think it's more a problem of entrapment in the endocardial tissue, where you have the entanglement effect, and then you pull, and you can't get it out. You even pull the lead, you're almost in the right ventricle, in the right atrium. But I've never had actually a tricuspid valve damage by putting in the lead there. Strangely enough, I think somehow probably we get into a cleft, and maybe, even if you may be pinning it, the septal leaflet with the contractions just works its way free, and you're up against the myocardium. What we have seen, though, what's been described is tricuspid valve regurgitation, which is maybe a little bit more with a more base position of LVBP compared to a little bit more mid-ventricular position, but the difference is not huge. With his bundle pacing, especially if you're on the atrial aspect, there's absolutely no impingement on the tricuspid valve.
So we'll move on to the next talk.
I take this opportunity to thank Dr. Kartikeya Bhargava for his wonderfully informative talk on PACE QRS morphology in physiological pacing. Moving on to the second session, we begin the second session by inviting the esteemed members of the chair, Dr. Ashish Nabar and Dr. Haigrav Rao. I also take this opportunity to call upon Dr. Vivek Chaturvedi, Senior Consultant Cardiology and Director Cardiac Electrophysiology from the GB Pant Hospital, New Delhi, for his presentation. Welcome, sir.
Thank you so much. And I would like to thank Dr. Ulhas for this wonderful opportunity for me to learn more than present here, really. So I start with a case vignette, which is a typical problems you face in such patients. So this was a 75-year-old practicing gynecologist from a remote area in Bihar. And she has had twice, she has had AF ablation. And sometimes, second time, there were additional lines. Sometimes there were additional lines, second time were also put on it. But now, after 3 years of the last ablation, she had effort intolerance and persistent heart rate above the rate of 100. And this was on escalating dosages of diltiazem, beta blocker, and ivabradine. Her ECG actually showed atrial flutter with 2:1 response. She had a largish LA with a good LV function. So since she has had problems with GA the last time she was ablated, so I took her up for an ablation under sedation. But as sometimes you face it, there were too much scar in the LA and there were too many confusing colors. The left side was reconnected, so I did isolate that again, but abandoned further efforts because she was getting very restless without a GA. So diagnosis of intractable atrial arrhythmia was made with heart failure and preserved ejection fraction. And she wasn't willing for a cardioversion and amio, so we went ahead and decided about AV node ablation and a CSP. So we did an AV node ablation from the femoral root. And then we followed this with an LVP, where again I had a misadventure because as you can see here, the first time I did it, it went straight into and perforated as okay. So the perforation into the LV side, but eventually I got it there and got it reasonable looking complex. I had a decent result, but second day of post-op she had severe dyspnea on getting mobilized. And X-ray showed marked PVH, so made a diagnosis of stiff LA syndrome, which is well known after multiple ablations in this population. And she responded well to a small dose of furosemide and has been doing well since then. So atrial fibrillation is a frequent cause of resistant heart failure, whether it's reduced ejection fraction or preserved ejection fraction. And heart failure also causes an increased sympathetic drive, causing heart failure, causing atrial fibrillation to become more symptomatic in terms of intolerant heart rates. And while drugs and ablation do help a lot, a stage comes when the patient says no more, I can't take more of drugs and I don't want to have more ablations. So in that case, we go ahead with the final destination kind of therapy for intractable AF, which is the AV node ablation. AV node ablation has been done for more than 25 years, I think now, for this indication, and along with simple right ventricular apical pacing, which helped these patients a lot for symptoms, but a large meta-analysis found that there was no difference in mortality or ejection fraction or exercise duration. Symptoms did improve though. And that made a lot of people think that if there is so much improvement in symptoms and the rate is getting regular, then why isn't the hard endpoints getting affected in these people? And so, because, like what I said, that the rate reduction and regularization of heart rate should benefit at least patients who have LV dysfunction, but it was not happening. And that's why people thought that we must compare this to a biventricular pacing, which again showed some improvement in ejection fraction if you had an LV dysfunction to begin with. A lot of improvement in symptoms and hospitalization for heart failure, but again, mortality was not affected when you compared this to the CRT. So then Brignol from Italy, he started with the APAF CRT trial, which had 2 arms, consecutively reported. One was the morbidity arm and then the mortality arm. The morbidity arm, as usual, showed that there was significant improvement in the morbidity. But what was more surprising was the results of the mortality arm. And although it's a smallish trial, it clearly showed that as compared to no intervention, that is no apical pacing, just simply drugs versus CRT in a patient who typically is very symptomatic for AF, very symptomatic for heart failure, has a narrow QRS. If you ablate their AV node and put a CRT in, there is a huge mortality benefit. And this happens irrespective of the baseline ejection fraction. So the latter part may be contentious, but what this does show is that in retrospect, if you extrapolate it back, you realize that this benefit is seen now because the RV apical pacing may actually be negating the benefit of AV nodal ablation, because you do a good thing, but then you add something which is deleterious. So if you take that deleterious thing away, then maybe it's a good strategy for the AF patients to be subjected to an AV node ablation along with pacing. But there are problems with BIV pacing, and we all know that. There's an extra lead, it costs more. They are frequently very poor vein targets, and then we do know that it's inherently unphysiological, because rather than one simple waveform proceeding down, you have now 2 colliding waveforms from different parts. So it's not physiological. And then there is still a question of whether it would help people who have a preserved ejection fraction and people who have a narrow QRS, because these are the 2 things which traditionally have not been associated with improvement when a BIV resynchronization device has been used. Now, almost from the same time when the BIV was being used, the HIS system pacing started, and we saw this slide earlier too, when Deshmukh et al. Showed that in this particular subset again of refractory AF with heart failure, he subjected them to AV node ablation and this kind of HIS bundle pacing with beautiful looking ECG for these patients, and they also did dramatically well in the long run. Again, it was a small study. And since then, we have come a long way, but if you realize, somehow because of lack of large randomized data, the HIS bundle pacing and the left bundle pacing are still occupying a lower rung of recommendation as compared to BIV. And that's probably got to do because the long-term data is still not there. So we all already know, and this Karthik has shown you the spectrum of conduction system pacing. So the conduction system pacing for AV node ablation started with HIS bundle as is expected, and this is one of the few studies with quite a reasonably long-term data which showed that although I could not find how many of these patients actually had additional RV leads, but Dr. Burry tells me that pretty much everybody in the West would get additional RV lead if you are burning the AV node. But the good thing here was that there was no lead displacement in this particular study. There was a rise in threshold in a minority, and the LV ejection fraction improved spectacularly in this particular subset of patients who had undergone an AV node ablation along with the HIS system in place for the pacing. And then, so then obviously the question comes is whether which of them is better, whether CSP is the place to go in, or BIV still has a role. And we have had this recent publication from Dr. Vijayaraman, and it's a multi-center collaborative study for about 110 implants inside, with 34 with RV backup lead in the CS pacing side. And that's because the group actually was predominantly his to begin with, but then moved on to left bundle for most of these. So that's why I think probably the his ones, most of them were with the RV backup lead. And then they actually clubbed RV apical pacing and BIV pacing as a group called conventional pacing. So we have 56 patients with RV pacing leads and 57 with BIV pacing leads. EF about 43% mean, and QRS was also narrow at 113 of mean. And what they were able to show was that the conduction system pacing fared better in terms of combined endpoint typical for any heart failure study, which is death or heart failure hospitalization. And then during the subgroup, they found that in patients who had LV dysfunction, CSP actually fared better than biventricular pacing. And similarly, they showed that the QRS duration achieved was less, and the ejection fraction also increased more. However, if you look into the details of the study, you do realize that suddenly, things are different. The baseline QRS was about 140 in the BIV patients. And you would expect, because most of the investigators would feel comfortable putting in a BIV lead if the QRS is in fact wide, while it was not so for the other ones. Similarly, the starting EF was quite low in the BIV cases, as you can again see, that something like 28% EF in the BIV cases, while it was well above 40 for almost everything. So that makes you think whether this conclusion of CSP is better than BIV in this study is actually valid, because it's comparing apples and pears. Having said that, one can make this kind of a conclusion that conduction system pacing actually works pretty much across the spectrum, whether you have a narrow QRS or a wide QRS, while a BIV device in this setting is also expected to work, but probably would be better in patients who are already having a broad QRS to begin with. Although the APEF CRT trial did show that it did good even with narrow QRS. And then there is this small study which is again compared these two therapies and found again that BIV was actually causing a reduction in the EF, which is very surprising. But one can understand that if you realize that their paced QRS after BIV was 170. So I could not find the paced QRS in other studies, but clearly there is something wrong in the way BIV was implanted in this study, because if you increase it from 100 to 170, I don't expect EF to improve in these patients at all. So then the other important group is because a lot of these patients are actually undergoing an ICD implantation, and this was an important study by Wong et al., where patients who had an indication for an ICD and who had AF with symptoms were randomized into a traditional ICD implantation or his Purkinje system pacing with AV node ablation. And there was a clear-cut, I think one big finding which they had, which has a lot of relevance for our clinical practice, is that the inappropriate shocks were dramatically reduced when you did the AV node ablation with his Purkinje system in this particular setting. And similarly, the EF improved irrespective of whether you had systolic dysfunction to begin with in terms of significant systolic dysfunction. So then the question arises is whether you should go ahead and do a his bundle pacing or do a left bundle pacing. So, I mean, it's understandable that there are problems with his Purkinje system in this particular setting. So this study, which was, I think, in the HRS at some point, showed that when people were taken up for AV node ablation later, after the pacing had been done, you found it difficult to ablate because of the lead positioning and trying to get a good place, which ended up requiring, actually influencing your success rate and increasing the procedure time also. And so this is a recent study, just came out, I think, in Heart Rhythm, of comparing both, and it found that
besides a more arduous procedure for his bundle pacing in these patients, there is the problem of rise in the thresholds and significant number requiring an additional lead and extraction, etc., which concludes that obviously for this particular indication, that is AV node ablation, you are better off with a left bundle lead as compared to a his bundle lead. So then what is clear from the evidence I have presented so far is that we don't have too much data in terms of numbers for the different pacing modalities when it comes to this particular subset of AV nodal ablation. It's a different subset because unlike a person with wide QRS or a sick sinus, this is somebody in whom you have actually created an AV block. There may or may not be dyssynchrony in the LV to begin with. So let's look at data from some other things which might help us and make a decision. So this is a network meta-analysis of more than 2,000 patients. And we can clearly see that the QRS duration reduction is maximum with his bundle and left bundle. It is far more superior to a bi-V case. And in a similar vein, if you look at the outcome data in terms of ejection fraction, while it's not very impressive across the board, but if you compare left bundle area to right ventricular septal pacing, there is a trend towards increase in EF, and there is a trend towards decrease in EF with right ventricular apical pacing. So then coming to some other type of problems that we encounter and dilemmas that we have for AV node ablation and pacing. So the timing has conventionally what's happened has been that one would implant the pacemaker and then bring back the patient after maybe 2 to 3 weeks for a AV node ablation. But in the current times, I think most of the operators have moved towards concurrent, either on the same sitting or maybe the next day for AV nodal ablation. Then the question arises, from where are you ablating the AV node? Is it from the femoral or axillary? I mean, I feel more comfortable doing it from femoral because I think the number of AV node ablations we do in India are far less as compared to other places, so our overall volume is less. So I feel comfortable doing it from the femoral, but US, the data, there is a large body now that axillary route is as good, and you end up using the same intravascular access for both. And then the type of device then again depends. You can use a simple dual chamber pacemaker. You could use a dual chamber ICD or a CRT box. That depends on whether the need for a defibrillator is there or no. So to sum it all up, what I could gather from this search into the data is definitely we should abandon RV apical pacing as a method of pacing after AV node ablation. I don't think it serves any purpose. Left bundle area pacing probably is the way forward in terms of minimum number of hardware used with a good outcome, because as we just discussed and Karthik also showed that even if you are in the left septal area, I think it's a reasonably good decision. Alternative can be a bi-V pacing, especially if you have a left bundle branch block at baseline with low EF, or if you are not able to enter the left bundle area through the septal pacing. LOT CRT is another option. And another important thing is that I think because we have such good hardware now, AV node ablation should play an increasing role in management of AF with patients with heart failure. Thank you.
Vivek, great presentation. Can we sum up that post-AF ablation for permanent AF, if somebody has HFpEF or HF mid-range ejection fraction, you would get away with the left bundle area pacing. And if somebody has HFrEF, you would study it in terms of the initial QRS and maybe the scar burden by maybe MRI, and then decide whether it should be a LOT CRT. Rather than a bi-V pacing, and probably certainly not left bundle only.
Yes, so I completely agree with you there that patient who has reasonably preserved ejection fraction can get away with just a single lead for the left bundle, and that helps you decide in terms of hardware selection to begin with. Somebody who has a reduced ejection fraction in today's era, as we saw in the case today, I think one has to go with an open mind inside and take it as it way. His bundle pacing per se, I would probably not be keen at all in this particular subset of patients who have an AV node, because you are ablating near about the same area where, because the patient is completely dependent on this, you need to have a backup lead, which I think this whole thing can be entirely averted by just putting a lead deep inside the septum.
Haran, your impressions?
Yeah, so I no longer do his bundle pacing if I'm going to ablate the AV node, because there is a risk of increasing the thresholds. We tried cryoablation as well, maybe thinking it's going to be more reversible, but it doesn't work. We still have to sometimes sacrifice the his lead, so I think definitely LBBP is the way forward there.
Sir, I'll just make one comment about doing the AV node ablation from the axillary vein, because I've worked in US. There the practice is that they try to ablate the AV node and implant the device same time. But that's not the case in Europe, where in sort of UK, we implant the device first, wait for 6 weeks, make sure there's no problem. So same in India as well. I think we can't do both at the same time, because you're going to run into trouble if there is some problem with the device later.
I disagree. I mean, that was my practice too earlier, but of late, the ones I've done more with BIV than with left bundle, to be very frank. But either ways, I do it in the same setting now.
Yeah, BIV is okay.
I think that's now I think the routinely same time. So we'll move on to the great lecture coming up. Our master Shanmuga Sundaram is going to be.
Yeah, only thing, Ullas, the concern is only about the lead dislodgement in case you implant it simultaneously. Do the procedure.
And that's okay. I mean,
economics nowadays don't really help you a lot in taking two procedures. You can convince the hospital to charge less.
I think at the end of the procedure, I think you are fairly certain in how the lead is going to behave. And so I do not think we put even a temporary pacemaker as a backup for 24 hours.
I do the ablation first and then I do the pacing.
Yeah, true. I think that is also
because you can do all the capture confirmation criteria, especially with left bundle, you can get the potentials. Many of the patients will be having a narrow QR. So you can confirm the capture and the lead will be far away.
I agree. If I had your expertise, I would do that. But,
no,
it helps actually.
No, but that's the standard.
Yeah.
In case, especially when there's a narrow QRS, I think, and then you are already determined to do the connection system pacing. Yeah, you put the lead, then ablate. Yes, sir.
Thank you, sir, for sharing your knowledge with us. I cordially invite Dr. Shanmuga Sundaram, interventional cardiologist and electrophysiologist from Velamal Medical Hospital and Research Institute, Madurai, to talk about device for heart failure where CS leads no more needed. We welcome you, sir.
Good afternoon, everyone. I think it's going to be the lunch time, so I'll not take more than 15 or 20 minutes to finish off the session. It's customary to say disclosure before starting any presentation, so my only disclosure is I'm biased. So what is the concept of doing conduction system pacing for patients with heart failure? The concept is the same, longitudinal dissociation of fibers inside the his bundle. So if you have any segmental disease inside the his bundle, be it on the fibers on the left bundle or be it on the fibers committed towards right bundle. You can have either left bundle branch block morphology or right bundle branch block morphology. So ultimately, if you are going to pace the lead distal to the site of block, which you can very well identify by doing a good pace mapping, either it in the distal east bundle or in the proximal left bundle. So you will ultimately end up in narrowing down the white QRS and giving maximum benefit for the patient. This is almost equal to a surgeon putting a Lima graft for a proximal LAD stenosis, where you just have to identify the site of block and attach the artery to distal to the site of block. So let us take an example of a patient, a female patient, a non-ischemic cardiomyopathy, normal coronaries, female, white QRS, LBBB. So this particular lady had a QRS duration of close to 150-60 milliseconds, and his bundle pacing was done. And no need to explain, once you get such a good QRS, ultimately you will end up in normalizing the left ventricle. So what happened inside the lab? So we usually place 2 catheters from the groin. That is our customary practice to do his bundle or left bundle branch pacing. So one will be in the his bundles and the second one will be in the RV apex. The baseline HV interval for this lady was 85 milliseconds. So you can very well see the prolonged HV. And all I have to do is just take the lead to the site where the HV was normal. So once I identify a site with a normal HV, I know that if I'm going to deploy the lead there, I'll be able to correct the QRS. So this same principle applies well for even patients with the right bundle branch blocks. This is one such patient where he had a near normalization of a right bundle branch block with his bundle pacing. So once you normalize the QRS, you know that the patient is going to have a synchronized activation of the ventricle, and they'll have improvement in LV ejection fraction. Of course, the latest published ESC guidelines, they have recommended his bundle pacing, not as a primary approach, but as a bailout strategy, and in patients where we can expect some suboptimal response from conventional bi-V pacing. Coming to the left bundle branch pacing. So I'm not going to discuss about the procedural details. I'm going to discuss about 2 categories where CRT by left bundle branch pacing may be as good as bi-V therapy, and CRT by left bundle branch pacing where we can expect a better response than a conventional bi-V therapy. So a typical example, Strauss criteria fitting LBBB, normal coronary, severe LV dysfunction. So once you do a good left bundle branch area pacing or a left bundle branch pacing, and once you optimize the AV delay and output to utilize the anodal capture and native AV nodal conductions, you'll be able to normalize the QRS. Let us say what studies say. So this is our collaborative study which showed that both in patients with an ischemic and non-ischemic cardiomyopathy, both in patients with an underlying LBBB and non-LB morphology, we could show reduction in QRS duration, we could show improvement in LV function, and we could show improvement in NYHA functional class. Similarly, the master, Dr. Wong, so he has shown that he has specifically chosen patients with a non-ischemic cardiomyopathy, fitting in Strauss criteria, where he had shown almost 75% of the patient had normalization of LV function at the end of 12 months. So this is too quick when you see in terms of response to therapy as compared to bi-V therapy, and too large when you see this normalization rate. Normalization rate 75% at the end of 12 months, I don't know, it can hardly see in patients who are undergoing a conventional bi-V therapy. Similarly, we have identified a specific subset of patient where we label it as LBBB-induced cardiomyopathy. So where LBBB was diagnosed, and we have documented that the LV function was normal. Over a period of 3 to 4 years follow-up, we could track them that the LV had come down. And once we did left bundle branch pacing in these patients, we could show that almost all of them had an improvement in the LV ejection fraction, and almost 100% of them had normalization of LV function over a period of 3 to 6 months. So if you choose this particular specific criteria of the patient, all you have to do is do a good left bundle branch pacing, connect a dual chamber pacemaker. You can see as good as or a better response as compared to a conventional bi-V therapy. Let us move on to the second category, which is of course a category of interest. CRT by LVBP better than bi-V therapy. Remember, I put a small note, so there is no direct head-to-head comparison available. So let us see what happened while you are doing a 3D mapping. This cartoon I've shown it yesterday. So this right one is a patient with an LBBB-LV dysfunction, where you can see the activation starts from the distal RV, then it connects to the LV from the distal aspect of the left ventricle. So that is how the breakthrough occurs. The breakthrough occurs from the right side to left side. Either it can occur at the proximal septum or in the distal septum. Many times it occurs with the distal septum. So that is the reason why we are seeing most of the patients with the LBB are having a
left axis deviation. So usually it connects to the LV at the distal aspect. From there, the LV activation occurs. So once it reaches the LV free wall, it is almost always some 70 to 100 milliseconds delayed as compared to the septal activation. So you'll be having a desynchronous activation. So what happens after left bundle pacing? So after left bundle pacing, so after left bundle pacing, as expected, the activation will start from the left bundle pacing lead. And you can see the first site to get activated is the area where the left bundle lead is, and from there the impulse will start activating the whole of the left ventricle. Let us see the activation map. So even you can delineate the fascicular fibers, how it gets activated when you're carefully following the activation pattern. So image credit goes to Sabari, who was helped us in getting these images. So this cannot be, I can tell you, this pattern of activation, you cannot get it from a conventional BIV therapy. So in terms of electrical resynchronization, you can get a much better response so when you are doing a conduction system pacing as compared to a conventional BIV pacing. Let us come to abnormal axis. We have talked about the response to CRT. Suboptimal response will be there in patients who are having an extremes of axis, whether it is in the northwest axis, left axis, or right axis. So this particular therapy, whether it is a his bundle pacing or a proximal left bundle pacing, you'll be able to correct the axis, especially when you are capturing the proximal left bundle. So what happens when you are correcting the axis, the response will be equally good as compared to those patients with an abnormal axis. So what we could show was even in those patients with the baseline left axis, the axis could be normalized in 75% of the patient. And once you normalize the axis, the response rate is not as different as compared to those with the BIV therapy. So that is the idea of going into the proximal bundle. Like, of course, there is a debate of capturing the proximal left bundle versus capturing the distal fascicles, but our idea is always to go for capturing the proximal left bundle. Let us come to the other area, again a matter of debate, left bundle branch pacing for a conventional RBVV. So we always start from the groin to look for the HV intervals. If in a patient with a right bundle branch block, if the HV is prolonged, especially with the left axis, we can usually understand that there is some sort of conduction system disease. So once you're able to do a good left bundle branch pacing, entering directly into the left bundle, you'll be able to get a good narrow QRS. So this is our study. So though the QRS reduction was not very dramatic, the reduction was from 156 milliseconds to 150 milliseconds, but still the response occurred. The patient had a significant improvement in LV ejection fraction and significant improvement in NYHA functional class. So even in patients with the right bundle branch block, of course, one can go for a conduction system pacing. So if there is a suboptimal correction like it happened in the morning's case, you can always put a lead in the CS to go for a LOT or HOT CRT. Acute benefits. Again, acute benefits of resynchronization rarely can be seen with the BIV therapy, but it's very well obvious in patients with the conduction system therapy, conduction system pacing, both in terms of mechanical as well as electrical problems. So these two pictures were taken at an interval of just 10 days. So this one before pacing and that one after pacing. You can see how good the LV contractility has increased just within a matter of 10 days. Similarly, you can see a functional improvement in mitral regurgitation as early as 10 to 14 days. So this patient had a significant mitral regurgitation, just underwent a dual chamber pacer, left bundle branch pacing, and a period of 10 to 14 days, you can see how beautifully the MR has come down. So what we have shown was we have classified those patients into two categories, those with a mild MR, those with a significantly severe MR. And all these patients were followed up over a mean period of 12 months. And we could show that in patients who are undergoing a left bundle branch pacing, the severity of MR can be reduced up to 82%. So once the severity of MR has come down, the patients will have so much reduction, dramatic reduction in the symptoms. Even we could document that the BNP levels, both at baseline and during follow-up, have shown significant reduction, which translates into improvement in the NYHA functional labs. Of course, we don't do this so too often in our lab, but still, if you are doing it with a perfect left bundle branch pacing, you almost always see a synchronized activation of both septum as well as the lateral wall. Coming to a big dilated LV, so this particular patient had a very huge LV internal dimension of almost close to 84 millimeter. We know that the larger the LV, the response to BIV comes down. So this particular patient had a QRS duration of almost 220 milliseconds. But the only problem is this QRS was so generous to have it to 220 milliseconds, but he didn't have money for getting a BIV therapy. So we had to put a dual chamber pacer, and this is what I got. So we had a selective, non-selective to selective transition during implantation. This was the best QRS I could get after the procedure. Surprisingly, after 1.5 years, this is how his LV was. You can see how beautifully the LV has come down. So just for comparison, so this is the one with the baseline. This is after 1.5 years. You could see how beautifully the improvement is. So this actually told us that the PACE QRS duration is not the only criteria which will determine the procedural outcome. So you just have to confirm that you captured the left bundle. If you feel that the LVAT is not optimal, then you probably can put an additional lead in the coronary sinus to make it as a lot or heart CRT. But the overall, the prolonged the QRS duration alone should not be the determining factor to decide the outcome. Of course, for pacing-induced cardiomyopathy, the idea is to recognize this entirety at the earliest, once the patient had a fall in EF of less than 50%. So it is like once they had a fall in EF of less than 50%, ultimately they'll have further deterioration of EF. So once you identify them at an early stage, before the LV goes for a big dilatation, before it goes for a fibrosis, all you have to do is just pull out the lead from the right ventricle and put the lead in the left bundle area and use the same pulse generator. So that helps in conserving the money and just utilizing the same pulse generator. All you have to do is just change the lead position. Of course, in pediatric patients, just we had a discussion of pediatric left bundle branch pacing. This particular kid had was listed for a transplant for a pacing-induced cardiomyopathy. 4-year-old kid, underwent surgery for VST, developed a complete heart block, underwent an epicardial pacing, developed LV dysfunction, weighing around some 8.9 kg on venti, and we just had a discussion whether a left bundle branch will help or not. The septal thickness was 7 millimeter by echocardiography. So we thought before subjecting the kid for a transplant, why can't we do a left bundle pacing? And we got a reasonably good result with a QRS duration of 96 milliseconds. And all this during follow-up, at the end of 6 months, the baby had a significant improvement in LV function to 31% and no further episodes of heart failure. Till date, the baby is doing really good. So even in pediatric population, you can do a left bundle branch pacing. There is a case series from China regarding left bundle branch pacing in pediatric population. So all you need to know is the septal thickness. So if you feel that the septal thickness is very suboptimal for doing a procedure, you can deploy the lead obliquely. So this particular kid, what I did was, after giving one turn, I just pulled the sheath little back so that I could deploy the lead little obliquely to deploy additional length of the lead inside the septum. So even in pediatric patients, if the septum is not scarred, you can deploy the lead little obliquely to get additional length of the lead inside the septum. Of course, in patients who are BIV non-responders or CS failure, so this is an excellent strategy to salvage the patient out of the heart failure. So this was this year's lead breaking trial. Of course, CS lead is not an enemy for us, so you can get the help of a CS lead whenever you have a suboptimal correction. So this particular patient had a suboptimal correction with the left bundle branch pacing alone, so you had to put a lead in the CS to fuse it together to get a good lot CRT paced ECG. So again, it's not like an enemy to dislike, so you always get the help of this CS lead whenever you find that the results are suboptimal, so that you can give a better possible resynchronization therapy for the patient. The advantages of conduction system pacing, like we are discussing, you can use a single lead, you can use a dual lead, you can use a triple lead, or even a quadruple lead to convert a patient from a wide QRS to a narrow QRS. Remember, you can have a loss of R wave during follow-up, that's what we were discussing. So the incidence is with the 3830 lead, it's less, it's around 4.6%. This is our single center experience. So what we found out was, whenever you are going to demonstrate a non-selective to selective capture transition at implantation, that's going to tell you that the patient will have a consistent capture. The incidence of loss of capture will be less. And more the number of attempts, the more the tendency for going for a loss of capture. The need for redo procedure was only meager, only 5%, 5 patients had undergone a redo procedure. And remember, the most common dislodgements occurred after 6 weeks. So you have to follow them carefully to look for a late lead micro dislodgement, which could produce this loss of R wave. But what about the guidelines says? I think yesterday Dr. Bure was discussing about the guidelines. As of now, they have given some encouraging statement about left bundle branch pacing, but they said they are not going to recommend it because there is no randomized trial available. So once with the availability of randomized trial, probably in the next 2 or 3 years, we'll be getting a good position for left bundle branch pacing in terms of an alternative for cardiac resynchronization therapy.
So till then, probably you can use it as a workhorse strategy or a standalone strategy or a backup strategy depending upon one's own convenience. So this is our strategy. So CSP with the dual chamber pacemaker in patients with an AV block with LV of less than 50%, in patients with a non-ischemic cardiomyopathy with a white QRS, whether it can be an LVV or RBVB. For patients with a pacing-induced cardiomyopathy, remember, identify this pacing-induced cardiomyopathy at the earliest so that you can just use a single lead, a single additional lead, pull out the RV lead, put an additional lead in the left bundle and connect it to the same dual chamber pacer. And AF with fast ventricular rate. I think previous session Dr. Vivek has described it beautifully. But in patients with an ischemic cardiomyopathy with a white QRS, keep a CS lead backup, always explain the patient that they may need an additional CS lead in patients with IVCD and in patients with a non-ischemic cardiomyopathy where there will be a suboptimal correction by conduction system pacing. So let's wait for another 2 years to get into the guidelines. Till then, we can keep our faith on conduction system pacing. Thank you.
It's a very comprehensive presentation of the whole indications. Now, one thing I was seeing, particularly, you may have done it, but specifically I wanted to ask you, what about non-responders to CRT? In such cases, because non-response could be various reasons, but in your data, have cases where non-responders to CRT and you have used?
So that was our last year's late breakers. It's this year's late breaker where it was a multi-center study. Yeah. So they do well. We don't know the exact reason for the non-responsiveness of a CRT. And this includes patients whom there was a CS cannulation failure also. So this includes both patients where there was a failure of the procedure per se and the failure of the response. So this includes both. And even in these patients, the ones you do a good left bundle branch pacing, definitely they'll respond, sir.
Yeah. No, but separating them, those patients who have had a CRT, who are improved over the follow-up, you did not see them response. Yeah. Not about a CS failures. Separately, have they been analyzed? Only patients who are non-responders to CRT.
Yeah, this particular article had a subgroup analysis of those patients who had a CS failure, cannulation failure, as well as those patients who had a CRT failure.
In this article, were there patients who were responders and then lost the response and that you added a...
No.
Okay. So 2 questions. Even in my left bundle pacing, and I saw some of your ECGs post left bundle pacing, the QT in the precordial leads particularly looks really ghastly.
Yeah.
And is there any hazard associated with in your experience?
In fact, in our left bundle branch, that paper on LBB-induced cardiomyopathy, we had put a picture on this QT interval. In fact, we had briefly mentioned about the TPT parameters also. So usually measure it at the end of 6 weeks, it will be normalized. Immediate post-implantation will be prolonged, but it doesn't produce any arrhythmia. So far, we never had any patients developing an arrhythmia, but usually it will be prolonged in the immediate post-op period. That's what we usually call it as a memory T wave. And at the end of 6 months, 6 weeks, it usually gets normalized.
No need to keep a higher rate or something like you do in post-AV node ablation.
Nothing. Post-AV node ablation, of course, yes.
Yeah, just
post-AV node ablation, in fact, I had a case where after deploying the lead in the left bundle, I have ablated it. And I usually deploy the lead, ablate, and then go up and close the pocket. That's my procedure. So while closing the pocket, the patient again had a recurrence of AV nodal conduction. So I went back and ablated it. This time I was make sure that it should not recur. So I waited with the keeping the backup rate at 30. Within few minutes, the patient had thrown my polymorphic VT. So I had to defibrillate. I had to keep the pacing rate at 90 for almost 2 months. So that's our practice. Keep at 80 for 2 months. Then you can come down in the pacing rate.
There would be a very small group of HFpEF patients who show echocardiographic dyssynchrony, but yet don't have a wide QRS. Is there a role for conduction system pacing? Answer from you as well as Haran.
So I'm not sure. There is a study which is going on for ismonal pacing with a prolonged PR, but this particular subset, I think Dr. Haran can answer.
No, I don't think so. I'm just questioning the ability of echocardiography to really
diagnose dyssynchrony also in these patients. So is it what we're seeing really dyssynchrony? I don't think so.
But when it is very clear that the reduced ejection fraction
Yes.
and narrow QRS,
Yes.
nothing worked.
Yeah.
Yeah, so
You have a higher NYHA class and you have a dyssynchrony. Are you tempted to do something with the conduction system?
no,
pacing or it
I'm very tempted to do a good optimal medical management.
Always.
Always. So narrow QRS, even if the echocardiographer says there's a dyssynchrony, I think it had been shown devices won't work. I think that will be the same.
130 plus with STRAS criteria, I'll always put. 130 plus with the STRAS criteria.
As usual, excellent presentation. Is there any limit of the IVS thickness?
Yeah, that's what
below
I'm telling
which
you.
we should
There
not
is
go
no scar.
or increase in the thickness? Thickness.
So you can
beyond
deploy
which
even in hypertrophic cardiomyopathy patient. I've done a septum with a 24 millimeter. I've done a septum with 6 millimeter. So all you've done, you have to modify the procedure accordingly. If it is too deep, then you have to go deploy additional length of lead. Probably the whole anode will be buried inside. If it is too thin, only thing is that there should not be any scar. So interval MI with a scar septum of even 7-8 millimeter, the lead will not go. But a kid with a septum of 7 millimeter, usually it goes. But our practice is to go little obliquely so that additional length will be deployed to get the stability.
Thank you.
Go now.
Yeah, people are coming out with a lead with a longer helix, not with a shorter helix. So I think longer helix lead to get into the septum to get into the left bundle branch area easily. All these things are under experimentation. We don't know. Probably in the near future, we may get a still better lead for doing a left bundle branch pacing.
Thank you very much. And before we disperse for lunch, I take pleasure to introduce my colleague, Dr. Anindya, who is the right hand and the backbone of our department, so who actually ably assisted, I'm sure, Haran. He is going to be presenting the beautiful work they completed in the morning. They are going to show you the final pictures on the fluoro and the ECG. And I think you are the right person to show that. And after that, we disperse for the lunch.
How can I move? Okay, it's okay. So this is the ECG of the patient we just had in the lab as the first case. Haranburi sir had started the case with this ECG. The patient had an ischemic cardiomyopathy, which was a status post CABG, which was more than 14 years. There was an RBBB with a leftward axis and a prolonged PR, and a full PR. We were thinking that we would start with a conduction system lead in the left bundle, and that would suffice. At most, a dual chamber ICD with a LB left bundle branch alone pacing would be okay for the patient. But what we encountered was a significant conduction disease in the interventricular septum with the left his coming. There is an intrahesian delay, so that the RBBB was more at the level of the his, and plus there was some intramyocardial delay also. We could not get a narrow QRS, let alone a QR with the left bundle branch alone pacing. The QRS duration with left bundle branch pacing was around 180 milliseconds. Then what we did was we thought we could fuse the left bundle branch area pacing morphology with the intrinsic QRS. We went ahead with the atrial lead. We put the RV coil lead as well in the RV apex. We saw in all configurations. We made the AV delay pre-excited from the intrinsic PR by 40 milliseconds, 30 milliseconds, 50, 60 milliseconds. All of them led to a QRS morphology which was not physiological. There was still notching in the V1 with the QS morphology. The QRS duration was nowhere less than 160 milliseconds. So we ultimately decided to put the CS lead. After putting in the CS lead in posterolateral vein, when we fused it with the left bundle branch pacing morphology, we got this, the final result. There is no fusion with the intrinsic. The AV delay has been kept at the sense AV delay of 160 and paged of 140. And this looks as good as any other case with a normal heart and maybe a CHB with a conduction system block in the intrinsic conduction system. So it's like a QR in V1. This is in DDD mode with an AV delay of what I mentioned, with a simultaneous left bundle branch pacing and pacing from the LV lead, LV2 to RV coil. The final lead positions are these. So we can see there are so many leads which are jumbled up. The RV coil pace sense has been capped. So it's a quadripolar CRTD device. The ATI is in the atrial port. The left bundle is in the pace sense of the RV. The high voltage coil goes into that respective port, and the LV lead is in the respective port.
Anindya, would you like to show us the ECG again? You know, there had been some change in the morphology. How are you explaining that? For example, when you look at the lateral leads, V5, V6.
So what we got with left bundle branch pacing was definitely a QR, but it was wide.
Yeah, no, I just was thinking, is the output require some setting here? There are a few beats which are losing.
So was it, yeah, there's just like one QRS towards the end.
The thresholds
a little bit different.
All of the thresholds are less than
were
1.
good. I mean, I think the LV threshold was less than 1. I would program it in bipolar because then the impedance will be a bit higher, and then the battery longevity would be a little bit higher as well.
Tested in the lab in unipolar only, sir.
Yeah, we tested it, but we had less than 1 volt. So with bipolar, it's going to be like 1.2, and the impedance will be higher. So just for the device longevity, was the adaptive CRT algorithm left on? It was off, right? So I'm just wondering because I think there may be still some degree of fusion. What was the AV interval program?
Sense David delay 160, paged 140.
Sense 160.
140 and 160.
Yeah, so we may be getting some fusion, I think. That's probably why we have the slide. We can maybe see, yeah, but just changing a little bit the AV delay, if we can still change, because there may be some fusion still, which could be good, actually. Maybe we'll get a very good result with that. But,
so my understanding here is, you know, there is a scope for AV delay changes. And, well, be careful that, you know, if the output also needs to be adjusted.
I think the thresholds were okay. The threshold from the LBBP lead was
1.3, sir.
Yeah, 1.3, and I think it's probably pasting at 2.5 or something.
Yes.
Yeah.
This patient cardiac MRI was done?
No, sir.
There's one question. Does cardiac MRI help in assessing the septal scarring and septal thickness prior to doing this procedure?
I don't think we have any data on that. I once reviewed a paper, but it was very poorly done and got rejected by the journal about the amount of septal scar, and that paper seemed to say that it does. I personally don't have any big experience with that.
In your center?
Sorry?
In your center, do you?
We do quite a lot of MRIs. The thing I look out for is really an ischemic cardiomyopathy. If you have a big anteroseptal scar and stuff, that's something which tells me it may be a little bit difficult. I think the substrate may be different with non-ischemic, with the mid-myocardial band of scar that you have, in which we have in quite a few patients with dilated cardiomyopathy. That hasn't somehow been too much of a problem.
So one doubt I had, so where was the conduction block in this patient? I am still confused.
Yeah, what was amazing in this patient was when we had the transition in the QRS, yes. And there was an extremely long stim to V delay. Nothing that I've ever seen with conduction system. It was like 100 milliseconds. I've never seen this, especially as we're pacing so far down. It could be that there was in intrinsic rhythm, I saw what I thought was a potential within the V quite late. So a very delayed conduction down there, or even retrograde, and then maybe we were just capturing that and having a very slow conduction out. So that's one possible explanation. The second explanation is that we were actually with the LBBP lead pacing in SCAR, and then we had a stim QRS, as you do with VT ablations, right? You have a long stim to QRS. The only thing which was a little bit strange there was the capture threshold was actually quite good. So if you were really pacing in a very scarred region, maybe I would have expected the capture threshold to be a little bit higher, but I think those are the two explanations, but I've never seen such a long stim to QRS pacing from LBBP.
Was there a long AH on the left side, or was it a split his which we were seeing?
Well, I think we were probably seeing a split his because from the right side the HV was long at 90, and then I had tried a more distal position and I came back much more proximal. We had no hiss at the area where we screwed it in, and I was in deep. I mean, I had capture from the anode, and we saw a small pre-systolic potential there, a pre-systolic potential. So it may have been a sort of a distal hiss there, left-sided hiss. And I sort of saw a far-field A wave as well on the lead. So that's why I thought that this could have been a very distal hiss. And there the HV was a lot shorter. So I think there was also intra-Hessian conduction delay.
There is an intra-Hessian disease plus some distal conduction disease which we took care of.
Yes, yeah.
Otherwise this would not have helped.
That putting a CRT lead would help you because the distal disease...
I think so. Yeah. You can definitely get, I mean, Marek Jaszewski has really showed this in his studies, that you can get LBBB capture confirmed with all sorts of maneuvers and so forth, and have an R-wave peak time in V6 that can be over 100 milliseconds, 120 milliseconds. So very delayed conduction because of a very sick conduction tissue, and I think in these instances it's good to have a CS lead on top of it. You can't take care of the whole story with just one lead.
Can I ask what was the QLV on the CS lead which you had?
So it was about 50, it was relatively early. And even on the right side with the right lead, normally with right bundle branch block you have a really long QRV, I would say, and it wasn't. It was relatively early. So I think this patient had sort of disease everywhere, but with the BIV patient, probably anatomically what was good here was that the LBBP lead was very basal and high up, and CS lead a little bit more, it was, you know, a big anatomical separation, so that when we get, in this case, we don't necessarily need to use the intrinsic conduction, which is not very good, and we have the BIV pacing, and the anatomical separation means that we can get some degree of electrical resynchronization. And the pacing, the BIV pacing using the LBBP lead looked a little bit nicer, a bit sharper, with about 10 milliseconds shorter QRS duration than with the RV apical lead. So we probably worked around that. And then we can see maybe by changing the AV delays if that's something we can still gain a little bit more.
All right, so wonderful job, Anindya. And thank you. So Anindya and Buri, they only deserve the lunch, I think. But anyway, as a bonus, I will give you lunch.
Ladies and gentlemen, let us break for lunch, which is arranged on right side of the auditorium, and I would like to request assemble back here after your meal for upcoming session. Thank you. Welcome back, everybody. It's our pleasure to invite Dr. Daljit Kaur, consultant cardiologist and electrophysiologist, AIG Hospital, to speak about conduction system pacing in post-TAVR or post-valvular surgery.
Good afternoon, one and all. Thank you, Dr. Lasser, for having me here. So, I don't have much or big experience, or as a team also, we don't have a very big experience with post-TAVR cases. We have done some 5 post-TAVR cases for conduction system pacing, but yes, we are doing a decent work for the post-valvular surgery patients. TAVR, we have done some 5 cases, and I would like to tell that the first case I only started in the lab, that was early 2019. And I took the case and I was trying to pace very basal. And I think that was my mistake. I could not go very deep and it was a failed case. So I just pulled it back and I kept it in the distal septum and came out. So that was the failed case, I would say. And then after that, Shanmugam came to a center, and I think I told this last time also. His bundle was started by Dr. Vijayaraman at a center, and we were doing his bundle till then. And then with help of Dr. Shanmugam, he told us nuances, basics, and all those things about his bundle. And slowly, I think our work is improving about the conduction system pacing. With this, I would like to show a case. 63 years male, post-TAVR for severe AS, bicuspid aortic valve, normal LVEF. And this was the pre-procedure ECG, left bundle, normal PR. PR is full, like 200 millisecond, only left bundle branch. Post-TAVR, you can see there is a PR prolongation happening, and there is some notching in 2-3 AVF, little widening of the QRS, and after few hours, it became very prolonged PR. And all of us are aware that this is an indication, progressive prolongation of the PR interval, and left bundle branch block, and it's little more widening of the QRS interval, and we know that this patient needs a pacemaker now. So there is already a data published by Dr. Vijayaraman and his group, like multi-center trial, where they have done more than 35 cases, and they have shown that initially they were also doing his bundle pacing, and they have shown overall success rate of 85%. His bundle, they have shown success rate up to 50%, and left bundle, they have shown success rate of 93%. So I would like just to emphasize that for the students, like how these cases are different, especially post-TAVR cases or post patients who are having a significant aortic valve disease, not only TAVR, if you're putting a valve, surgical valve, because these patients are already having some disease in the conduction area. There is a calcium there, a lot of calcium. They will have a lot of LVH, so septum will be very thick there. And secondly, they'll have LV dysfunction, especially post-TAVR patients, they will have some LV dysfunction, and they may have heart failure, plus minus heart failure. And there is already a data because, and if you do an RV pacing in the patients who are already having an heart failure, the RV pacing will induce more dysynchrony and heart failure, and pacing-induced cardiomyopathy can happen. So that's the reason already there is a data published. If you do a conduction system pacing or CRT as compared to only RV pacing, the outcome is better. So how the AVR or post-TAVR cases are different than post-mitral valve replacement or post-tricuspid valve repair or replacement or annuloplasties. Post-TAVR, the disease is mostly infranodal disease, and post-MVR or post-tricuspid valve repair replacement is a AV nodal disease. You may have a narrower QRS, and so you may be having an area where you can do his bundle pacing as well. Possibly that's the reason his bundle pacing was not much successful in the patients with the post-TAVR, because there is a more fibrosis there. You're not able to go inside much in that area. So this is a case which I was showing. This is a post-lead placement. This is a left bundle branch pacing. And if you can see here, I would like to re-emphasize, I think I'm thankful to Dr. Karthike Bhargava and Dr. Raja Sularaj, because they showed very nice physiology and the anatomical aspects of the conduction system pacing. And if you can see, Dr. Shanmugam was also showing the cases there. You are having a QR in V1. Lead 2 is positive, 3 AVSF is negative. That's what we see when you try to do his left bundle pacing, right? 2, 3 opposite to each other, AVR, AVL opposite to each other. And I realized, I think that's what I was doing the mistake. I was trying to pace very much, so very much towards the valve. So you have to go little distal in these kind of cases, because you may get very fibrosis and you may not be able to screw the lead too much deep within the septum. So if you go little distal, like if you want to do, even Dr. Vijayaraman's series, they have written like 2.6 to 3 centimeter distal to the struts of the TAVR valve. We are going distally, where you can recruit the fibers and you can achieve good conduction system capture in these patients. unlike in the patients in whom there is no valve there. And in the post-TAVR cases, you have a nice anatomical landmark because you know that posterior inferiorly on the septal aspect, lower aspect of your valve, you have it's near the non-coronary cusp, and you know your conduction system is below this area. So you can go below this area to achieve a good conduction system capture. I would like to pause here and talk about this. This I took it from one of the Dr. Alan Bogan's paper. So this is already discussed in the anatomy class in the morning. Like in the septum, the left bundle allows us a very big area to capture. That's why it forgives out. Even if you go little distally, if I go posterior, inferior, and distally, I'm capturing more of the posterior fascicle, not the main left bundle. So that's why I'm having a residual left excess deviation or residual LAFB. So what I was doing going through the cases of Dr. Vijayaraman series, and if you see even what they have achieved is, if you can see that baseline there was no left excess deviation. And once he has implanted the lead, it's not the main left bundle capture. It's a posterior fascicle capture. I think I'll take inputs from seniors here. You can see 2, 3 AVF. Now it's an RS complex here, more like an RS, or you're having a left excess deviation. So you are not able to recruit the left anterior fascicle, and you're recruiting the left posterior fascicle in this patient and achieving a decent result. Next, I'll go to the cases where in the patients with the valve replacement, this is a 46-year male, chronic rheumatic heart disease, post-MVR, chronic persistent AFib since last 5 years, and he was admitted with the refractory heart failure and arrhythmia-induced cardiomyopathy. He had atrial fibrillation with fast ventricular rate. Multiple attempts, I think Dr. Morning, this kind of cases was shown that AVJ or pace and ablate kind of cases where you're not able to achieve the control of ventricular rate, or you're not able to do the atrial fibrillation ablation. This guy was in NYHA class 4, and I'll show the echo of this patient when he was in hospital. Multiple attempts, we were trying to cardiovert this patient. We were not able to cardiovert this patient. He was on multiple antiarrhythmic drugs, very sick patient, and you can see that LVEF is just 25%. Actually, it's not, LVID is not very huge. It's an arrhythmia-induced cardiomyopathy patient. So we were, especially this case, huge LA, huge RA, this case was actually, we were pushed against the valve. This case, that time, this is done in 2018. So that time we were doing predominantly his bundle pacing. So this is, if you can see, is a non-selective. We got a nice non-selective his bundle capture. And all these cases, we have done with the backup RV lead, RV septal pacing, and all these cases, we have connected a CRT device. And I'll tell why CRT device, not just a dual chamber pacemaker where you can put his lead and the RV lead atrial port and the RV port. So this is, he was okay, and we always, I think this was discussed in the morning, we always keep a higher rate. Once you do AV junction ablation, you keep at a 90 rate, and slowly you come down on the rate so that patient should not have a polymorphic VT. So this is what his 2 RV interval I've kept 40 milliseconds, so that if by any chance there is a loss of his capture, you have a backup RV pacing. So this is what I do usually. I would like to emphasize that I'm just blank. I'll put all cases atrial lead. If it's going, I'll just put all cases atrial lead. I'll see if the impedance is very good, sensing is acceptable, more than 1.5 during atrial fibrillation, I'll not pace. So I put atrial lead. After 6 months, I called the patient and I cardioverted him and I sent him back. This guy is from Bhubaneswar. Now you can see, I called him now in June 2022. So this is now 4.5 years. Same patient now maintaining sinus rhythm, in whom we were not able to achieve sinus rhythm whatever way we were trying to use. And this is the parameters. It's been 4 years, now 6 years battery life. We accept that, we know that his threshold will be little more than your left bundle branch area pacing threshold. And these are his parameters now. And this is the most recent echo. LA is still 5.3. EF is completely normalized. After that, not even a single heart failure hospitalization. And this guy is doing good. This is a second case, 59-year male, chronic rheumatic heart disease. He was given mitral valve, it's a ball-length cage valve in 1997. AF since 10 years. Initially paroxysmal, then persistent since last 5 years. This case I'm following since 2014. Initially he used to revert with flickerite, and he had a narrow QRS. Slowly what happened last few years, as soon as I give flickerite, QRS was widening. So I had to stop flickerite. Even I tried sotalol in this patient, I could not give sotalol in this patient. So he went into atrial fibrillation. He was doing good, but he was having few heart failure hospitalization, and the left atrium is 5.6 in this patient. So even if your cardiovert QRS is still wide, so it is not now rately rated LBBB, he has developed left bundle branch block over the period. He used to revert. I've done 3 cardioversions over like 1 year. He used to revert, but again after some time, immediately he'll come back with bad symptoms and he'll have fast ventricular rate. So this case, because it's a recent case now done last year, it's a left bundle pacing, and you can see in both the views, RA, LA view, left bundle pacing. And I've placed atrial lead in this patient. And this is immediately post-procedure. You can see ECG, QRS of this patient, same little left axis deviation in the patient. And this is, I would like to show, this procedure was done in August 2021. The last follow-up he came is February 2022. I'll be calling him again for the follow-up. Till now, device is not showing AFib episodes to me. So he is maintaining sinus rhythm. So I think last time when I was, Dr. Olas gave me a place to talk, and I was showing this, that I'm interested in rheumatic heart disease patients who are having a refractory heart failure. We are not able to manage them and having arrhythmia-induced cardiomyopathy. Why not consider conduction system pacing and AV junction ablation? Mind you, I want to say that these patients are not affording patients, that you cannot bring, because we do perform AFib ablations in these patients, but they come with recurrence. Few are well-to-do patients who do AFib ablations or LA flutter ablations. These are the patients who cannot afford multiple procedures. So this I showed last time also. Any patient come, I'm collecting the data. IHR has given me some grant for this, along with institutional grant. I'm trying to collect data. Like any patients, chronic persistent atrial fibrillation, rheumatic, symptomatic come, I try to revert them first with the pharmacological reversion, then DCCV. If that fails, either take them for ablation, or if they are willing, we will do conduction system pacing plus AV junction ablation in these patients. So I collected this data day before only, so I have recruited 46 patients. Out of that, only 5 I could achieve conversion with pharmacological drugs. Remaining still failed, pharmacological cardioversion failed. So out of that, remaining patients have attempted cardioversion. Out of this, 26 are reverted with cardioversion, and few are only 8 patients are maintaining sinus rhythm. So out of 18, we've done dual chamber pacemaker implantation plus AV junction ablation. And I would like to emphasize, I have a follow-up of not much actually, just hardly 3 to 4 months follow-up, but 75% patients are maintaining sinus rhythm. It's too short a data, it's unpublished data, but I'm following these kind of patients. I would like to show failed case as well. All the cases are not able to achieve conduction system pacing. This is a lady, 59-year-old, post PBMV done first, after that post MVR, 20 years back something, chronic persistent AFib of 10 years. And this is the ECG, and this lady is little sick patient. You can see RA, RV are hugely dilated along with LA, LV. Left atrium is 6.4 centimeter. Persistent atrial fibrillation, heart failure. She was in NYHA class 3. And then when I took her for procedure, you can see huge RA. Whatever maneuver or whatever I used, I was not able to go and sit at the septum. So usually what I try in the lab is I'll take AL and I'll take thermo and try to go into the outflow and try to pull back if you can place the sheath. We didn't have deflectable Medtronic sheath till then. I don't know whether that would have worked. But this particular case, I was not able to go to the septum nicely. It was not getting narrow QRS. It was trying to throw it towards the apex only. So I left it, and this case I have done a conventional CRT. And because when I was trying to pace atrial lead, there was no sensing, hardly any sensing. RA was very much dilated, sensing was very poor. So this case upfront, I decided that I'm not going to put atrial lead and just put the 2 leads and connected VVI. And this is I was trying to show the anatomical separation. This case, I was not able to put the lead into the septum also. And this is the QRS post CRTP. This lady has finished some 8 months of follow-up, and despite of your having a little wider QRS, you can see that the LVEF has improved drastically. I don't think this is a correct LA dimension. I've asked them to send report from outside. It cannot become 3 from 6.4. Its LA must still be dilated, but definitely she's not hospitalized after that, and she's having improvement in LVEF. So this is a 76-year-old lady, post CABG, post MVR, complete heart block, now pacing-induced cardiomyopathy. So one of the case, we are in the post MVR, we have done the left bundle pacing in the pacing-induced cardiomyopathy, and I think it's clearly seen you are getting a very good QRS with terminal S and lead V1 with a good LVAT in the patient as compared to the, you can compare it, the previous paced QRS was 180 millisecond and now it has come down to up to 110, 120 millisecond. This is a very recent case done like 10, 15 days back, so I don't have much follow-up, only follow-up will tell what is this. But this case, so because it's a very old lead, we have not extracted, kept and left it. It's a non-affording patient, we have not put any LV lead, so it's just same device. Only thing is lead position has been changed and will follow up, because it was looking like pacing-induced cardiomyopathy to us. This is the last case, 47-year-old lady, post-ASD, surgical closure and tricuspid valve repair was done this patient. This patient came with complete heart block with the narrow escape rhythm. This case, I would like to, this is the only case I think we have done at a center with the Abbott. We are not using Abbott, hardly any Abbott device. This is the only case I've done with Abbott, and it gave me really, really hard time. Because if you can see that, this is a tricuspid ring, and the RA was very big, and this thing like mouth was very small. And I think Abbott is not having a secondary curve. Every time you try to thrust in, it was like all and on. Either it was going completely towards apex, or it was completely coming out of the into the RA or the RV. So here again, use of the AL and Thermo helped me a bit, and I thought I'm going too anterior. So this is the area, I got very nice area, I thought, and I'll show the ECG also. So instead of going towards the posterior, I'm little distal and I'm going too anterior. And this is the ECG I got. So if you can see that, you're getting a very narrow QRS, and you're getting 2, 3 AVF positive, but 1 AVL is negative. So that's my feeling is, I think we have captured the anterior fascicle here. That's why you're having a residual posterior fascicle block, 1 AVL negative, 2, 3 AVF positive with a very narrow QRS with less than 100 milliseconds. So I think it depends. We are not capturing the complete recruiting all the fibers of the left bundle. Sometimes we are capturing the posterior fascicles, sometimes we are capturing the part of the anterior fascicle, and if we are recruiting whole of the fibers, there are few cases we are recruiting whole of the left bundle branch, then you are getting a normal axis and the RS complex in V1, and if you are having a nodal fusion in the patient, AV nodal fusion once you connect the atrial lead also. I'll stop here. Thank you.
So yeah, these are indeed sometimes challenging cases for the post-TAVI patients. I found that it's very difficult to do His bundle pacing. Very often the His, you don't really see it. It's very low, and the block may be distal. There is a case series from Belgium where they had good results. I don't. I simply don't. So for me in these patients, it's really is LBBP by far with post-CABG. So I've given up His. Otherwise, the post-surgical patients, the anatomy is a little bit different in these patients as well. So you have to keep your mind open to not always go to exactly the same place that you would in a patient with a virgin heart to go there. So I think you have to look out for surprises. The case that you showed, the last one, where you thought you were maybe pacing with the Abbott lead, I think probably what you were doing there is that you're a little bit tangential to the septum and going in an oblique direction because you didn't have that 3D curve, and there was no R at all in V1 or V2. The QRS is nice. I mean, the end result is good, but and it was positive in 2 and 3, if I remember correctly. So it's a little bit like the case I had this morning where I was coursing anteriorly. In LAO, you think you're going septal, but then if you don't see that R wave in V1 and the QRS is not really changing that much, you really need to go back to RAO and look. But I think you did a good job on that last. I mean, the QRS looks nice, but if it really was left anterior fascicular capture, I don't know. I don't know.
Regarding the positivity in 2-3 AVF which you are quoting in Vijayram, it all depends on the site where you are pacing. So if you are higher up, closer to the distal case, then probably you'll get all positive. So you can get any sort of combination in inferior leads, 2-3 AVF, depending upon your height of lead deployment in RAO view. If you are too high, closer to the distal case, then you'll be getting all 3 positive. If you are
High
in the
means
midway,
anterior.
high means in RAO closer to the his catheter. Yeah.
Anterior,
not anterior,
right?
not anterior, superior. Superior.
Anterior is too much equivalent to superior, right? If you're going
No,
to
no,
outflow
RAO
tract,
view, if you
do
go-
we have Purkinje fibers when you go properly high outflow
No,
tract?
no, no,
Because
I'm
you're
talking-
recruiting Purkinje fibers, right?
Yeah, so the thing is that if you have a his catheter in RAO view, if you have a temporary his catheter from groin, if you are going in line with the his catheter, your right bundle will be there, right? So we always try to keep it
Go
1.5 centimeter below. So in that initial 1.5 centimeter, if you are pace mapping, you will get many times lead to positive and sometimes AVF also positive. If you are moving down towards the RB apex along that imaginary line, the 2-3 AVF positivity
Becomes
gradually
negative.
comes down. So if you go more anterior, you'll be capturing more of an anterior fascicle rather than the main bundle. So if you want to capture posterior fascicle, you come down. If you want to capture the anterior fascicle, you go anteriorly. If you want to capture the bundle, you stay in the initial 1 to 1.5 centimeter. So that can be pre-decided by doing a pace mapping. So these days I look on only one parameter if I have any doubt, see the lead to positivity. If you are anatomically, fluoroscopically in the correct area, see the lead to. If it is positive, then probably it's not equivalent because we don't know how the bundle causes. Probably you will be ending into the proximal bundle. If lead 2 is negative to begin with, the most probably you will end up in capturing the fascicle.
This case I didn't have choice. It was not staying at the
Yeah,
base at all. It was just throwing it very distal. It was not staying at all.
Sometimes with a thick septum, it will be slippery. You will not be able to deploy it in the proximal septum, especially with the sigmoid septum. It tends to slip. So that time you may have to mid-septum only going. Probably you will end up in capturing the
This may
posterior
be that the tricuspid valve ring is there, close, and there was a TR.
yeah.
So I think maybe it's throwing it distally.
See, in your rheumatic patients, AF patients, so you are constantly saying sinus. You mean to say the AF went off by pacing?
No, you have device no, sir. So yeah, A pace, in this case which I showed, there was 40% I think A pace going on, 40
Yeah,
or 50%.
40.
So maybe you have remodeled it. So you are able to maintain sinus a longer duration.
No, that is very interesting because most of the AF cases where we can't attain rate control by drugs, when we ablate the AV node, we don't expect the AF
Yes,
to go off.
that's true. Absolutely, we don't expect. I agree with you. We don't expect. So what I started doing is you just leave a natural lead. Because few cases I initially did cardioversion in the lab. These are non-affording patients. No one is bothered about these cases.
I think we will get Dr. Buri here. You know what? The observation in the clinical practice, including ours, is little different. If you have a DC version as well as some drugs, and then you did a good BIV or a conduction system pacing, I think the sustenance of sinus rhythm is much higher. No, we are not talking about on specific 6 centimeters. Still, I just would like to know, this conduction system pacing also has positive remodeling effects on the atrium. So those patients with AF, with AV junction ablation, with achieving the narrow QRS, whichever the way, I think the result of the maintenance of the sinus rhythms are far more gratifying than otherwise.
Yeah, I think there's also an interplay between the tachycardiomyopathy, the heart failure, and the AF, and then simply getting rid of the tachycardiomyopathy with ablating the AV node and even pacing the right ventricle or by V. We've all had patients who've actually gone back to sinus rhythm and then kicked ourselves for not having put in an atrial lead. You didn't. Yes. You put in an atrial lead and you did very well to do so. But I've had these patients, and it's just by getting rid of the tachycardiomyopathy that they actually stay very unexpectedly in sinus rhythm.
So this is the belief that these would be into the sinus rhythm. That's what made you to put the lead, right? Yes. So there's already she started off in assuming that the patient would be in the sinus rhythm, and this is really in our series. I think many of them have retained the sinus rhythm for a long time.
So you should be publishing together.
Sure. And India, you heard.
Can I just say, so I have had a similar case where there was a guy with
same amiodarone, single shot cardioversion, he's been in sinus for 3 months now. So it happens.
So great presentation.
Thank you, sir. Thank you.
Thank you so much, ma'am. Now we have Dr. Anandya Ghosh, Consultant, Department of Cardiac Electrophysiology and Pacing, the Madras Medical Mission, Chennai, to share his experience with steroid-driven leads.
A very good afternoon to all. At the outset, I would like to express my sincere thanks for having been given this opportunity to present our data and experience of conduction system pacing using steroid-driven leads. I would also, from the start, request all the mentors present here to forgive me for any inadvertent mistakes in my presentation and also to guide me and correct me at any point they think I got wrong. So, to start with our experience of steroid-driven leads, one question comes to mind: how did we come up with the idea of steroid-driven leads for conduction system pacing? But the answer is it was always there to start with. The first case of conduction system pacing, reported permanent His bundle pacing in man, was in fact done using a steroid-driven lead. You can see here a modified J-shaped stylet was used in a bipolar screw-in lead, which was from cardiac pacemakers vendor. So from there on, it has always been the lumenless lead 3830. And as a part of the evolutionary process, and because currently left bundle branch pacing has almost taken over His bundle pacing as the default strategy, we have again moved to steroid-driven leads to have some better experience, and also because the lumenless lead was never intended for a deep septal penetration to begin with. So there are several tools in the market currently. Among the steroid-driven leads, 3 vendors have already stepped in the market. In India, Boston Scientific is not yet available, but Biotronic and Abbott have already set foot. There is the Selectra 3D sheets, which come in 3 different curves and 2 lengths in India. The 42 centimeters is not yet available. Abbott, with its His Pro sheath with no secondary curve and its already existing STS lead, is also in the market. We will cover the topic under the following headings. We'll see how we defined in our series the conduction system capture, not going into much details of how to define a left bundle capture or a His bundle capture. We'll see the specifications of the current tools, the lumenless lead versus the steroid-driven leads. We'll see what are the advantages of steroid-driven lead and also the disadvantages of them compared to the pre-existing technology. And then we'll look into the specific advantages, disadvantages of the Abbott and the Biotronic systems. So in our center, we tried to make it simple. We decided in a patient where we try to attain a conduction system capture, we think in the His bundle area, paced QRS morphology, which is identical to the native QRS with or without bundle branch correction, or with the paced QRS morphology like a para-Hisian capture, 2 lead 2 positive, lead 3 negative. But all these criteria are inclusive, so the paced QRS duration also has to be less than 120 milliseconds. In the left bundle area, a QR or a monophasic R and V1 with unipolar tip capture. For the left bundle area pacing, we believe in lead stability. So unless we get a ring capture, we are not satisfied with the end result. So a ring capture with a W configuration or even a QR, which we have got, is also required as a criteria for a successful conduction system pacing. We have also seen in absence of a QR with unipolar tip, even if you get a QS in V1 with bipolar configuration in left bundle area pacing, with the QRS duration again less than 120 milliseconds, that will be enough. Acceptable thresholds, appropriate sensing, and no over-sensing also included in the criteria. So we'll go to the comparison of different different tools in the market. We are already familiar with the lumenless lead. We have know it in and out. It's the lowest of the profiles in the Medtronic 3830 lead. It's 4.1 French compared to the Soli S60, which is 5.8 French, and the Tendril STS, which is 6 French. The main difference in the tools of Biotronic and Abbott is basically the sheath. The sheath is deflectable, has a mapping electrode at the tip for Abbott, and Biotronic is basically the same sheath as the C315, just that it's more sturdy and takes the torque well. The other major difference between the lumenless leads and the stellate-driven leads combined is the length of the lead, which is particularly important because the working length of different vendors, when we compare the sheath length and the lead, comes in very handy when trying to slit. Sometimes we are not able to get an appropriate slack inside, and trying to get an appropriate slack, we were left with no length to slit. And that's where the 3830 lead, the lengths 69 and 74 come in handy. So their 3830 is lumenless, the other two are stellate-driven. The methodology for lead placement has been described variously for Biotronic, but it's fairly stable for the Abbott. We'll discuss them in detail. And all the data which we have as of now, major data is with the lumenless technology. So we'll start with some of the advantages of the stellate-driven leads. It has a sturdier profile because it has the stellate for its support, and there is better control. There is a possibility, there is a scope for continuous mapping of the unipolar characteristics while screwing in. So because there is a stellate, we can attach the crocodile clip to the stellate, and while screwing in, we can continuously monitor the pacing impedance, the paced QRS morphology, how it goes from a W to a QR and an R. Also, we can check at will the LVAT. So as we go from the right side of the septum to the left LV subendocardium, the W becomes QR. The pacing impedance initially to start with increases slightly, then comes down unless there is a perforation, and then it will suddenly encounter a drop. Already described by our mentors in the previous sessions that anything less than 450 is unacceptable. Also, the LVAT will progressively decrease. So all this has to be ideally monitored to avoid penetration into the LV, because stellate-driven leads, being more sturdy, have a tendency to easily penetrate deep. This was not actually what we thought in the beginning, because stellate-driven leads did not have an isodiametric lead profile. There was the diameter of the helix did not match with the distal lead body, so we thought it would be difficult to get inside the septum. But as it turns out, it's quite easily to get in the septum, and even a lead perforation is possible if we don't continuously monitor the unipolar characteristics from the tip. So this is one of our cases. This is actually the LVAT is not mentioned here. The impedance, as we can see, is gradually decreasing, and we can continuously see the morphology in V1 changing from a W pattern to a QR and ultimately R. It has already been seen and described well in literature that in pushing the lumenless deep into the septum, there are template beads which we can make use of to protect us from penetrating and perforating into the LV cavity. Mind you, even if we perforate, that's not a major problem, as has been described, but why waste an extra attempt in order to take the lead out in position again? So the use of template beads has been recommended by Shanmugasundaram sir in his series, but in his series also, not all the patients had template beads. Approximately 2/3 of patients only had template beads, and we cannot rely on them 100% all the time. So the most important thing while screwing in the stellate-driven lead is a continuous mapping of the unipolar characteristics, continuously check the impedance, continuously check the paced QRS morphology. That is the most important point. As soon as you see a QR, you should stop there. Also, the luminous lead, the helix is always out, and while mapping, it has a tendency to snag in the tricuspid apparatus. Wherever we try and position the lead, every time we try to pull it back into the sheath, there is always a resistance, and that is something not nice. It can cause sometimes catheter-induced bundle branch block or a HISB, because sometimes even a CHB has been seen in some of our cases. So in mapping can be done in the screw-in configuration, also minimizing local injury by the exposed helix, and there is less chance to snag the tricuspid valve apparatus repeatedly. So this is one of our cases where we used the solely as lead. There are the electrograms with the lead inside the sheath are as good as when they are out, and when they are out, we can again also check for pacing characteristics and injury. And last but not the least, in case of failed attempt, the same lead can be taken back to the RV apex without the need for a change of sheath, or even actually not change of sheath. You have to take a new vascular access, so that is taken care of. Now, some of the common disadvantages of stellate-driven leads. The larger profile we know actually necessitates larger diameter sheaths. Actually, it has been recommended to take in a bite of the muscle and create a hemostatic suture ready in patients who have been planned for an Abbott device, because their sheath is the largest, and if not placed before the procedure, it can lead to inadvertent bleeding and unnecessary delay in finishing the procedure. The lead lengths are considerably shorter when we compare it to the luminous leads. We can see the Medtronic lead comes in 69 and 74 centimeters. The Biotronic and Abbott are hovering around 58 to 60. And this provides us less available length for slitting, although the problem with slitting is no longer a concern now, but it was more of a concern in the beginning where we were new to the technology. The lack of isodiametricity still remains, but as we now know, that is no barrier to deep septal penetration. Now we'll specifically look at the two vendors from which the stellate-driven leads have been provided to us in the Indian market. First is the Abbott system. There is a Trendil SDS lead, STS lead, and which is through a delivery catheter, the HIS Pro. The HIS Pro is basically a modification of the EP Agilis catheter. It has essentially, you can see in the tip, there are bipolar tip electrodes which are in a split ring design, 3 millimeter by 3 millimeter, placed 180 degrees opposite to each other. They have the ability to pace and sense both. Then there is a double deflection curve, which is controlled by this knob here at the proximal end. There is a slittable hub, which is available here, where you can put the slitting tool. The benefits of this sheath are that it's the first delivery sheath which can be used in conduction system pacing with mapping and pacing capabilities even without the lead. It is deflectable, has a stiffer profile. But the cons are that the profile is too large, hence requires a larger sheath, approximately 10.5 French. There is no secondary curve to orient it to the septum. You have to actually manually pre-shape to get it to orient perpendicularly to the proximal septum. Slitting is optimal only in non-deflected positions, so you have to release all the curve which you have given during the implant to start slitting. And the tip electrode information can be misleading. You may get a HIS at the tip, but when you get the lead outside, it goes somewhere more anterior, and you may actually not get the same capture as with the Agilis pacing. So you can see here in the patient, this was a patient with sinus rhythm LVBB with equilibrium dysfunction. We had taken the patient for a hot CRT. We can see here the Agilis Pro is sensing the HIS bundle signals. We have already, I have just now told you that the tip information can be misleading when we take the tendril out at the same location because of not a perpendicular orientation of the sheath to the target area. The tendril will not end up at the same site as the distal electrode position on the Agilis HIS Pro. So there is no question about the quality of signals which you can get from the Agilis. We can also pace from the Agilis, and
at the same site where we got the His signal, although not seen on the right side because this is in a different patient, we got a non-selective His capture. The Abbott lead, the STS lead, is nothing new. It's a standard lead which we have been using for a long time. Obviously, the still driven feature offers greater stability, as we already discussed in the common advantages. Even with the helix inside, it can be used for mapping. The problem is the available slitting length, 58 centimeters, may cause troubling during slitting of the sheath because the working length of Agilis is 38 centimeters, so it provides us 20 centimeters. Although we have gotten better at slitting, in the initial few cases we had difficulty in the slitting of the sheath because of this inadequate shorter length of the Trendil STS lead. In the beginning we thought the Stillet introducer tool which is available with Biotronic is absolutely essential to make the Stillet driven lead, actually the outer conductor and the lead body and the inner conductor to be a single unit, but that is no longer essential. The larger profile always a problem, lack of isodiametricity. They have a longer lead, 65 centimeters, which can be used, but that is not MRI compatible. The implantation technique for the Abbott lead is a very simple one. There is no lead preparation required outside, as has been mentioned for Biotronic, and there is a reason for that. The insulation which the Trendil STS lead have is actually not conducive for a single lead body rotations for deep septal penetration. I'll discuss that in the next few slides. So no lead preparation is required. No sheath preparation is also required. We'll map initially with the Agilis His Pro. We'll get a target location. Then we'll map with the lead in the screw-in configuration. If at the left bundle site, if we're targeting the left bundle area, we'll get a pre-screw septogram for lead orientation, and then we'll use the clip-on tool to take the helix out, followed by quick clockwise rotations of the lead body, during which there is a chance of the helix coming back inside the lead body, and that's why the periodic re-extension of the screw, which is required to prevent because otherwise it will tend to retract the screw back in. So our experience with His bundle pacing has been good. We can see the His Pro catheter, we can get non-selective His bundle capture. Here we are pacing in a patient with a sinus rhythm LVBB. We are getting a good His bundle potentials. In another patient where there was a His signal present, we could actually get a selective His bundle capture from the Trendil. In the left bundle area, we have gotten some great results. Here in this case, we have a fascicular potential, to be exact. In the Trendil, the His bundle is at the His. The distance from the His bundle to the fascicle is around 35 milliseconds, and we pace at that site. You can see a retro His, which is seen. The spike pacing stimulus to that retrograde His is also 35 milliseconds. And as with any Stillet-driven lead, it provides a continuous monitoring of unipolar characteristics while screwing in. We can see the lead V1 morphology changing from a W to a QR. Also, interesting thing to see in all of our cases would be that whenever we get a so-called left bundle area pacing, it always turns out to be 2,3 EVF negative. That is because the Agilis sheath with no secondary curve is very difficult to orient perpendicular to the septum. To get anteriorly, more anterior, more superior is very difficult. So whenever we get, when we use the sheath without a manual pre-shaping, without the secondary curve, we always end up being quite near to the septum. As we can see in the septogram, we are quite in, no doubt, but what we can see is a 2,3 EVF will be negative, not the ideal proximal left bundle capture. As we already saw in the previous case, there is left fascicular potential, and although the long-term results between a fascicular capture and left bundle capture have been debated, this is what we are content with. So it's difficult to get to the proximal septum with this absence of secondary lead. Only thing we can do that is we can manually pre-shape, give the secondary curve with the dilator inside, and actually, if not with not much effort, you can actually get, just a second, we can actually get a secondary curve which looks very sweet compared to the Medtronic sheath. The only thing, the curve has to be given with the dilator inside. We have done it in 2 cases, and the results were satisfactory. We can see in these 2 cases where we were able to go more towards the proximal septum. So I already discussed the lead length is an issue. So the lead length available for slitting is what we are talking about. The select secure lead 30-30 lead is 69 centimeters. The working length of the C3115 sheath is 43 centimeters. So the available length which it provides us for slitting is 26 centimeters. On the other hand, in tendril lead, there is only 20 centimeters length. This is compounded by the fact that the agilis has a braided structure. Even with the minimal slack provided at the distal end, it can be sometimes an issue because there is not much available length proximally for slitting. And even when you get an appropriate slack while slitting in, you can see the braided structure of the agilis tends to have a dragging effect on the lead. Towards the end of it, you can see, you saw that just now. It tends to pull the lead back. Although we have not had any lead dislodgement during the slitting procedure, this is what we noticed, and especially in the hands of beginners like me, it can be dangerous. There is another tool which they have, which we have not seen before, is their slitting tool, which has this long groove to be put inside the slittable hub. And in our initial experience, we were not very comfortable with that. We even ended up breaking it. You can see the blade and this entire groove, I don't know what they call it, is actually stuck inside the proximal end of the sheath. And this is the one we had to take a new one. Actually, we didn't use this also. We had to use a blade to cut this off. Also, repositioning is an issue. The helix strength of the stellate-driven leads is not the same as 3830 lead. There is one more issue with the lead insulation. Just before we started specifically talking about the Abbott lead, I told you that the way to put the tendril lead inside the septum is not the same as Biotronic. In Biotronic, you can use the stellate introducer tool, make the entire lead as a single unit, and then give body rotations. But it is not recommended for the Abbott lead because the Abbott lead has a different insulation material. It has a combination of a silicon and polyurethane, and this particular insulation has the potential to become damaged when subjected to repeated rotations directly applied to the lead body. Already published. Therefore, it is not recommended to rotate the outer body directly by using the stellate introducer tool to obtain a deep septal penetration. So this was all about the Abbott tool. Now we'll discuss the Biotronic tool. It is basically an improvement upon the C315, his sheath, which comes in 3 different curves, 40, 55, and 65, 65, probably for larger hearts, although there is no recommendations from the vendor regarding its use. It is available in 3 lengths, 32, 39, 42 is not available in India. So this leads to all these configurations, these 6 configurations which you can use, 32, 40, 32, 55, 32, 65, and same for 39 centimeters. It has, again, same 2 curves which the C315 has, but it is much more sturdier. It provides better stability, and it does not tend to kink as compared to the Medtronic sheath, which frequently does. So it's sturdier than the contemporaries. There are different curves and lengths which you can use tailor-made for different patients. The longer length and larger curve may fare in larger hearts, as we already discussed. Cons, although we don't know how much it helps, there is no option of deflectability. You cannot use the delivery sheath for mapping the intracardiac signals, as in the Agilis sheath, and there has been no definition as to which curve to be used in which set of patients. The lead characteristics is it's an old lead. We all know about it. The only new thing which came up when introduced for a conduction system pacing was this stellate introducer tool, which we also have currently stopped using. We initially used it to make the inner conductor and the outer lead bodies a single unit to facilitate penetration into the septum. We thought that the stellate introducer tool fitted onto the first in the IS1 in the first ring in the IS1 pin would make the biotronic stellate-driven lead into a stronger lumenless lead. Essentially, because we thought the stellate-driven tool was actually making it as a single unit like the Medtronic lead, but it didn't turn out to be so. There have been it doesn't fare that better as compared to the Medtronic lead. And so currently for the biotronic tool, we use the same method as we used for the Abbott 10 STS lead. Also, there is an issue with slitting. In the initial days of our practice, the available length for slitting is still less when compared to the 3830 lead. As we discussed, we used this previously, and we thought the slit introducer tool was absolutely necessary. We even used that tool. We actually wasted one biotronic lead to get the tool just for the Abbott lead. So with the biotronic tools, it's also no issue. We can go in deep in the septum. There is also the possibility that we can continuously map the unipolar tip characteristics, but the same problem in repositioning still remains. With the Medtronic 3830 lead, you can reposition 10 times, 15 times with the same lead. The helix won't go bad, but in the biotronic and the Abbott leads, this is a frequent occurrence. It has already also been published. This is one patient where that lead distortion even happened during the penetration into the septum. You can see in this lateral view, I don't have the LAO view here. In the lateral view, you can see the tip of the helix is quite distorted just because we got an excellent PHQRS morphology and it was stable. This was the patient with the sinus rhythm LVBB, severe LV dysfunction. We did this lead bundle pacing just in lieu of a CRT. This is unipolar, this is bipolar pacing, so there is a QS in V1. Because of the good PHQRS morphology, all lead parameters being stable, we accepted this kind of a deformity on fluoroscopy. And the patient is doing well. The methodology has been variously described using the stellate-driven tool, but currently we use the same method as we used for the Abbott lead, except for the fact that there is no pacing and sensing ability of the delivery sheath. Our experience with his bundle pacing has been good. This is just one case which we did where we got a local his bundle potential in the lead, and pacing at that site led to a his bundle capture. Similarly, we could get good left bundle captures. Getting into the septum was never a problem with this lead. You can see as we described, getting into the septum and attaining a ring capture is what defined our success in case of lead bundle area pacing. You can see from the tip you can get a QR, and the ring which shows a W, which is exactly the configuration to start with on the right side of the septum. Also, with decremental output pacing in this patient, there is a QR to an R. You can even see the retrograde his in the his bundle catheter. So this is our experience with the overall experience with conduction system pacing in our center. We have used all three different technologies. We have had the largest numbers. We have been doing it for the last 4 years with the lumenless lead, and the Abbott and Medtronic have been the recent addition to our experience. The success, the procedural success which we defined according to the criteria described before is definitely more in the Medtronic group because we have a large experience, and with time we hope that the procedural success will definitely improve with the other two vendors too. The procedural time is definitely less with Medtronic, but we are getting better with the state-driven leads, and hopefully that will come down too. So with this, I would like to share our idea of a ideal CSP tool, which we thought would be best for any patient. The lead has to be slit-driven. I don't know how do you make it, but it has to be isodiametric too. The lead has to be lengthier, and ideally there has to be longer helix, so that will help us too. The delivery sheet should be sturdier, deflectable, mapping enabled, but for now I think the Biotronic sheath is what is the best which we have for current practice. In summary, with the stillet-driven leads, we have to keep in our mind that they are stiffer than the lumenless lead. So the care should be taken not to perforate the septum, and because we have the stillet to continuously monitor the unipolar pacing and pacing characteristics, and we should make full use of that. And the lead placement should be always under fluoroscopic guidance and continuous monitoring of the unipolar characteristics. The lead implant depth, we normally routinely use the septogram to make sure that the ring is still inside, and also we test the ring capture and threshold. So it has been published in literature that they have currently similar implant success rates, procedural safety, although Shanmugasundaram sir yesterday mentioned in one article the risk of lead dislodgement on follow-up was more with stillet-driven leads, but yeah, we are yet to see long-term results from that. So stillet-driven leads offer several advantages over the lumenless lead, all of which we have discussed in detail till now. So one of the most important things, it provides excellent torque transmission. Deeper septal positions are more easily obtained. And one thing which I also personally felt, that while rotating, for a beginner, when you rotate the 3830 lead, we more often than not twist the lead on itself. There is no manual transmission distally to the tip, which is a less frequent occurrence with the Biotronic lead or the Abbott lead. So unipolar pacing characteristics can be monitored, already discussed. The most important thing for amateurs like us is the unfortunate event of a lead dislodgement. The same lead can be positioned in the RV apical position without having to regain another venous axis. So neo CSP tools are all available throughout the market. Boston is also coming in towards the end of the year in India with its CSP tools. And till then, it depends on the operator preferences. I may use Biotronic someday, Medtronic the other day, maybe later on we'll do the Abbott also. Thank you. Sir, it can go, sir, but for me, I'll not try in the apex with that lead too much.
They have been doing it, but we have never used that in the. He tries to encourage the amateur. I mean, as he says amateur, but he's an expert.
He wanted to test whether you're
he just is trying to encourage that it is time to adopt new technology, and then even if you fail, don't despair. The lead could be used. That was his point, and then you did a good job. Yeah. So any questions? No, Daljit, tell us something about your Biotronic. Of course, you have a talk, right? You have a talk, right?
Not Biotronic, but whether all patients should be CSP, something like you gave me. No, Biotronic, we did 42 cases actually. It was a good experience, I would say. But what happened, 2 cases, that's true. Even that happened with Abbott also. That has never happened with Medtronic. That lead has gone in, and whatever you do, it is not coming out. Septum, not perforation. It went into the, maybe you are going through Cordy or something.
I think probably you're having the...
Anybody else was there around you or you were alone? No, I couldn't get it.
So,
that's exactly the reason why they could not pull it. That was the problem. People require muscles to pull the lead out. It's like, I just was wondering, how could that happen? You know, just, you know, like, what on earth, you cannot move the lead out. You may perforate, you can rupture.
No, I think you entangle. It's clearly the entanglement effect, because you're not concentrating a lot, you're just completely winding the endocardium around the lead. It's getting completely entangled, and there's no way you can get it out. You can't screw back the lead. You can't pull back the screw. It doesn't work. And the only way you can get it out is by pulling and by stretching the helix, so the helix stretches out and will free itself in that manner, or you rip out part of the endocardium, the fibrous tissue that's there. And I think the problem is that you should recognize really this entanglement effect. So with his bundle pacing, you want to feel some resistance, you want to feel rebound. That's important. If you don't have the rebound, you don't have the torque build up, your lead is not well anchored, and you will get micro dislodgements or macro dislodgements. With left bundle branch area pacing, you don't want to feel rebound, you don't want to feel resistance, you want the lead to go in smoothly. And if you're battling at the beginning and feeling the resistance, and you want to keep on battling and try to penetrate, you won't. You'll just get completely entangled. That's been shown in the cadaver model by Marek Jaszewski. And that is a lot less forgiving with stylet-driven leads than it is with the lumenless leads. The luminous leads, you can pull a lot more, and you will less damage. I have also damaged the luminous leads with his bundle pacing because it's been entangled. But with stylet-driven leads, if you feel there's a bit of torque build-up, stop, reposition elsewhere, and try again. And in that instance, you will get a lot less of this issue. The series that Shanmugan showed yesterday was from the Singapore group. I don't think they were implanting properly.
I think
no, sir, I'm sorry. Both the cases, first case, they have screwed first time and they were not able to come out. It was extracted by the team from the groin. Second case, I was there. That was a Abbott system. First time we were using Abbott, and only 2 times or 1 or 2 times it was screwed, and then it didn't come out. And whenever you are the way you're pulling, and whole thing was coming up, you can see till mid RA, everything was pulling back. Just, and maybe I'm wrong. So then what I have realized is, first time when you go towards the septum and you get current of injury without screwing itself on the unipolar, I think that's a good site because you're pushing. But if you don't get current of injury, maybe you're too much into the Cordy, you're going through Cordy. Correct me if I'm wrong. So from that onwards, what I never go very basal, or I see if there is no first current of injury without screwing. You first go and against the septum, and then you keep the lead because you're pushing so much, you get some current of injury without screwing. No, if you're not getting current of injury, that means it's not a good sign, I'm trying to say. It's not a good sign. You should, that means you may be going through Cordy or something.
Without current of injury, you don't start the thing.
That's what I'm saying. Maybe starting mistake done. It may be you're going through Cordy. I don't know.
We'll discuss. You know what? I think the master is getting into action. Let's not miss any one of those beautiful moments. Shanmuga, can you hear us?
Yes, sir, absolutely.
Oh, great, great, great. So we are getting ready to see you in action. And before we start off, let's see what was the case. Can you present the case, please?
Yes, sir. Moving on to the second case. Our second case is a 63-year-old female with a history of diabetes mellitus and systemic hypertension. She's a known case of non-ischemic dilated cardiomyopathy. She has complaints of dyspnea, NYHA class 3, and episodes of PND. She had 1 episode of heart failure admission in the last 6 months. The ECG shows sinus rhythm, left bundle branch block with a PR interval of 190 milliseconds and a QRS duration of 146 milliseconds. The echo revealed severe LV dysfunction with an EF of 23%. Planned conduction system pacing optimized CRTP. The ECG. This is the baseline ECG.
So, Dr. Shanmuga, I think you have seen the basal ECG. Now I realize that it didn't really look very wide. Or
So the baseline ECG was like borderline. It was of probably 140, 150.
Yeah, is it in India? Is it like an intermittent kind of a wide QRS or all the time the same? I mean, it's like, not so very wide. It is usually we don't put.
I think there were two ECGs, and both were showing us almost a similar QRS duration of probably around 140 plus milliseconds.
Yeah, just qualified for the, bi-week,
Yeah, but now you can see the ECG which is running in the EP system. So it's little wider than what it was in the ECG. So, and the rate is also little high. So I think she has LBBV, and there are, I could see some notches in lead 2 and 3 on the R wave and the descending limb of R wave. If you take Strauss criteria, it will most probably fits into this Strauss criteria. More than that, the HV interval was, I think, some 70, which was measured at the beginning of the study. And septal thickness, as per the echo report, was 9 millimeter. I don't know, MRI was null or not, I'm not sure. And I was informed that the coronaries were normal. So we are dealing with a typical non-ischemic cardiomyopathy in a female patient with a normal coronaries and probably fitting into Strauss criteria with a prolonged HV. The only worrying factor for me was the LV dimension, which was given as 70 millimeter. So that was little probably dilated than what we expect for a super responder. Let us see whether we can penetrate the septum or not. So I always start from the groin with two catheters, as I was discussing in the morning. So one will be in the his bundle. Now the his catheter got a little bit dislodged. And one I always keep it in the RV. Though we are not going to injure the right bundle, but inadvertent injury is going to happen sometimes if the sheath is jumping into that area. So it's always better to have an RV catheter, especially when you're doing a LBBB correction, so that you can work comfortably. And another important thing is that hump of that RV catheter will tell us a rough location of the his bundle. So that I always use when there is no EP system. We can always place the RV catheter at the apex and use that hump to delineate probably what is called as the apex of the tricuspid leaflet or the distal extent of his. I started from right atrium, so I kept the sheath in the right atrium. Then I tracked the sheath into the right ventricle. I kept at a spot, probably a favorable spot. Then I did a pace mapping. Can you show the pace mapping of that area? So lead 1 positive, 2 positive. So I'm not going to look into the notches in V1. I'm going to look into the lead 2 positivity. So lead 2 is positive and AVR-AVL discordancy is there. Let me see whether that spot is allowing me to enter. It is more proximal. So can you show the fluoro? Yeah, so this is the spot. And I always remove my this outer gloves before deploying the lead. That's my usual routine. Always wear 2 powdered gloves, and I'll start with 2 gloves, and I'll make sure that everything is ready for deployment. Once I'm ready for deployment, I'll remove the gloves, and I should not throw it down anymore.
Shanmugam, is there anybody at the groin? Can we just put that his bundle catheter at the his bundle?
It's not staying there, sir. Anyway,
doesn't matter. It's just that we wanted to know, like Buri was saying, that you go a little more basal.
Yeah.
That differentiation I wanted to know. So it's okay. Now, what do you think from the his bundle is your tip of the left bundle catheter?
So now the his catheter is far away. It is in the right
correct. But from the his bundle region to
so
this.
I think I'm probably 1 centimeter below, rather not 1.5, probably 1 centimeter.
It's too very proximal.
Yeah, it's too proximal. Let me see whether I can deploy. I'll be happy if I'm going to deploy the lead here. Can you come to level? Yeah. Fluoro? $25 is sufficient. Yeah. This strike, it should be strike. Yeah. So I always want someone helping the sheet to hold it at probably 4 o'clock position. And let me see whether I can deploy the lead. Reduce the table height little. It's not going. Can you go to Arevo? Arevo? Fluoro? Yeah. Control level. Compare level. Compare level. Yeah, sure. So this area is not allowing me. So I'll just go to Arevo. Hold the lead. Yeah. So fluoro. Okay, control level. Hold it. The initial subendocardial aspect is little difficult to penetrate. Go to Arevo. Let me go in and come. Sometimes the tricuspid leaflet might come, especially if you are in the proximal location. The tricuspid leaflet might come. So we can go in and come back a little bit to displace the tricuspid leaflet. So we can go in a little bit and then pull back so that I can negotiate the tricuspid leaflet. Control level. Hold on. Yeah. Fluoro. Not getting a good support. Okay, come to Arevo. Fluoro. Okay, control level. Fluoro.
Moved little in, but not sufficiently in. But let me check the parameters here. In patient, so and that's fine. Is it capturing? Okay. No, it won't fix it. So off pacing. Off fluoro. Can you go to Orevo? Yeah, show fluoro. Okay. Just give me a pace map here. Cable connected, yeah. Yeah. So I'm getting a positivity in lead 2 and yeah, let me see here. I'm little below only. Hello? Fluoro? Yeah. Come. Hello. I had gone in, I had some ectopic also. Can you catch the ectopic? Yeah. Okay, so anyway, pace and see here. Okay, that's fine, yeah. So notch is ascending, but still we are not getting a good QR. Right. Let me see, what is the impedance like? Okay, you can still more go in. So we advance little further, yeah. And we had an ectopic also now. Show the current of injury, so we had still a good current of injury. And ectopic can be chased. Still it is not QR. So anyway, just pace and see. Still wide. Okay. What is the impedance? 800. Okay, thank you. Yeah, off pacing. So almost gone in for 12-30 milliseconds. Still we have current of injury. Yeah, pace. So there is no QR. So I think I'll change the position and off fluoro. Come to Arevo. Fluoro. Okay. Come to level. Fluoro. It's really a tough septum to penetrate.
That's what I'm saying. You know, I think I've disconnected. Let's see. There are several questions we need to be asking about the technique to it. It's like Sachin Tendulkar taking the card. His position, Sachin Tendulkar taking
Go
the
to
card.
Arebu.
Yes, yes.
Yeah, show me the. Show fluoro.
There are so many things which we have been observing there, which is against the what the guidelines. He should not have done like this. I mean, like persisting disease entanglement.
Let me see whether I have any tissues attached to the leaflet tip. Yes, there are some tissues. Yeah, yeah.
It's a bad thing. You should not jump. Yeah, it's a bad thing. So
Yeah. Yeah, yeah. So I can use a 2 ml syringe, but I always use my hand to remove it. Just rotate it in the opposite direction, and usually the tissues will come out. Yeah, hold on here. Fluoro, offline. Yeah, come to Lego. Fluoro. Ah, so great. But the ectopics are not really great, so that is associated peripheral disease. So anyway, connection, show me the connection. Connected, show fluoro. It's connected only, KGC within. Yeah, sir. Yeah. Still we may have to go in, yeah. Still it is all negative. Yeah. Go, hold it, yeah. Hold it. It's not going. Yeah. So anyway, it's drilling the septum. It's not going in further. You come to Arebu. Can I have one more glove? 6.5. 6.5 gloves. Yeah. Come to Arebu.
So it's going up till the mid-September, but it's not going beyond that. Let us check here. That went. Can a patient show? Yeah, it's such a long stream to QRS. Yeah, it's 83, right? It's all distal disease. We may end up inputting a large CRT in this case. So how much was the impedance? Show fluoro. 860, yeah. Show fluoro. Got stuck there, it's not progressing anyway. Let me check here, otherwise we'll go to some other question. Show. Yeah. It's still the same? Yeah. So I think we'll go to some other position. Show fluoro. Yeah. Go to RAO.
Shanmugh, in this, are
Yeah.
you able to listen?
Yes, sir.
Yeah, the spike to QRS was so long. Yeah, by that definition, it is selective. And in this case, you don't have a terminal R. And is it not in that 10% cases where you don't get a terminal R? Why would you change?
No, that LVAT is not really a good one, and it's not looking
Not
like
LVAT, the spike to the onset of QRS.
Yeah, that may be because of a local scar producing some exit block. I'm
Yeah.
not sure whether it is a selective capture.
Okay, but the QRS got narrow, right?
QRS get narrowed, but not up to the extent of a conduction system capture. It looks like more of a myocardial capture because in non-ischemic cardiomyopathy, the usual site we face resistance is the mid-myocardium.
Yeah.
So if you just give additional force to penetrate that mid-myocardial resistance, the lead will usually jump across that area. This looks like more of a mid-myocardial area rather than...
How much was the QRS width here?
QRS width, can you measure and show?
Did they measure? Yeah, here, on the screen.
How much it is? 170. 170, yeah.
No.
No, it's measure the QRS alone, not from the onset.
Yeah, QRS onset to onset.
130, 140.
120.
So it's more of a septal pacing rather than a bundle capture.
Shanmugh, can I ask you, I know that it is becoming difficult here. So, Haranpuri is here.
Yeah.
We have been, talking.
Yeah.
A few things.
Yeah.
One, you see, you went on or you persisted in the same site, going on, drilling in.
Yeah.
That is probably not a correct way because, if you're not penetrating deep enough at a particular site, whatever you do further, you won't proceed further. That's what he calls an entanglement effect, or what is it?
Drilling effect,
right? So that's one. And a couple of times we saw you actually pulled it a little into the sheath, and then again, without cleaning the helix, you went in. You could figure out whether there's a tissue attached or not. You can feel it, or what is it?
Yeah, so that removing the tissue, I don't do it frequently. Many times you can get away with that because if you just see the lead 10 times, at least 1 or 2 times you'll be having the tissues. So I always try to go to the next part. and see whether a lead is going in. If it is not going in, then I'll take out the lead and see whether tissues are there. So that's how I usually do. And regarding this persistent effect at the same spot, this mid-myocardial fibrosis usually requires additional force. I usually try for additional 3-4 seconds before taking it out to going into some other spot. If it is like a normal ventricle doing it for a bradyarrhythmia, then it's like you should not keep on doing in that area. If it is a cardiomyopathy and if you feel that the mid-myocardium is the usual resistance, I'll try to give additional rapid rotations. The rapidity will be really rapid than the usual one and try to penetrate that mid-myocardial resistance. That was the idea of persisting at the same spot, but it was not working. Then I started changing the area. So let me see another area and decide.
So you will be going little more apical now?
Apically, yeah. Show fluoro. Okay. So come to LA. Can I have gloves? Gloves. Come to LA. Show fluoro. Again, the same thing, it's going up to the mid-myocardium, it's not going beyond that. Can you space and show? Yeah? Okay, stop pacing.
Plus, we have an MRI on this lady?
Are you?
No, we have not done the MRI.
Are you?
That's the routine practice. Yeah. It's
MRI was done? No. Hold it here. Can you do a pace mapping here? Pace. It's connected? Yeah. Yeah. Okay. Come to level. Fluoro. I think I penetrated a little bit in now this time. I got a good current of injury. Yeah, pace. Pace. Yeah. Still it is QRs. And yeah. What is the impedance? Okay. Let me see whether I can go still more in fluoro. I've gone in a little further. It's an ectopic also. The pace. No, I think it's still QRS and I've gone almost deep in. It looks like more of an IVCD here. Yeah, stop pacing. Yeah. Fluoro, what is the impedance? Okay. So almost the whole anode is in here. Can you come to Arevo, just see how the lead has gone in? Yeah, just check it. Yeah. Yeah. Can you show fluoro? Off pacing. It's going little anteriorly, and most probably it is having an oblique course. Come down. Off pacing. Yeah. Okay. You come to a level. Show fluoro. Which is the clear. I think you can carry on with your discussion for some time. So I'll come back to you in another 10 minutes. Is that
Yeah,
okay?
yeah, absolutely, absolutely.
Yeah.
I think you can also kind of take a break there.
Yeah.
Okay.
Yeah.
Sure, we'll come back to you.
Yeah.
But we are sure that you are going to see the beautiful QRS soon.
Yeah.
All right.
Yeah.
So you know what, the MCs to take over.
Arevo.
Next presentation. Acha, by the way, your coffee? Your coffee is ready?
Yeah, coffee and then.
But I hope Shanmugh didn't hear this.
I've heard. I'll get this here.
You did hear, so anyway, we'll get you coffee inside there.
Yeah.
Okay, with a straw.
Okay, come to a level. Yeah.
Shall we break?
It's going to be a big exercise here. You come to a level.
Yeah,
No, it looks like more peripheral disease. Penetrated
the
vein, but
the
still
audio visuals could be stopped.
not even a trace of QR.
Stop பண்ண சொல்லு, stop.
It's more of an IVCD, I think.
Thank you so much.
Of Patronic and Abbott is basically the sheath. The sheath is
Let's now begin our third session with some CSP case presentation. The first case presentation is about CRT by V non-responder, role of left bundle branch pacing by Dr. Bharatraj Banavalikar, consultant cardiologist and electrophysiologist, Sakra World Hospital, Bangalore.
Good evening, everyone. At the outset, I would like to thank Dr. Ullas for giving me this opportunity. I am a consultant in Sri Jaideva Institute, and I am a visiting consultant in Sakra World Hospital and Aster. So this is a very simple case which I am going to present. Biventricular CRT has been a major advance in the last couple of decades. However, almost 1/3 of the patients are non-responders. And I'm going to show a case in which we used left bundle optimized CRT to overcome this problem. So this is a patient, a 45-year-old gentleman who was referred from Bengal. He was diagnosed with non-ischemic dilated cardiomyopathy with severe left ventricular systolic dysfunction with an EF of 25 to 30%. He had undergone a CRT-P implant 6 years back. And his EF did not improve significantly post-CRT. And then almost a couple of months back, he was admitted with decompensated heart failure. And then at that time, it was detected that the device was in end of service with no pacing. So this was the intrinsic rhythm. The ECG shows left bundle branch block with a QRS duration of around 160 milliseconds. Echo showed significantly dilated left ventricle with a EF of 25%, and patient also had moderate mitral regurgitation. So these are the serial echoes which I got in the patient's documents, which was documented. So the EF at implant was 30%, and it never really crossed 35% in the last 6 years. Usually patients with non-ischemic cardiomyopathy, they generally respond to biventricular CRT well. They respond very well, except patients with sarcoid. However, despite MRI being a standard protocol in our institute, we could not do in this case because of a pre-existing device. So we planned for upgradation to LOT CRT. So screwing was not much of a difficulty here. The septum, the lead went in very easily. So this was the first pacing side. We got a good QR complex in lead V1, and at 2 volts, there was a transition to QS complex. The impedance was around 700 at that particular instant. So I tried screwing a little deeper, and then there was a sudden drop in impedance with loss of capture. Then I had to reposition the lead again. Again, the lead went in quite easily, fortunately for me. And then this was the QRS which we obtained. There is a good QR complex in lead V1, and then there is an isoelectric interval. And then you can see that there is a monophasic R in V5 and V6, which means we are capturing the basal conduction system. Whenever we pace the posterior fascicle or the anterior fascicle, obviously there will be change in the axis, but also there will be a S wave in V5 and V6. Absence of S wave in V5, V6 means that you are capturing the basal conduction system. So the QRS duration was less than 100 milliseconds. And the R wave peak time in V6 was around 79 milliseconds. And Dr. Karthikeyan made an interesting point of measuring the R wave peak time in V1 and then noting the difference. I have not measured that. However, it looks that it is more than 40 milliseconds here. So this was the 12-lead ECG at 25 mm speed. And you can see that the QRS is really narrow with a short LV activation time. and no S waves in V5 and V6. So this was the septogram. So this time I was a little careful not to screw the lead deeply to prevent microperforation. So with bipolar pacing, there was no R wave, and there was a slight widening of the QRS, probably because of anodal capture. This was the fusion between the left bundle pacing and the LV lead. So the eventual QRS was close to 90 milliseconds. This is the final position, fluoroscopic views, RAO and LO. And then this is the 12 lead ECG at 25 mm speed. You can see that the QRS is really narrow. And then it's less than 100 milliseconds. And then on follow-up, within 2 weeks, there is a significant improvement in ejection fraction. It's close to 38%. And the MRS, mitral regurgitation also has significantly reduced. It was moderate to begin with, but on follow-up, it had reduced to mild MR. And in most patients with non-ischemic cardiomyopathies, they respond dramatically to left bundle pacing. And within 1 or 2 weeks, in fact, I had a patient who came back with acute kidney injury because the EF had improved to 55%, and there was diuretic-induced dehydration, and patient had gone into acute renal shutdown. So the initial 1 or 2 weeks are critical. Sometimes there is a significant improvement, and then you have to completely stop the diuretic in such patients. So just to highlight a few challenges in such cases, venous patency is an important determinant here. Suppose the subclavian or the brachiocephalic segment is occluded, then be prepared to do a peripheral venoplasty in such cases. And then sheath manipulation can also be a little difficult because of fibrous tissue in the pocket. So as a routine, I generally serially dilate the puncture site with 6 French to 10 French dilators before I introduce the left bundle sheath. And then depth of screwing assessment is also very important. It's important that we measure the septal thickness before the procedure, and then carefully monitor the impedance. Once the impedance reaches 600 milliseconds, I think it's better not to screw it further deeper to avoid microperforation. And then finally, you can either extract or cap the old lead. Dr. Shanmugam showed a case where he extracted a lead, but then sometimes selectively extracting a single lead while preserving the other leads can be a little difficult. So it's better to cap the lead. And whenever you are capping, it's important that you bury the capped lead deeper into the muscle to prevent erosion or other complications, pocket-related complications. So to conclude, I would say that in patients who are CRT non-responders, left bundle optimized CRT is a reliable and important strategy to overcome LV dysfunction and to improve the long-term prognosis of these patients. Thank you. That ECG was not available, sir. Because on the fluoro, it looks that there is a good separation between the RV and the LV leads.
Yes.
He was already in EOS, so I didn't have any old ECGs.
No, that's okay. I just was wondering, before you could contemplate on putting another lead, to reassess like what is happening with the morphology.
Exactly. I had that curiosity myself, but then I didn't have any of the old ECGs of the patients, sir.
Fair. You have a question? All right, thank you, Bharat.
Thank
you so much. You know what, we'll...
Deceiver. So you can see the RV septal lead is actually more towards, it is more left to the left bundle lead.
Yeah, sure. You
so
know,
it's a very nice
you know,
image.
what he's trying to say is, you know, there is a comparison between the positions of the
the original RV lead and the left bundle lead. Okay, it actually looks in the LAO as if it's a great spot, but which is not true in the RAO. Yes, I noticed. You can again elaborate on that. I think Vivek's point was great. Yeah. So look at that. You know, in the LAO, it looks so great.
Actually, show the septogram. That was even more revealing.
Yes.
Show the septogram.
Really? I hope you're.
Yes. Because it is more apical.
Yeah, and because septum is actually curved. No?
Curved, yes.
No, that's the original RV lead, but yeah, all right. So, Bharat, thank you very much, and we invite the next presenter, please.
Thank you, sir. Here we have Dr. Naveed Aslam, Associate Professor of Interventional Cardiology in DMC Hospital, Ludhiana, to talk about the CSP, a alternative or complementary to biventricular pacing.
First of all, I must thank Dr. Ulas, who has given me the opportunity to present this case and to learn much more about this upcoming modality. So it's not an interesting case, it's more of a problematic for which I need your suggestions and comments, since many expert and pioneer in this field are here. It's a sort of most of the questions are answered in the morning case. So at the end of this presentation, you say that it's a sort of second copy of the first case in the morning. She's a 52-year female, non-diabetic, normotensive. She was having history of breathlessness for last 1 year, which was progressive in nature. She came to us in June this year in NYHA class 3, despite optimal medical therapy. Her coronary angiogram was normal. It was done outside. She belonged to Jalandhar. This was the ECG, left bundle branch block with broad QRS, sinus rhythm, normal access. This was the echo showing significant LV dysfunction. These were the dimensions of LV. Septal thickness was 9 millimeter, and her ejection fraction was about 28%, 25 to 28%. So the option was either we should go for CRTP or physiological pacing. And since it's emerging concept and there is a lot of enthusiasm, we decide to go for physiological pacing. This was the baseline ECG. This was a spot we identified for screwing of the lead with notch in the V1. Lead 2 was positive, 3 was negative, and discordant between AVL and AVR. We have, while screwing the lead, we were facing the same problem as we have witnessed in the last case. After going in for some distance, it was not going in. We changed almost 3 spots, but we were not getting good parameters on electrocardiogram. Finally, we got some good tracings, and after 3 attempts, this was the tracing we got. And here we thought, although the findings were not very ideal, optimal, here we thought either we should abandon it or we should go for the CRT. Coronary sinus lead.
Naveed, can you go back to the ECG? I have a question for Dr. Buri. So now, how do you read this, for example, the V1 and V2 findings, what does it suggest?
So this was initially right before screwing, is that right? This ECG, or?
This was after we have screwed few rotations, then it was not going in.
Yeah, so I think you're still not very deep in, right? You still have the notching in V1. And
We have notching V1,
yeah.
yeah.
But the level is good. You have positivity in 2, negativity in 3, so I think it's fine. It just needs to go in deeper.
There's so much of a difference between the V1 and V2. So what I wanted to tell you, so this is again a beautiful spot or a sweet spot. You do not have to concentrate only on the V1. Please look at the other leads too. For example, in the V2 here, this kind of a change we don't see it often, but occasionally you see. You agree? Or?
Yeah. But you have the positivity in V2. Yeah.
That's what I'm saying. The caution needs to be exercised at this stage. Do not go further in. That's the point, because you are looking at it and then do this. I think another one turn should be enough.
Yeah, and I think V6 is very important.
Exactly. So this was our concern, because there was a lot of resistance, and these parameters were not okay, because V1 it was not showing R wave or complete disappearance of the notch. So that's why we thought it's a sort of suboptimal finding.
Sure.
The same thing you are saying. So because here we were struggling with the same problem. It was not going in and direction was not less, and we were little bit hesitant to screw more for the risk of perforation. So we stopped here. Then we thought, should we accept it or should we go for the sinus lead? Then we decided to go for the sinus lead because the results were not very ideal, suboptimal. So we thought, let's see, we didn't remove this lead. But once we got the coronary sinus, the problem was same again, because there was a branch, we could not negotiate that little branch, and there was no branch. Finally, there was this middle cardiac vein. So again, the things were not very ideal. So we decided that we will accept this left bundle pacing. We'll keep this patient on left bundle pacing for 3 months. We will reassess her parameters and her clinical picture. If there is no improvement, then we'll switch over to this LOD, the CRT. So after 3 months, only about 2 weeks back, we reassessed. She was symptomatically quite better. Lead parameters were stable. There was some improvement in the LV functions, but there was significant improvement in her clinical picture. So we are continuing with the same. So here, should we continue with this left bundle pacing, or should we switch over to LOD CRT? So these are the few issues which need some clarification for us.
I think there's a great result to begin with.
Yeah, exactly. I mean, the result speaks for itself. She's really improved clinically and also objectively. And this was just by pacing LBBP, is that right?
Yes, only we are doing
And you have the LV lead in, but you just didn't activate it.
Yes.
Is that correct?
Yes.
Well, if the QRS looks narrower, I don't remember this. With the by V pacing, it looked narrower, right?
So this is the ECG we got only 3 days back from Jalandhar. We got the ECG to see what is the ECG right now.
Okay, so this is LBBA only, but what about the by V QRS? Do you have that one? Is it any the by V QRS with the LBBP, the LOT CRT QRS, in fact?
So by V QRS we just measured at the time of implantation.
Oh, okay. But the CS lead is in there, and she's got
CS lead is in, but it's not. It's inactive.
Well, I mean, you can give it a try and then always come back.
So
I
should
think.
we switch on this sinus lead and see the result? If there is improvement or if there is deterioration, we should return back to...
I would wait a little bit because she's doing better, so you're not in a hurry anymore. Because now if you turn on the LV lead and she continues to improve, you don't know if it's still the effect of the LBB pacing or if it's because you've activated the LV lead, and it's going to cost you a bit of energy. She's doing better. I would still leave another 3 months with the LBB pacing, check her clinicals and check her echo, and and if she, she's just hasn't changed anymore, she's stabilized, then I would turn on the LV lead and see if there's any further improvement. Because the remodeling process takes time, okay? And if you turn it on now, you don't know. Is it just a continued remodeling from the LBBP, or is it the effect of the coronary sinus lead?
True.
So I would leave it, and you're saving a bit of battery also just by.
All right. So thank you. I think the clinical improvement makes us to continue the same thing. I think the eco-guided decision. I'm not sure. I'm not an expert, and we don't really do anything when the patient is doing great. Again, eco-guided approach of LB alone or CRT, I'm not sure.
I mean, what we sometimes have is a patient who improves clinically, says it's fantastic, thank you so much, doctor, I'm really feeling great. And you do the echo, and the echo doesn't look any better. Well, you're not going to discourage them and tell them, no, you're not any better. Right. But usually when you do get a remodeling, and moving from 25 to 35 is meaningful. I mean, 20 to 25, or, but this is a 10% increase, so it's something which is meaningful. Usually those patients also do feel better, usually.
Yes.
If you go by Marek's recent paper, the separation of the R wave in V2 and let us say V6 peak time is quite low. It's low, yeah. So probably this is LV septal pacing. Yes. Yeah, correct.
Yeah, sure.
But it also shows that sometimes the LV septal pacing works. Yeah, exactly.
I think it was a great result. So you still have a choice, but I think you will continue to do this configuration. This is my thinking.
Sure.
Thank you. Now,
Thank you.
So on the next.
It gives me immense joy to call upon stage our next presenter, Mr. Mohammed Akram, cardiac technologist, Department of Cardiac Electrophysiology and Pacing, onto the stage to discuss CSP in unusual anatomy.
So very good evening to everyone. So first of all, I'd like to thank Dr. Ulasam Pantangi sir and my team here in Arrhythmia Heart Failure Academy for this opportunity. So I'm going to present conduction system pacing in unusual anatomy. So we know like conduction system pacing is rapidly evolving, and it is considered as the most physiological way of pacing, so much that it is considered as a viable alternate to cardiac resynchronization therapy. So some examples are which deviates from the normal anatomy, which is left SVC, dilated atria and ventricles, left subclavian obstruction necessitating right-sided implant. So congenital heart disease involving ventricular inversion, that is congenitally corrected. So my case, history of 67-year-old female, symptomatic degenerative AV block, narrow QRS escape rhythm, good biventricular function, EF of 60%, dilated atrium. So this is a pre-ECG of the patient. It's kind of a Wenke block going on, like a 3:2 Wenke block going on. So we took the patient. usually we put, through the femoral vein, we used to put 6 months diagnostic his quadripolar catheter. So we were trying to do, like put the catheter there, but we see this kind of a wire passing through. So we just saw, we took an angiogram there. So it shows like the way it goes through, there is no IVC, the interrupted IVC, then it goes through hemiazygous vein and drains into right atrium. So it goes through a pathway of through LSVC and it drains to CS, then into right atrium. So we did left upper arm venogram that shows LSVC. So then we took the shot of right arm. Right upper arm venogram showed patent right SVC. So then we decided to go through the right side. So we did a right-sided implant. So this is one of the review article, his bundle pacing tips and tricks. So before going through the right side, we took the C315 his sheath, Medtronic his sheath. We created a 90-degree curve, like it was like a 90-degree curve at the estimated right subclavian SVC junction. So by making this 90-degree curve, it made us to reach the his bundle region. So when we were like going from the right side, we felt this kind of a jump, and it leads to kind of a stability issue there. So this is our traces. We paced at the site, appropriate site. We showed this kind of a notch in V1 pre-screw. Then we decided to screw in this region. So when we were screwing, during screw we noted that there is this kind of a beat which is happening, kind of a, we noted it as a template beat. Then post screw, we noted there is kind of a potential there. So this is our final result. We did obtain a selective left bundle area pacing with this. So this is our final fluoro. So this is our post ECG of the patient, which shows a selective left bundle area pacing, which shows V1 QR. So I conclude, like with the increased experience of conduction system pacing and new tools all coming up, so all anatomical challenges can be tackled effectively. Yes, thank you.
The most important thing is he is our cardiac technologist. So I think he deserves a bigger applause. So I do not think the days are very far where we probably will be sitting in the control room and everything is going to be operated upon by them, and I think he's setting the standards. Thank you.
Now, we're moving on to the session 4 by inviting our chairpersons, Dr. Rituparan Shinde, Dr. Sujit Majumdar. The next presentation is about conduction system pacing, choosing the optimal site by Dr. Ashish Nabar, Senior Consultant, Interventional Cardiologist, Electrophysiology and Pacing, Mumbai.
Yeah, good afternoon, everybody. I think a lot has been discussed in the meeting up till now, and I wonder what new I can add. And as I understood the meaning of this topic, you will find that there is a lot of repetition of what we have discussed since yesterday. But all the same, I understand the meeting has managed to attract a lot of postgraduates, and therefore some kind of a repetition wouldn't be that bad. So left bundle pacing as compared to his bundle pacing, and that's where I'm going to concentrate in the next 20-25 minutes, was supposed to be easier. The main reason for that is that the left bundle branch area is a pretty broad area,
and therefore, unlike the localized his, you might just be easily able to do the left bundle area pacing, or left bundle pacing rather. And the other reason why this might be easier is there is less fibrous tissue around the left bundle, unlike the his bundle where you have to penetrate the fibrous tissue. However, while each of us started doing this is a publication which represents probably our experience, meaning the experience of most of us, is that there is a certain learning curve. And in this study, the first 80 patients were divided into 4 quartiles of 20 patients each. And what you can see that after first 40 to 50 patients, the implantation time and the fluoroscopy time kind of stabilized. So there is definitely a learning curve, and if you listen to Dr. Buri's yesterday's presentation, he even says that you may need 150 patients before you are really good at it. And correct, so it depends on how hard you practice the criteria of left bundle pacing, and how meticulous you are about achieving that would decide what the learning curve is like. But once again, it's not a simply done thing. And that probably comes from the variation in the anatomy of the left bundle. So normally you would believe that left bundle area pacing is achieved if you get a QRS width of less than 130 millisecond right bundle branch block pattern and maybe a fascicular capture kind of a morphology. But the difficulty is that this fascicular system is quite varied in different patients, and this specimen shows you that left bundle trunk is probably a broad structure, but then you have splitting into left anterior and posterior fascicle, and there it gets so varied in anatomy from person to person. The cartoon on the right is the work from Dr. Culbertus from Liège in Belgium, and that tells you why it can be difficult and why we sample so many sites before you can really achieve a satisfactory left bundle pacing. The standard way would be, as we have discussed in this meeting, is that you try and target a region, at least to start with, which is about 10 to 15 millimeter distal to the his bundle region in the RAO view along a line, imaginary line that joins the his bundle to the apex. And you get the lead slightly out and pace with the screw, and you should start where a W pattern or a slur on the down slope of the QRS complex in lead V1 is. Usually would like to see a positive QRS in 2, biphasic in 3, and maybe the AVR and AVLR in opposite direction. That probably would be a starting site for most of us. This location may be still distal to the distal his if you have a underlying left bundle branch block or IVCD kind of situation. So you might go still a little apical. The reason why the initial site will also tend to vary, or you might have to sample more sites, is because the fluoroscopic location of the his bundle is different. There are significant variations where the AV node to his bundle transition is placed in the triangle of Koch superior or sometimes inferior within the triangle of Koch, and the ramifications of the left bundle. All this anatomy tends to vary quite a bit, and you really don't image that anatomy when you're trying to do the left bundle pacing. So that's why the number of tries that you need to give to get the ideal location. Again, your sheath, we discussed that in the previous presentations, the various sheaths that are available, but you might have to use different types of different sheaths, different curves, for example, the Biotronic, to reach more apical position sometimes when that position just distal to the his is not delivering the right QRS complex in lead V1. So the last panel in the ECG shows you what you would normally like to see as a starting point, and I repeat that is something like positive in 2, equidiaphasic in 3, AVR, AVLR in opposite directions, and V1 has a notch on its downslope. So that's where you might want to begin. Now this is an interesting paper, and I didn't see it being quoted in this meeting yet, and therefore maybe take a look at it carefully, is that it's good to achieve whatever, left bundle trunk pacing or left posterior fascicle pacing or left anterior fascicle pacing at all these sites. What you would look at the ECG is to get some kind of a R wave, terminal R wave in V1. So it may be QR, all those patterns are shown. The most common is a deep Q and a small r that you get. And at these sites, you will be happy if you get a QRS somewhere like 125 to 135 and a LVAT of about 70 plus minus 5 or 10. So these parameters would be ideal, and you get these parameters if you divide in the RAO view that RAO, the septal surface of the right ventricle. Most of the time, the overlapping site where you get this anatomy, where you get this ECG of left bundle pacing is in the posteromedial. So in the posterior most quadrant and in the medial part, so in the number 4, that's where probably you get most of the times your left bundle area pacing. So something good to know as a, so this presentation is more like an implanter, and therefore your mind can be active in this way as to where you want to start locate the site of pacing. It might become slightly easier as you heard that if in the presentation of prosthetic valves, your prosthetic valve might serve in some way as a site from where you can start your first attempt to get the pacing. So when it's a TAVR, it is about, say, 20 millimeter inferior to where the prosthetic valve is. And when it is, say, mitral valve prosthesis or a tricuspid annulus, it can be in the RAO view, say, about 23 millimeter distal to the septal tricuspid valve. So, so the prosthetic valve does serve as some kind of a landmark to get it. Now, once you decide to start at a particular site based on that pacing morphology, you keep looking at lead V1 and you start drilling the lead. So from W, you gradually, if you follow the lead V1 in the ECG there, you can see that the slur gradually goes on the upslope of the V1 and then finally makes R. So you can keep looking at lead V1 as you screw in, and your impedance would initially increase before it again drops, but as it nears the LV subendocardium. So it should not drop further below 500 as again is discussed before. So you should know your certain definitions as you work through this, this procedure. One is what is RBBB pattern, is that you have a terminal R in V1. QRS duration is helpful to distinguish the site, adequacy of the site. And stim LVAT is important. So somewhere you should target LVAT of 75 if the QRS was narrow or a non-LBBB type. In the LBBB kind of a situation, you can expect a LVAT of about 85 milliseconds. So these can be your initial markers when you want to start, and sometimes when you work without a EP system, these criteria may be something to look at. So summarizing here, if you get the fulcrum sign, if your sheath angiogram shows that the proximal anode is touching the right side of the septum, and your LVAT is something like 75 or so, you would be happy to get at least 2 of the 3 criteria. That is, the width is less than 130, you have RBBB kind of a morphology, and LVAT is less than 90. So if you get these criteria, you would be believing that you are doing left bundle branch pacing. Question is that adequate? So once again, this is an example which shows you that in 3 different types of so-called left bundle pacing, your deep septal pacing or non-selective pacing or selective pacing, you seem to have an overlap of the QR pattern, an overlap of the left ventricle activation time, and therefore these criteria may not be able to distinguish these 3 types of left bundle pacing, and therefore we now actually call it left bundle area pacing. So to get a selective left bundle pacing, you might have to do something more. So you can see that in these 3 forms of left bundle pacing, the QRS width is somewhere between 150 to 120 in the columns above. The stim LVAT is somewhere between 70 to 80. Now, not really very discriminatory amongst these 3 types of pacing, and therefore you might want to have some additional criteria. And what are these? Left bundle potential, and to see how the stim LVAT behaves with different outputs of the pacing. So paced QRS duration is not necessarily an adequate criteria. Reduction in the QRS width actually happens only if there is a left bundle block kind of a pattern initially. If it's a narrow intrinsic QRS, actually your QRS width tends to be still wider at the site of left bundle area pacing, because you tend to capture all the RV tends to get activated by myocardial capture, whereas the LV is activated by the conduction system capture, and therefore actually there is a interventricular dyssynchrony, and actually it creates slightly wider QRS. So QRS width alone is not good, and if you do bipolar pacing, then you may even eliminate that terminal R. I think this aspect was also discussed earlier in the meeting. So going by the QRS duration alone is probably not sufficient. This is a paper from our country where again an RBBB morphology is probably only a screening tool, because in 1 out of 4 to 5 patients, you will not have a great terminal R, and it may still be a left bundle area pacing. In fact, you may have a QS pattern only in about 15% of the times. So once again, your QRS duration, RBBB, not a foolproof way to say that it is left bundle capture. LVAT also probably not, because in this cartoon you can see that the LVAT, or actually LVAT is actually R wave peak time. We discussed this, that it is not the total left ventricular activation time. It is just a scalar representation of the left ventricular activation, so we better call it V6 R wave peak time, which we take as equivalent to left ventricular activation time, and that's what you want to reduce. So here in different examples of selective, non-selective and deep septal pacing, you can see that the R wave peak time in V6 is almost similar, and therefore it may fail you unless you have your R wave peak time less than 75 milliseconds, or your R wave peak time in the paced QRS is less than the intrinsic QRS R wave peak time. So these two criteria may help you if you rely only on the R wave peak time, but generally there would be a lot of overlap between different types of left bundle area pacing as to what the ideal or acceptable peak time should be. Dr. Buri's paper, again, V6, V1 is, so you don't have stim LVAT may vary depending on the conduction system capture, the myocardial conduction, and therefore this is an intra ECG only comparison. So within the patient, the V1 to V6, so stim V6 is the LV activation time, stim V1 is the RV activation time. And normally if you have a selective capture, you would have a V6 minus V1 would be a comparison. So V6 would be going further down, and V1 is the RV activation time through the myocardium, so that will come a little early. And actually RV6 minus RV1 would be longer. So something longer than 60 is suggestive of a selective left bundle area pacing, and lesser values would suggest non-selective or deep septal pacing. So again, this is something useful to decide. Your pacing parameters really don't help you. What the voltage is, what the R wave height is, or even impedance for that matter doesn't necessarily distinguish between a deep septal, non-selective or a selective capture. So that's not useful beyond saying that the lead is quite in the septum and not perforating. So therefore, you need more refinement of the criteria, and the new criteria that are there is recording left bundle potential, comparing the stim LVAT at different outputs, and then finding if there is a direct evidence of left bundle capture. So briefly, we will kind of go through them. So here you can see the A is selective left bundle, B is non-selective left bundle, and C is deep septal pacing. Now, if you get a fixed LVAT at different outputs, the only way you can distinguish between deep septal and selective left bundle is by going for the shortest LVAT. So for example, in the cartoon on the top, the LVAT is 780 at different outputs, whereas on the down it is 90 plus. So a longer LVAT may mean deep septal, and a shorter LVAT may mean selective left bundle capture. But that's not really helpful, because what is short, what is long? What helps is the variation in the LVAT that happens. So even a 10 millisecond variation in the LVAT with reducing your output, say from 8 to 5 to whatever, is actually more suggestive for non-selective left bundle area pacing. And that's actually more relevant to say that you're at least doing a non-selective, if not a selective left bundle area pacing. Here is a little bit explanation. So if you reduce your outputs and you move to a narrower, you move to a higher LVAT as you reduce your outputs, that means you're moving from non-selective left bundle pacing to LV septal pacing, because at higher outputs you were capturing the myocardium as well as the as well as the left bundle, whereas as you reduce the output, you are capturing only the myocardium, and therefore it's LV septal pacing. So reducing the outputs, if you have a widening of the LVAD, that would say that you moved from non-septal to LV septal pacing, and therefore you should screw in this lead further to reach the left bundle. So that's how comparing the LVADs at different outputs can help you. Similarly, on the right side, you see that the LVAD actually remains the same at different outputs. And if it remains the same, that means you are doing a selective left bundle pacing, that with difference in the voltage, you don't get any better in the LVAD. So that would tell you that you are already doing a selective left bundle pacing. That is what is in the cartoon on the right, short and constant LVAD. So in this case, it is short because it is 56, so much less than 75. And at different outputs, it is the same. So therefore, this helps you to say that this is a selective selective left bundle pacing. There are a couple of other things that are described to say whether you are non-selective or deep septal pacing. So you can measure the VA time. If you are doing a left bundle capture, then your VA time will be the shortest. Whereas if you are doing a deep septal or a non-selective capture, then your time to reach the A will be longer, because with left bundle capture, you are directly traveling up the conduction system. So here you can see that with an output of say 3 volt, your VA was shorter, and with reducing the output, your VA became longer. So the first instance with a shorter VA, you were a left bundle, selective left bundle capture. Similarly, from unipolar to bipolar, if with unipolar you are getting a shorter VA, and with bipolar where you capture the myocardium also, you get a longer VA, that means you are doing a selective capture. So therefore, this comparing the VA time at different outputs and between unipolar and bipolar would again help to tell whether you are doing a selective left bundle capture. Presence of left bundle potential is a very, very nice thing, but you get it in different studies about 80 to 90% of times. 15 to 30 milliseconds should usually be the difference between a left bundle to the onset of the ventricular electrogram. Now, this is not easily obtained in patients who have left bundle branch block. You have to pace the His bundle to show the left bundle potential. So therefore, you can hope to get a nice left bundle potential in patients who do not have a left bundle branch block. But otherwise, getting a left bundle potential is good because your capture thresholds will be lower and stable. So left bundle potential is nice to get. Again, you can look for the current of injury of the left bundle potential. Again, one more thing that probably we haven't yet discussed is there are 3 different patterns of left bundle injury. As your lead touches the left bundle and you record a left bundle potential, you may also record an injury potential of the left bundle with the elevation of the so-called ST, or your injury current being part of the ventricular electrogram, in which case after some time the elevation may be seen, or sometimes you may have depression of the segment after the left bundle potential. So therefore, different forms of injury patterns of left bundle potential can also help you to say that you are doing a selective left bundle capture. Fixation or template beats, I think this is one thing that Shanmuga, loves to demonstrate and does it often. I have seen him demonstrating it often. A QR pattern in V1. So if you look at those extra beats that start coming up when the lead is being screwed to the septum, if you look at the last 2 or 3 beats, between those dotted lines, look at V1 that has a QR pattern. So that kind of a beat, if you get, they are called as fixation or template beats, and they resemble the morphology that would appear if you are paced at this side. So once again, about 70 to 100% chance that you may get it, and these are suggestive of suggestive that you will obtain a selective left bundle area pacing. Programmed stimulation, I think Dr. Buri showed some of the examples, and again, I think we had one more time this discussed. Programmed stimulation tries to exploit the difference in the effective refractory period of the left bundle and the myocardium adjacent to it. If there is a difference in the refractory period of the left bundle and myocardium, which is likely to be it can be demonstrated by either widening of the QRS or narrowing of the QRS during the extra beat, meaning one tissue is refractory and the other tissue has shown a different morphology of the QRS. So for example, if you move from selective to non-selective, you would get the QRS widening further. If you move from non-selective to selective, you will get a narrowing of the QRS during the extra beat. So you are exploiting the effective difference in the effective refractory of the two tissues by doing a program stimulation through the lead. This is something which is difficult and probably more of research interest. If you put a multipolar catheter on the left side and document the His bundle to left bundle potentials, you can show an antegrade capture or the retrograde His conduction. So retrograde His conduction, if you capture the left bundle, you will have a very short activation of the retrograde His. If you are doing a selective left bundle capture, you will have the left bundle being recorded before the QRS. If you are doing a non-selective left bundle capture, you will have the left bundle being recorded after the ventricular electrogram from the lead. So this is probably a little bit of research value. Probably we won't be putting catheters on the left side when you are doing the procedure. Does it matter what you do? Does it matter whether you achieve a deep septal pacing, non-selective left bundle? So the jury is yet out. Jury is still out on this aspect, whether it is necessary to achieve a selective left bundle pacing in everybody, because the success of having a selective left bundle pacing is about 60 to 90%. And what is shown in this particular study is that in the initial spinning moments, when you start achieving the R wave, the most of the R wave is achieved in the initial spinning moments, and in the terminal few moments, you really have a little further development of the R wave, or very little further narrowing of the QRS, or very little further reduction of the LVAT. So therefore, from deep septal to selective, you have very little difference in the change of these parameters. And when one studies the dyssynchrony, there is very little improvement in the synchrony pattern of the LV by going from deep septal to the selective left bundle pacing. So the jury is still out on how much you should struggle to move from deep septal to selective left bundle pacing. Again, there are doubts about these new criteria also, what they mean. So existence of left bundle potential was not a prerequisite for successful left bundle area pacing procedure. So left bundle capture. So here if you see successive left bundle pacing obtained in 90% of the patient, the paced QRS, the stim LVAT, you would be happy to achieve these values, and the left bundle potential is recorded in hardly 50% of the patients in this study. So once again, whether you should really get a left bundle potential, whether you really obtain a left bundle potential in selective left bundle pacing is again somewhat open to discussion and may vary from case to case. So therefore, can paced QRS duration be your ultimate thing? Well, not the first thing that you would rely on, but if you have made substantial attempts to satisfy 2 or 3 criteria of left bundle area pacing, and Shanmugh always says that you never can get all the criteria, but if you are struggling to get 2 or 3 criteria and you have made sufficient number of attempts and you are not able to do, then even a narrow QRS might be your final thing, because the call there that you have to take is, should we remove the left bundle area pacing and go to the normal RV endocardial pacing in the bradycardia? Or today we had that case where we quickly debated whether to really have the left bundle pacing, or the RVDF lead and the CS was achieving enough synchrony. So then therefore narrowing the QRS can become your ultimate truth in terms of probably whether to leave the left bundle area pacing lead in place, provided the pacing parameters, that is the QRS width, the threshold and the impedance are adequate, you may have to accept. And I think we saw one of the presentations sometime back also. So summarily, your helix at the left bundle area, see what your pattern is with unipolar paced pattern. Then try to screw the lead in further, look at the stim LVAT less than 75 or in LBBB less than 85. That would be a good starting point. See if you can demonstrate a selective left bundle pacing by shortest and constant stim LVAT time. That could be your final site. And if you can record the potential, bigger the potential, a current of injury in the left bundle potential, this could be still good. So therefore, this could be a normal working flow chart as to how you would how you would select your, how you would confirm the adequacy of your left bundle area pacing, or how you would struggle to achieve, or how you would work towards achieving a selective left bundle pacing. Thank you very much. I think I'll stop here.
Thank you, sir, for your valuable insights. Now, we hand over the deck to Dr. Anindya Ghosh for physiological pacing quiz.
So we are fast forwarding to the physiologic pacing quiz. We'll need some time to set up. Just before the quiz, we'll go live, and after the quiz, the challenging EP cases session will be held. So I'll request all the participants for the quiz to be ready. The 8 participants will be divided into 4 teams, and the teams will be decided by random choice on the basis of chits.
Pull back the wire little. Yeah. Pull back the wire little. Pull back the wire little. Pull back the wire little.
Dr. Shanmuga, can you hear us?
Yes, sir.
All right, great. So you could not get optimal results.
Yeah.
That's why you are getting into the LV. So
yeah.
It's going to be a lot CRT.
Exactly, sir.
All right. So we do not know about the anatomy of the CS. I think you are getting into one of the good tributaries, right?
Yeah, I hope it is.
Okay. All right. So anything at this stage you would like to tell us?
Yeah, that it looks more of an IVCD. So we tried at least some 8 to 10 sites where I could not get a good QR pattern. And I think the review screen is showing the one which we got ultimately. So I had to stop because I know it's an IVCD. Wherever we go, it's either a scar which is not capturing, or a QS pattern with a broad QRS. So I thought it's an IVCD which requires a lot CRT.
Yeah. All right. So again here, Dr. Buri, you are talking about the stim to the QRS. Would you like to make some comments here?
So I don't know what the stim to QRS. It looks like it's about 90 or 100 or something like that. But then the HV interval was long at the beginning, right? If I remember correctly, it was like 70 or more.
Yes.
So again, we're probably having some peripheral conduction disease, which can be incompletely corrected.
So they have subselector. Can you have a subselector?
The Shanmuga,
yes,
the question here is you have a coronary guide wire?
Yeah.
You have?
Yeah. It is there deep inside. It's going into the branch, and you can see it until anteriorly.
Yeah, I think there is something radio opaque thing.
Yeah.
Yeah. So
it's a vein is little tortuous. It's not visible in the fluoroscopy. So that wire is going down and getting into a branch, and it's now placed very anteriorly in the spine now.
Yes.
And you can you show the review screen? In the fluoroscopy review screen, the venous anatomy, or even you can play and show. So freeze and show. So the first
Anand, our Ram Kumar is around?
Yeah.
Yeah, good. You see, what I am trying to suggest here is, of course, we'll have a discussion with Shanmuga.
Yeah.
You see, I'm very proud, you have Dr. Ram Kumar by your side. He is our CRT specialist.
Okay.
So you think, once you are, whatever you are doing it, you can hand it over to him.
Yeah.
And Ram Kumar and Anand would, take over the case.
Yeah.
In the meanwhile, you would like to tell us something about this case?
Yeah, so now I'm free to discuss whatever I have.
Yeah, so
I'll just go back.
Ramkumar, so may I request you to take over, and then you continue.
So, so we started from the basal and went anteriorly, went below towards the apex. So all the areas we're trying to capture. So one thing is that the basal septum was not allowing to penetrate. So the basal septum, I think it's more of a scar from the RV subendocardium itself. And the mid septum was the area where I could get some penetration. Thrice I perforated, and still perforation also didn't result in a good QR. Even before perforation, I didn't get a good QR. It's all of like a W pattern notching in the descending limb or on the ascending limb of the QRS, and the QRS was really broad. And most of the areas, the thresholds were 3, 3.5, so it was not acceptable. So this final one was probably little below the right bundle area, so it's more anterior, and it's in the mid septum, it is little more anterior. And this is the QRS which I got. The threshold is, I think, 1.2 when we implanted. So both with unipolar and bipolar is getting the same thing. There's no difference in the QRS morphology. And LVAT, I think it'll be around 110 or 120. How much? 97 is really not a bad, but still it is LV septal pacing, and just getting very short, tiny QR in the lead B1. It's more of a septal pacing. It's not a real bundle capture. And other areas are like it's not a living me. So I had to accept this result. I thought rather pacing the RV apex for the CS lead, I think it's better to pace the basal septum so that it'll have a good final QRS. Any suggestions?
Well, you did your best. It is just that, from sitting here, we could always give you a suggestion that you could go a little more down, or, you can. Yeah, I think, you did your best, but it just exposed the reality that even in supposedly to be an easy case, even by a master at the time, you may not get the best of the QRS. So that's, I think, the lesson, and it should not discourage any one of us here that, you come across occasionally some real difficult cases. So that calls for, whether we should be actually selecting the cases on the basis of some more information than just the echocardiography and the intraventricular septal thickness or its characteristics on echo. Maybe we have we got to learn something more about the surface ECG better, maybe. And maybe imaging should be a kind of a routine protocol. I think there are questions to be answered. All right. So final comments before Shanmuga is released from there.
Yes. I think the two cases that we had today show that LBBP is not always easy. So one needs to remember that, and but overall, in general, I think it's doable. When I remember my first 5 LBB cases, and the 4 were failures. I was unable to get into the septum, and I was very discouraged initially. But then after you just stick to your guns, you keep going, and your learning process progresses, and then your experience gets better. You learn also how to use other tools, and with all that, then your success rate does climb up. And I think we will continue to have new tools which will help us also continue to improve our success rates. And it's just the same sort of evolution that we've seen with CS pacing, where initially we had very rudimentary tools, and now it's definitely much better.
All right, Dr. Shanmuga, thank you very, very much. You can actually join us here. There's going to be a very exciting quiz program. Ramkumar, you would do this the best. Okay, maybe the patient was destined to be treated by you, Ramkumar. I don't think he has ever failed in the CRT. So thank you, and we are going offline. So everyone, be free. Okay, and good luck to you all, Anand and Ramkumar. All right. Okay, Shanmugam, you can.
I'll come there, sir.
So Shanmugam, you can come here. We will have a. And for today, let's wind up from the. We are offline from the cath lab, and everybody there in the cath lab, Thank you very, very much. The projection, the audio-visual people, everybody, it was great. Thank you, Ram Kumar, and all the people there. We can go offline, please, so let them be free.
So we'll call Mr. Sheila start.
Yeah, you should. Well, again, I just had introduced Dr. Anindya Ghosh, who is our consultant EP. I just explain or describe how blessed I am or how lucky I am. He has taken over the entire department. That I'm absolutely free because of him and Dr. Anand sitting there, and of course the technologies and the people. What I'm trying to say is, he has worked so very hard. As you are aware, we have had the questions the collection about how many questions were for the screening? 10 questions from 60 the residents and the fellows across the country they participated. And some lucky 21s are actually chosen and then they have brought in here by the industry. Thank you, Medtronics. They are maybe even an offer of some kind of a PT observership in our institute for 3 to 6 months and all that. That we will take a look. So thank you, Anindya, for organizing all this, and I think we will learn a lot because I have answered the questions which I could not answer. Okay, so well, it should not discourage the participants. For you, it is going to be home. But please invite and you tell the instructions, etc.
So welcome all to this very exciting session. We are having the best of the young minds in the field of conduction system pacing from across the country to participate in this battle of minds. I'll request all the participants to come on stage. We'll have them pick up small chits and that will tell them which team they belong to. There are 4 teams, A, B, C, and D. So it is possible that 2 of the best can get in one team, but that's not our fault. Please.
So the participants are Spurti Jadhav, Dr. Sai Kiran Kakarla, Dr. Mautika, Dr. Dinakar, Dr. Ramanathan, Dr. Chinmay, Dr. Jyoti Vijay, and Dr. Surampalli Vijay.
So I'll explain the rules of the quiz. So there are 4 teams, but there will be 5 rounds. 4 rounds will be routine rounds, and the 5th one is a buzzer round. Each round has 4 questions. The 4 questions will be directed at the 4 teams separately. So The first round starts with team A. So the 4 questions will be like A, B, C, and then D. The second round will start with the team B, third round with C, and the fourth round with D. So the sequence of questions aimed at will be A, B, C, D, B, C, D, A, C, D, A, B, and D, A, B, C. Now, once a question is asked, the team to which the question is intended for will be given the first opportunity to answer the question. The team will have 60 seconds to answer the question. Meanwhile, the team to which the question is intended for thinks about the answer. The other 3 teams should be ready to press the buzzer. The other 3 teams will be trying to press the buzzer first, so that they will be the team to which the question passes on in case the team to which the question was intended cannot answer, passes it, or gives a wrong answer. So if I ask a question to team A, and if they cannot answer, or they give a wrong answer, or 60 seconds pass after finishing the question will go to some other team. That other team will be decided by the fastest one to press the buzzer. You will be able to press the buzzer only after I finish the question. So when I ask a question to team A, only B, C, and D should be ready to press the buzzer. In case that team the team to which the question is intended for, in case it answers, it will get 10 points. If they are not able to answer or give a wrong answer, there are no negative points. But then the team to which the question passes, if they get the answer wrong, it will be minus 10. And if they can get the answer right, it will be plus 20. All unanswered questions will be passed over to the audience. And the team for which the question is intended will get 60 seconds to think and answer. The team that presses the buzzer will get 10 seconds to answer. In the audience, whoever knows the answer, they'll raise their hands. It is up to me to decide who gets to answer the question. We have some souvenirs, some merchandise we can distribute. And you are the master, and your statement is final. Yes. No, so the statement of you will be the final, sir, and Dr. Haranbudi will be final, sir. In case of a difficult decision, I'll pass it over to you. Yes. And there will be the 5th round. 5th round is the buzzer round. There are 4 teams, so total of 8 questions. The questions will not be directed at any specific team. It will be fired at all the 4 teams. All the 4 teams will have the chance to answer. Again, 60 seconds time given to them to think about whether they want to press the buzzer to answer the question. In case they press the buzzer, they have only 10 seconds to answer. So they'll have to be very confident before they press the buzzer. And when one team presses the buzzer, all other buzzers are deactivated, so we'll know who actually presses the buzzer first. How to introduce? So to my extreme left is team A, then team B, team C is on the other side towards the audience, and team D is towards the stage, towards the screen on the opposite side. So we'll start the first round. You will not see it, look at me. You can look at the screen only. So, mic. So the first question will be directed to team A, but all the other 4 teams should be ready to press the buzzer in case they know the answer. The team A will get 60 seconds to think and answer. In case they don't answer or give a wrong answer, they don't get any negative points, but it will pass over to the team which presses the buzzer first. Timers are ready? Who has time? So team A ready? This is our first question. So the first round is on evolution, history and evolution of CSP.
So Omkar Narula.
That's the correct answer. 10 points to team A. Now team B. Team B should not press the buzzer. All other teams should be ready to press the buzzer in case they don't know the answer. First permanent His bundle pacing was performed in patients with which of the following clinical profiles? There are 4 options. Complete heart block with normal LV function, QRS duration less than or equal to 120 milliseconds. Chronic AF with complete heart block, normal LVF, QRS duration less than 120 milliseconds. Chronic AF with normal QRS duration with depressed LV function. Chronic AF with dilated cardiomyopathy, QRS duration more than 120 milliseconds.
Chronic AF with LVF less than 40%.
That is option
C.
Correct answer. 10 points. Now, they don't have the mic. They have. C, to team C. So this question is for team C. The first permanent His bundle pacing was performed through which sided axis and using which lead? So LL is lumenless, SD is slit driven. One minute is done. Okay, you are ready to answer?
Option D.
Because someone else must be. Option?
Left subclavian axis and stylet driven bipolar lead. C.
So no one has pressed the buzzer yet.
C.
They answered C, but no one has pressed the buzzer yet. Okay. The answer you said is C. So you can, she can press, you press the buzzer. Okay. So the answer is incorrect. You said C, right? It's incorrect. But no negative marking. Okay, no negative marking for C, team C.
Is it option D?
Yes?
Option D, sir.
D is the correct answer. So actually it was done through right subclavian axis. And it was a stellate-driven lead, which we had discussed previously. So this is plus 20 for team B. So the question number 4 is for team D. All other 3 teams, A, B, and C, should be ready to press the buzzer in case they know the answer. Maybe a simple one. When was the first left bundle area pacing in man reported? Correct. So, can I have the scores? So at the end of round 1, team A has 10 points, team B has 30 points, team C is yet to open the scoring, and team D is also at 10 points. So we move on to the next round. Sir, I told published only, sir. I said published. Okay, sir. But when I asked the question, I reported this. Okay, sir. We move on to the second round. The second round starts with team B. So the first question will be for team B. And the same rules will apply as the first round. Round 2 is imaging in conduction system pacing.
(10 to 15 mm). B, option B.
That's correct. Actually, what we actually do is, ultimately, in most of our cases, we end up 15 to 20 millimeters down, which Dr. Haranbudi also yesterday mentioned. But when we get a proximal left bundle, that is approximately 10 to 15 millimeter from his bundle. So 10 points to team B. The next question is for team C. Which are the 4 pacing sites, actually not 2, which are the 4 pacing sites correspond to the paced QRS morphology? So what you see here on the left is one paced morphology going on the ECG. You can see the morphology. I'll give 90 seconds to 120 seconds for you to answer this question. So there are 4 options. What you can see are leads in different positions. The first 2 leads, the first 2 fluoros are actually a running image with a septogram. The third image and fourth are stilts. No problem. Yes? No, it's not the correct answer. So team B had pressed the buzzer.
Option 2, sir.
Option?
2.
That's the correct answer. That is because both 1 and 2 are actually in the septum, but what you can see in the second cine image, it's very close to the apex, so it's down. So 2, 3 EVF are negative. In the first image, you can see it's in the proximal septum. So no negative marks for team C, 20 points for team B. So the next question is intended for team D. That's correct. 10 points to team D. Next question is for team A. Okay.
59 centimeters and 67 centimeters.
Will
69 and 74.
okay, correct. That's correct. So we have finished 2 rounds. So at the end of round 2, team B is leading with 60 points. Team A and team D are tied at 20. C is yet to open the scoring. Yes. So round 3 is ECG and electrograms. The first question is directed at team D. Team C. Team C. So I'll explain. This is day 1 of a post-conduction system pacing implant. The programmed AV delay had been kept at 150 milliseconds. So, team C. D. Okay. So what you see on the extreme right is the unipolar tip pacing morphology. V1 has a QR. And this is the ECG taken on the first post-op day. What explains the above ECG? V1 still shows a QR. So is it selective blood bundle area pacing with intermittent loss of capture? Is it selective His bundle pacing without correction? Is it ventricular safety pacing with consistent loss of capture? Or is it selective His bundle pacing with correction? On the ECG, we have made a mark of what you can see. I'll take you through the ECG also. What you can see is a A-paced, V-paced rhythm in the first 2 beats. The third beat is a P followed by QRS. No spikes visible. Whenever you see a atrial pacing spike, you see a ventricular pacing spike too. But whenever there is no atrial pacing spike, when there is an intrinsic sensing of a P wave, there is no ventricular pacing spike also. The programmed David delay has been kept at 150, but the paced David delay which you see on screen is 110 milliseconds. That's correct answer. No, sir, it was a difficult question. That's why I gave. Because it is difficult to see that, sir. Yes. So 10 points to Team C. This is a great question. Yes, great answer. Yes, sir. So, yes. The next question is to Team D. So I'll again run you through. First, you can read the question yourself. So this patient has had a non-selective his bundle pacing. He came to us in the month of July last year. This is the follow-up ECG rhythm strip without the magnet. There is a corresponding device trace on the right side. The device programmed parameters also given to you. Atrial oversensing. Okay, that's the wrong answer.
Option D, ventricular oversensing.
That's the correct answer. So it's ventricular oversensing of the atrial signals. So no points for Team D, but 20 points for Team B. Okay. So we move on to the third question. Hi, we told that, sir. It's oversensing the atrial signal. But what the ventricular lead is oversensing the atrial signal. They knew the answer, sir, but maybe the terminology got mixed up. Yes. No, ventricular oversensing. Correct, na? Yes. Ma'am? Oh, yes, ma'am, yes, ma'am. So it thought, the ventricular lead thought that something was there, so it did not pace. Yes. The next question is for Team A. It's a long question. This is the first page of the question. This is for Team A. So, a 71-year-old male with an non-ischemic cardiomyopathy, LBBB white QRS, LV dysfunction, 25% EF. He has had a bipolar CRTD with the left bundle lead in the LV port. And the pacing configuration has been kept left bundle alone. So there are three leads inside the patient. One is the atrial lead, one is the RV coil lead in the RV apex, and the third lead, which was meant to be in the CS, is actually in the left bundle. And we are pacing the left bundle alone. So you can see the ECG, focus on the ECG. The question has not yet been asked. You can have a look at the ECG. So after every 2 beats, there seems to be a pause. And the pace polarity of the left bundle lead is from the LV tip, means the left bundle pacing lead tip to the RV coil. So it's a unipolar pacing polarity. So we'll move on to the next slide in our question. What was the cause of that pause? We are not talking about what is happening in general. What was the cause of that pause? Okay. Okay. So we'll wait for 30 seconds more for team A to answer. Team A should remember that there is no negative marking. We'll give them 30 more seconds now. You can think about, because you are not able to see the trace so clearly. That's correct. I had to give them more time because of obvious reasons. Sir, no. It was a difficult question, sir. Because, I say this because there is oversensing on the atrial lead is also oversensing. There is a far field R wave which is being sensed as A beat sometimes. That is a sinus P wave. No problem.
Anindya,
Sorry.
can I take a minute here? I think this is a very good teaching point for the students because if you go back and see surface ECG, can you go back? Surface ECG, every third P wave is not being tracked, correct? Without change in the PR interval.
Yes.
So what are the differential diagnoses? One is if it's changing in the PR interval, we feel that it may be upper tracking behavior or something.
Yes.
But if there is no change in PR interval, if P is not been tracked, that means it's oversensing.
Yes.
And from the surface ECG, it's difficult to diagnose. So
Yes.
what happens when they check the device, when the rep comes, he never connects the ECG through the device. You understand what I'm saying? The ECG leads through the device.
Yes,
Now
yes.
you go next. So if they're not connecting ECG lead through the device, you don't know what device is oversensing.
Yes.
It may be oversensing double R wave, it may be T wave, whatever it is. Sometimes
Yes.
it may be artifacts. So I think that's the commonest mistake made because they will not connect, they will just keep the WAN there.
Yes, yes.
So you will not be seeing many times the markers and the surface ECG, all those things are not seen.
Yes, yes.
So I think that's a teaching point for the students.
Yes. Yes, yes.
We should always insist that the ECG is taken and the device markers are read. All right. Okay. But here, the TV oversensing is immediately seen even in your
Yes. Yes. So next question is for team B. So I'll get the diagnosis again. It's a bipolar CRTD for basically for primary prevention. This was the answer given by team A. It was T wave oversensing. The next question to team B is which of the following best describes the troubleshooting option for the previous case? Remember, there is no negative marking on this case. You have 40 seconds more, so you can still think.
So option B, change in sensing polarities.
That's correct. So can you answer why the other options cannot be done?
Because here the issue predominantly is oversensing. So if we change the vector of sensing, polarity of sensing, then it can
It's like
troubleshoot the problem.
the R waves you see are quite big compared to the T waves. So maybe if we tweak the sensitivity a little, we could have still be done with the problem. So why don't we decrease the sensitivity in this case?
It's a CRT-D, so if we decrease the sensitivity, VT, it can affect the detection of
Correct.
VT.
Correct.
So I think the sensitivity was already 0.9, no? If I
Yes,
remember correctly, which is already not very sensitive for an ICD. So for sure, decreasing the sensitivity to 1.2 would make it, there's a risk of undersensing. So just let me ask, so which is the sensing polarity that you would be choosing here? This is an ICD. What is the sensing polarity that you'll be choosing? And there's only one device which will allow you to do so, and it's this one here. Because would you be...
Scan to tip.
Can to tip? No, that's unipolar. The ICDs will never
Never
sense
unipolar.
in unipolar because then you'll have mild potential oversensing, which the device will think is VF and shock. No, what you will be programming is integrated bipolar. So it's basically tip to RV coil, and that can really reduce the T-wave oversensing. And actually the Medtronic device is the only one which allows you to program a different sensitivity, a different sensing polarity. So that it's a very useful feature which I would like to see also in the other manufacturers. And sometimes also if you have a low R-wave amplitude in true bipolar, you can try the integrated bipolar with Medtronic and you get a bit better R-wave. The only thing you need to watch out for a little bit with the integrated bipolar sensitivity polarity is ensure that you don't get any P-wave oversensing, because if the coil crosses over the tricuspid valve, it may pick up the P-wave. And secondly, you may have a little bit of a high incidence of diaphragmatic potential oversensing. But that's the right answer.
Yes, yes, correct. So round 3 is up. 20 marks. This was 10 marks for Team B. So Team B is way ahead at the end of round 3 with 90 points. Team A is next with 30 points. Team D is third with 20 points. And Team C is at 10 points. Before we go on to the next round, we have a bonus question for the audience. Even the teams can answer. We'll let the audience answer. If they don't, then you answer. This will not fetch you any points. Yes. Yes, sir, please. That's the wrong answer, sir. Yes. What minimum length we can at least say that in C? Yes, sir, that's the correct answer. Sir? Ah, yes, it's there. So were you also going to give the same answer? Same answer. So the length of the helix is a round of applause for sir. No, so we gave diaries. So the length of the helix is 1.8 millimeters. The distance from the helix to the ring is 9 millimeters, and the width of the ring is 3.6 millimeters. So that amounts to 14.4 millimeters. But that may also be true that it is indeed 16.2 millimeters inside, because it is way deep inside, even some 2 millimeters proximal to the proximal end of the ring. So we'll go to the round 4. Round 4 is follow-up in conduction system pacing. The first question is aimed at Team D. So, what? D, Team D. If it's not clear, you just need to look at V1. That is the same patient as the previous question. Our question is, what is the threshold at the ring? So I'll tell the numbers above. 3, 2.75, 2.5, 2.25, 2, 1.75, 1.5, and so on till 0.5. You still have time, so you can, if you want to ask me something, what morphology is that, you can ask, because it may not be clear. There's some pointer. Not working. So mouse is not. Correct. That is the correct answer. 2.75 is the threshold. So 10 points to team D. The next question is for team A. So this is 2 years after the patient had been implanted with the his bundle lead. She did not report to us. We got it on a remote transmission. We can give 20 seconds more in this case. Decrease the sensitivity of the ventricular lead. That's the correct answer. So 10 points to team A. Oh, sorry. So what is happening is there is ventricular oversensing of the atrial signal again. For the first marker is ASVS. So you can see on the near field EGM RV tip to RV ring there is a blip there. So that coincides with the atrial signal. What we don't have here is the surface ECG, so we don't know whether this is a junctional beat or not. So the next beat you can see there is an ASVS, but then there is an intrinsic conduction. So there are two ventricular events as detected by the device. The next beat is correctly sensed and there is no ventricular oversensing, and it is followed by an AV delay with a V pace. Interestingly, that V pace is leading to far field R wave oversensing in the atrial channel. So there is ventricular oversensing of intrinsic atrial events, there is a far field R wave oversensing also. But what is to be done in this case is to make the ventricular channel less sensitive so that it can sense only the, it does not sense the atrial signal. Third beat, sir. Sir,
A sense, V sense is the first one. Second is ascens, vescens. What is says as vescens? What is that?
The second one, sir?
No, the third. First one is ascens, vescens. Second is ascens, vescens. What is that?
That's a conducted. That's the AS and VS. It's conducted.
It's blank, so it is of no consequence to the patient.
Okay, the question here is that the far field, the QRS, or is the retrograde?
So unlikely retrograde, sir. Too short, yes.
Too short, that's correct. So, well, applause to them, right? So
Yes. So 10 points to team A. So next question is for team B. I'm sure they will get it right. We'll give them less time also. So this is a patient with his bundle pacing, has come for a routine device follow-up. We, here, in every follow-up, we do a VVI unipole and bipole decremental output pacing. The same can be seen here. The markers above mention what output is it pacing. There is an intrinsic ECG on the right side. You have 4 options. So the trace above is VVI bipole decremental output pacing. Which of the following is false? That is against more.
So is it option D?
You said?
Option D.
Option D.
Yes.
D.
Yeah.
It's a wrong answer. So 10 seconds for team D to answer. Huh? Hello? Wrong answer. Question passes over to the audience. No, sir. That was the answer given by team D. So we are asking which is false, sir. C is false. So Sabri got the answer right. Yes. So A and D were just given. They make no sense because we'll keep the output higher only to make a safety margin. This is transition from his bundle pacing with, and big applause for Sabri. He was previously in device only, now he is into EP.
He is everywhere.
Yes. Sir, C, sir. Answer is easy only, sir, but it's a cringy question. So no points for team B. So next question is for team C. Again, a patient with his bundle pacing who has come for a routine device follow-up. The trace above is a 12-lead VVI unipole decremental output pacing. We are again asking which is false. No. Their question is this. Sorry, my mistake. That was the same question as before. So this is your question. His bundle pacing for a routine device follow-up. It's a VVI decremental output pacing shown in the trace 12 lead. Which one of the following is true? So there is consistent capture, which you can see. still have 20 seconds, so you can think. So 10 seconds more. So what you can see is there's a wider QRS on the left side. So 5 seconds more, there's no negative answer. No negative marks. You can attempt. And that's correct answer. No problem, but that's the correct answer. Hi, they told the correct answer. E. So we have 4 rounds which are over now. So they know only, sir. There is an isoelectric line and there is a narrow QRS. Maybe more non-selective to less non-selective, sir. Maybe not true selective. Selective.
Another good sign, because sometimes it's not very easy to see the isoelectric interval, and sometimes not very easy to see the pseudo-delta wave. But one thing which gives you away is also the amplitude of the QRS in lead 1 and in lead V6. And when you go from non-selective to selective, almost invariably the amplitude of the R wave goes down. Because the local capture of the anteroseptal region, just parahistion, is like an anteroseptal accessory pathway. The forces will really be directed, it will be positive in lead 1 and also in the inferior leads and in V6. So that is something which is you can very clearly see here.
So you know what, we actually put this up because this is what I think we discussed in the morning today or yesterday. You know, the capture thresholds of the selective Higgs bundle is so very low. It was,
so
I think,
do we change this morphology and just keep the output at, say, sir,
no,
1.2?
Yeah, you know what I'm trying to say is, you will end up, if you respect that safety margin, you end up in having little wider QRS. So this happens, you know. Selective. You see.
Maybe there is a P wave inside, sir.
No, it's okay. But you know, I agree. I mean.
P wave, there is a P wave inside.
Yeah, but then if you see most. Yeah. No, I think the beginning of the P wave is on the ascending wave of the R. That is a P wave. That's why it looks like a delta in some of the leads. But you know what is so very characteristic for the selective is look at the isoelectric. Isoelectric, I think, is almost like 30, 40 milliseconds definitely. Yeah. So the challenge sometimes is, you know, if you want to have a safety margin, you are going to get a wider QRS.
So at the end of round 4, Team B is still leading, but they have not troubled the scorers in the 4th round. They are still at 90. Team A is at 40 points. Now Team C and Team D are tied at 20 points. So we've come to the last round, which is the buzzer round. The rules of the round are, there will be 8 questions directed at all the teams. The one to press the buzzer first will get the chance to answer. They'll have 10 seconds to answer. If they don't answer or give a wrong answer, the question will be passed over to the audience. The question will not move to any other team. They have a time of about 60 seconds before they can think about pressing the buzzer. So it's not like that you hear the question and you have to press the buzzer immediately. So this is the first of the 8 questions. So according to the recent ESC pacing guidelines, what is the indication for conduction system pacing in, what is the highest indication which they have got in the pacing guidelines? So team B. Huh? Team B.
Class 2A.
Huh?
Class 2A, sir.
2A. Oh, that's the correct answer. So 20 mod team B. So the marking is 20 plus minus 10. Next. We have actually changed it here. That way you have chance to catch up also. Question 2. Team D.
For rotating in the select-driven lead, for preparation for rotating when the rotation is select-driven lead.
Okay, that is the correct answer. How do you prepare that?
So we need to first the screw we need to elongate, get it out, and after that we need to extra 20 turns we need to do it.
Not okay, sir. That is good only. This 20 points.
Yeah. You have to push that.
Yes, yes.
So 20, 10, and
Yes. So 20 points to team D. This is the question 3. Team B.
It is branches from the posterior descending artery. And
I wanted a complete answer, so that's not a complete answer. The question will go to the audience. Branches from the posterior descending artery. No, the question passes over to the audience, sorry. Sir? So that will not count. So they'll have to raise their hand and... Oh, no. Who raised? Sir, they raised the hand, she says. Who? Sanjay sir raised the hand, yes. So, sir, you can answer. I didn't get the answer. No, sir, we didn't get the answer yet, sir.
Supply from the LAD as well as the PDA. That's why it's very rarely affected in interval MI. You rarely get a posterior fascicular block.
So minus 10. Team B minus 10. So 5 more questions left. 100 points at stake. Yes. So a patient has been planned for a Medtronic CRTP procedure. We are saying Medtronic because this has some significance. During the implant, one lead was placed at the his bundle region. A bipolar LV lead has been placed in the posterolateral vein. Just before connecting with the pulse generator, the R waves from the his lead were found to be no more than 1.1 millivolt even after adjusting the loop. You are the operator. What will you do to ensure good R wave sensing for this patient? And you have to give the lab in 10 minutes, 15 minutes to the next operator. It's a bipolar CRTP. It's a Medtronic device. No, we'll give some more time. We'll give some more time.
His lab is still open.
So the clue is in the bipolar LV lead. Please.
Say Medtronic is screwing lead, right? So
Screwing lead.
the screw and can take that waivers.
After, I'll give you one more chance. We did everything. We tried to screw in more.
Maybe may not be facing the.
We changed the loop also. Five more seconds.
Change the polarity from this bundle to one of the lead of.
How is it possible? Because it's a Medtronic lead. LV lead cannot sense. But it's a bipolar LV lead. Correct. Should I give them the?
No, I think of course.
That's a great answer. Ma'am, yes, they answered that they'll change the ports. So which port will change? You'll put the H bundle lead in the LV port and the LV lead in the RV port, right? Yes, because that will be sensing.
So you are saying here because you chose the bipole, right?
Yes. I should have mentioned that sensing was good from the LV lead. So 20 points to Team D. So for the next question, their buzzer is still not orange. That buzzer is also not orange. So the next question is actually quite easy, so anyone can answer. So I'll tell them to be fast on their buzzers. Team D. You have 10 seconds.
C304.
Okay. Yes, correct. 20 points to Team D. Again, reset.
What is it? C304 is collector machine.
Yes, correct.
Actually, you got a good point here. C304 doesn't have a secondary curve. C304 is.
Secondary curve. Oh, that I didn't know. Sir. Oh, answer is here only, sir.
We didn't see that.
That's why I tell Medtronic people, don't put posters. Who sees that?
They didn't see, sir. No, sir. Oh, sir. Sir, I'll check. The numbering is different, but we'll go on. We have 3-4 more questions. This is the next question. This is a programmed ventricular stimulation performed during a left bundle pacing implant. We want you to comment on the refractory periods of the conduction system in myocardium. The V1 is the lead which you see just below the annotations. S1, S2. Team C. But what do we have to comment on the refractory periods of the conduction system in the myocardium? No, no, you can think and then say, you still have 5 minutes. You can say in a complete sentence clearly. Yes? V1 is the one which is below S1. We can still give you 10 seconds. Correct answer. Lost, yes, correct. Yes, more myocardial capture. That's correct. Correct. 20 points. Press. No. Actually, whoever presses for other 3 will be deactivated. So they pressed it first. Sync is the answer. Correct answer.
Sir, this is not working, sir.
No, it will work, sir. When you reset and then you press now. It's okay now. You can try.
Okay. It's not working again.
It's working over. Is it not working? The next question, so 20 points to team A. Dr. Pramod, correct. So 20 points to team A. So we have come to the last question. No, there are 2 more questions. There are 2 more questions. So next question comes up now. Team 8, your 10 seconds starts now. Team B, 10 seconds starts now. It started already. Time's up.
QS, option 2.
Huh?
Option 2, sir.
That is wrong. No. Yes, sir. Sir? No, sir was answering something, sir. So that is wrong, sir. Yes, sir. Yes. Okay. Next one. Anyone else from the audience? That's the correct answer. Correct. Priyak, sir. Then you give it to sir also. No, 2 diaries you bring. No? Give it now. So who gets negative mark? Okay. So next question is the last question. Last question coming up. Team C. That's the wrong answer. Anyone from the audience? It will not have. Huh? 70%. Sir? Team D? No, only one person. Oh, that is the correct answer, but you cannot. 70, sir. 70, sir. Oh, yes. Okay. Huh? Not working? For the last question, it did not work? So we have finished all our rounds. There are no questions. It was a very closely fought contest. Team B is at 90 and still wins. With the huh? Did you minus them? Minus 10? Minus 10? Minus 10 did you do? Okay. They had actually gone to 110 and then come back. So in round 5, Team B had given one correct answer and 2 wrong answers. So they stay on the same. So joint second are Team A and Team D with 80 points. So there was a 10. And Team C had 30 points. So we have interesting, attractive cash prizes for the winners and all participants. It's 10,000 for the winners and 5,000 for all the rest of them. So hope you all enjoyed the quiz. All of them can apply for an observership in 36 months. And it will be a paid observership. Thank you. So we'll move on to the next session, which is challenging EP cases. Challenging CSP cases.
I hope you stay back for in another 45 minutes to 1 hour we'll finish. Yeah, so we have some great presenters, they were kind enough that the quiz could be, taking the precedence. So we finished the quiz. Now, please invite the first speaker, first presenter.
It's time to learn from the experts. We have Dr. Vikas Kataria, intervention cardiologist and cardiac electrophysiologist, Holy Family Hospital, Delhi, to share his experience about left bundle branch area pacing.
Thank you. Good evening. It's not a challenging case. I'm just here to share my, our experience for left bundle branch area pacing in CRT indication. So we have been doing left bundle branch area pacing for almost slightly more than 2 years. Our initial few cases, we started with his bundle pacing. But after 2 or 3 cases, we realized the challenges with his bundle, and then gradually, or maybe not gradually, suddenly shifted to left bundle branch area pacing. And today I'm going to, initially we started with those patients who were not dependent on LV pacing. So for example, sick sinus syndrome or intermittent 2-to-1 block. And then as our confidence increased on this technique, we started implanting left bundle branch pacing for all the indication. Today I'm going to share our experience on left bundle branch area pacing for CRT indication. So recently we compiled and analyzed our data of left bundle branch pacing in CRT requiring patients. So all these indications were typical patients, typical CRT indications, broad QRS, left bundle branch morphology, ejection fraction less than 35%, and symptomatic despite heart failure therapy. So we recorded all the device related and clinical parameters. So I'll just present two cases from our case series. So the first is a 62-year-old lady, or a known case of non-ischemic cardiomyopathy, ejection fraction 28%. She had AF, atrial fibrillation with fast controlled ventricular rate, and she was symptomatic despite the medical therapy. She was already on, implanted CRTD device 2 years back. It was conventional biventricular pacemaker, pacemaker defibrillator, minus the atrial lead, because she was in AF, so there was no atrial lead implanted. After 1 or 2 follow-ups, she was lost to follow-up, and one fine day, she suddenly reappears with the recurrence of symptoms after approximately slightly less than 2 years. So this was the ECG 2 years back after the bi-V pacing. This is not very great, but at the same time, you can see some R wave in V1. The QRS is not very great. And this time, when she comes after 2 years, this is her ECG. So we can see that the QRS is broad, and there's loss of R wave, which was there earlier in V1. So according to me, this is not pacing anymore in the LV. The device interrogation was done. The biventricular pacing was hardly 60%. The left ventricular lead was neither sensing, not capturing, even at high outputs. So we got the X-ray done, and you can see this left LV lead is displaced and has come up all the way to the vena cava. So we pulled the old records and saw that this is 2-year-old records which we retrieved. And at that time, there was 2 veins, one you can see here and the other lower down. So initially, the implanter tried to put it there in the upper one, but I think because of tortuosity and the size of the vein, the upper vein could not be used. The attempt to implant the lead here failed. So ultimately, it had to be implanted in the lower vein. And this was the final position 2 years back. And obviously, the lead has displanted, and this is the current fluoroscopy. The LV lead is displaced from that particular position and is in the vena cava. So we discussed with the family and the treatment options, whether to reimplant versus the left bundle branch pacing, and they opted for left bundle branch pacing. So we did the left bundle branch pacing. This is the, we could not get a good thresholds here, or the lead was not going up, so we had to move down a little bit, like our live case today. So this was the ECG without left bundle branch pacing. And after left bundle branch pacing, this was the one. Although it was not normal looking, but still it is narrower than the original pacing. And after approximately 1 month, we did the AV nodal ablation. And it has been almost slightly more than 7 months after AV nodal ablation. The device and lead parameters are within normal limits, and now the patient is almost 100% biventricular paced. She's symptomatically better. The ejection fraction has increased to 38%. No atrial lead because of AF. This is the second case, a 67-year-old lady. She had a PCI, post-PCI 2006. Ejection fraction since then is 25%. She's symptomatic. Recently, the symptoms have worsened, and she's now class 3 symptoms despite the guideline-directed medical therapy. And during the last 6 months, she has had 2 hospital admissions for decompensation. And during one of these admissions in some other hospital, her angiogram was also done to rule out any coronary obstruction, and it was the patent stents. There was no further coronary obstruction. And this was the ECG. The QRS is broad, approximately 150, 160 milliseconds. So we decided to put a CRTD using this left bundle branch conduction system pacing. We implanted the RV ICD coil lead first, followed by the left bundle, and this was the final position. And this was the QRS we could get, significantly narrow, almost normal looking duration. So patient was discharged. It's almost 11 months post-procedure. In the last 11 months, fortunately, there was no hospital admissions. Patient is symptomatically better. Device parameters are normal. Ejection fraction has gone up to 34%. So since during this last 1.5 to 2 years, we have implanted approximately 16 left bundle area pacing for this CRT indication. All patients had baseline left bundle branch block, and the mean age was 59.3. 37% were women. 33%, 1/3 of them had underlying coronary artery disease. The initial QRS was 147. Mean ejection fraction pre-procedure was 28. The procedure time was approximately 100.2 minutes. Fluoro time 22. The RA was 12 and threshold was 0.8. And this was the post-procedure data. The QRS duration in most of the patients, almost all of the patients reduced. Ejection fraction, except for few patients, it showed an improvement. So the pre-procedure QRS was 147, which we could bring down to 116. The ejection fraction mean was 28.2, which increased to 38.9. So these points have already been repeated multiple times since morning. And I'll just stop here and just re-emphasize that left bundle branch area pacing has come up as an alternative for conventional biventricular pacing, and it shows significant clinical and echocardiographic improvements. Thank you. Okay, thanks.
Next, I invite Dr. P.V. Sanjay, consultant cardiologist and cardiac electrophysiologist from SIMS Hospital, Chennai, with a complex pacing case where physiology may not be enough.
Hello. Yeah. Good evening to one and all present here. So there are two cases, probably on some nuances of physiological pacing. And as Ashish sir said, most of the last 2 days have been an exhaustive session. So going on to my case, so this was a 37-year-old gentleman who was referred to our center for a CRTD pocket infection. So he had an initial pacemaker, pacing induced LV dysfunction probable, then he was put a CRTD and he had a pocket infection. So he came to our center And the management plan was his device interrogation showed an intrinsic sinus rhythm with 1:1 AV conduction. At faster rates, he had AV block, Mobitz type 2, and he had one asymptomatic run of a slow VT lasting for 1 minute. So echo showed severe LV dysfunction. There was obvious thinning of the basal septum. He had bicuspid aortic valve with no stenosis. So TE, there were vegetations around the lead. So he was started on antibiotics based on the cultures. So he was planned for lead extraction and reimplantation of a CRTD, the contralateral side. So this was his Holter post-extraction. The extraction was uneventful. So he had runs of 2:1 AV block, and he had a run of asymptomatic, reasonably slow VT. So this patient, a young guy with both bradycardia and ventricular tachycardia, so the suspicion of infiltrative cardiomyopathy was always there. So this was, I wanted to initially plan for physiological pacing, left bundle branch area pacing through the right side. So this was the initial site of screw-in, and I was able to consistently demonstrate left bundle branch capture. The LVAT was, though the selective and non-selective capture was obvious, and the STIM to LVAT was consistently around 86 to 90 millisecond at high and low, and bipolar again you had from selective to non-selective, and even at one side we got a good left bundle branch potential, but the interesting thing was at none of the sites the LVAT I was able to narrow the LVAT to less than say 70 millisecond. His intrinsic LVAT was 70. His LVAT during pacing at all these sites was 86. So these were some of the sites, proximal septum, distal septum. So, and there's a point where I got a retrograde hiss. So I was sure I was able to capture the conduction system, but however, the LVAT was consistently at 90 millisecond, and his intrinsic LVAT, as the images show, was 70 millisecond. So, and based on the clinical profile, I wanted to send the septal tissues which I got from the lead tip for histopathology, and I decided to proceed with a conventional CRTD through the right side. Yeah. So these were the pre and post procedure ECGs, and the biopsy report, there was no evidence of interstitial fibrosis. There was some interstitial fibrosis, but without fatty infiltration. There was no epithelioid granulomas or lymphangiogenesis, and immunohistochemical analysis was not sent. Interestingly, the follow-up PET, which I did after 6 months, turned out positive for infiltrative cardiomyopathy. So I think the decision was justified. So I wanted the learning point, probably the point for discussion from the seniors and the audience, was that in a particular case where we see the intrinsic LVAT is lesser than what we are able to achieve despite good conduction system capture, would we still accept it, or would we evaluate for infiltrative cardiomyopathy or distal conduction system disease? That is one point which I wanted from the seniors here. And I thought that the left bundle lead itself was useful as a bioptome in this particular case. And yes, sir. So this is another interesting case. I just wanted to discuss this. So this was done very recently. So this is actually the second case. So I'll quickly go through it. It's an Antrol MI patient post-CABG. He had a Lima to LAD and SVG to the RCA. So he had baseline RBB with a normal axis. So this rhythm was there for the last 2 years. And the echo showed moderate LV dysfunction. He had recurrent failure hospitalization for the last 1 year. Again, the basal septum was scarred. He had 2 episodes of syncope. ECG, there was intermittent complete AV block. So this was the baseline ECG. It had RBB with abnormal PR interval. And in the cath lab, there was evidence of intermittent AV block, and I had kept the VVI backup pacing at 30, so it took over. And the HV interval was 82 millisecond, and the baseline LVAT was 86 millisecond. And I was wondering whether to offer him a CRTD, physiological pacing, or something else. So I'd come across an interesting article. I think all of us should read about it in our very own IPEJ. So this was the strain imaging of this patient. So if you see, the lateral wall contraction is reasonably brisk, but I'll go through the video again. Oh, sorry. So I felt there was some delay in the basal septum. So not the mid or the distal septum. The basal septum had a scar. So, so coming on to the literature. So what does RBB with LV dysfunction? So what does the literature say? So we have Pogrendisa's article. And again, it's very interesting to go through the data. So I think the response rate, clinical and echocardiographic response, where the patient improved symptomatically and there was an improvement in the LV ejection fraction more than 5 to 10%, was 60 to 61% in this study. And responders included in multivariate analysis female, and where you're able to reduce the QRS reduction by 10 millisecond or the LVAT by 5 millisecond. So these were the only predictors. Interestingly, wherever you eliminated the RBB, say by a QS, anodal capture, or a QR, you actually did not show improvement. So what, again, so you had the baseline QRS duration, the QRS axis, I think in this group, around 60% were RBB with the left axis. And the primary indication for CRT, the RBB elimination or attenuation during left bundle branch area pacing, did not predict clinical or echocardiographic outcome. RBB elimination was defined as no R prime in V1 with minimal or no S waves in V5, V6. And attenuation was just described as a decrease in the amplitude or width of R prime. So, and this was the article which I was talking to you about. It's a very interesting article, and I go through the IPEJ rigorously. And I found this article, I read this article probably a month before, and when I had a similar case. So this was an article where they've actually implanted an RV pacing lead alone in somebody with a right bundle branch block and normal, not a left axis, a normal axis or a rightward axis. And they've shown clinical and echocardiographic improvement by just changing the AV delays and allowing the RV pacing to fuse with the RBB with the LPHB. So their rationale was, so in the conventional LBB, you have a septal flash, you know, the septal and lateral delay, but they postulated that you have something called a lateroseptal delay, where the septum is delayed because of conduction or the block through the posterior fascicle. So, and what they have shown is, so this was the patient's, their patient's intrinsic QRS, and by critically adjusting the AV delay in this particular patient, they were able to give an echocardiographic improvement. So this article got me thinking when I had my own case. So I was wondering what to do, and that was the reason why I went in with the strain imaging. So I decided to go with physiological pacing. His basal septum was definitely scarred. I was not able to penetrate. The sense star waves at that point were less than 1. So I tried to achieve a fascicular capture, and I wanted to achieve an anodal capture. The reason being, I wanted to make sure at a bipolar pacing output of say 3 or 3.5, I was capturing the RV septum also. So this was a conscious decision. His septum was around 18 millimeter thick. So despite, if it was a normal case, I would have probably given a couple of more turns for the lead tip to enter into the LV side. But I was able to demonstrate again at bipolar, there was some selective and non-selective capture. So I'll get on to the ECGs. So these were the fusion of the patient with at various AV delays. So at an AV delay of 120 millisecond, so this was his ECG. So his LVAT was 70 millisecond, and there was a QR in V1 or a QS in V1. But this was an, so at this point the patient had intrinsic conduction. It was not an AV block. So he had his ongoing rhythm. And at an AV delay of 140 millisecond, this was his QRS. And at an AV delay of 180 millisecond, we got an even more narrower QRS. And at 200 millisecond, where it was fusing with the underlying RBB, the QRS looked more impressive. So I again repeated a strain imaging at all the 4 combinations. So, and again, at all 4 AV delays, the LVAT was consistently I think it was 60 millisecond. And this was the strain plot. This case was done probably a week before, so I think it was 48 hours post-procedure. So this was the intrinsic strain where there was definite septal delay and some maybe anterior and lateral delay. And this was at an AV delay of 160 millisecond. So I thought that the septal synchrony was definitely there. I'm not sure about the echocardiographic outcome or his clinical response. I'll probably monitor him. So RBB with LV dysfunction, it's a unique subset. Left bundle branch area pacing works in 60% of the cases. Narrowing of QRS and shortening of the LV80, they predict success in this subgroup. Elimination of RBB in V1 does not predict success. But RV pacing with fusing of the intrinsic QRS, it's ingenious, it needs evaluation. And does the axis of the QRS determine if RV pacing or LBB area pacing would be better? Because as I mentioned, in Pugarendi sir's group and Shanmugasundaram sir's group, it was around 65% were RBB with a left axis. And I think normal axis were 25. So the RBB with right bundle branch, right axis was just maybe 20%. So anodal pacing with conscious penetration of lead, it helps us in giving a programming capability, as in my patient where suppose he goes into a persistent AV block, I lose the edge over RV anodal capture, but still the LV80 is consistently narrow. I'm sure that would not cause a pacing-induced cardiomyopathy. I would love to hear the opinion of the seniors present here regarding those 2 points. Thank you. Sir. Yes, sir.
After extraction,
yes,
after some time, for you're suspecting granulomatous disease,
yes, sir,
you
yes,
do a PET CT,
I
just
couldn't, sir, because he had this intermittent AV block, and it was an international patient. So we don't have a PET CT in our hospital. So he had to be shifted to another center. So that was the reason why we didn't do an initial PET CT, sir. We did it when he came for follow-up after, I think, 4 months. Thank you, sir.
Thank you, sir. The next case is about CSP in non-EP setup by Dr. Ravi Cherian, Senior Consultant, Interventional Cardiologist in Believers Church Medical College of Hospital, Tiruvalla.
Good evening to all. I would thank Ula sir for giving me this opportunity. I'm a non-EP fellow and I don't have an EP setup at my hospital. So I do all these cases with my 12V DCG. I have a portable 12V DCG. It has all my cases with the 12V DCG. So initially I did one his bundle. After that, this left bundle came into the picture. So I was thinking what is this left bundle, whether it is possible with whether I'll be able to do it or not, because initially everybody was telling it is only done with an EP setup. So I was really worried about it. So then I came to read about this article, The Beginner's Guide to Permanent Left Bundle Branch Placing. So after that, I had a patient, 62 years old male, hypertensive, dilated cardiomyopathy with normal coronaries and severe LV. So I thought I'll go with the left bundle pacing for this. So this is a severe LV, global hypokinesia, dilated LV, moderate MR. And the LV measurements was around 62, 52, and the EF was around 28%. So I thought I'll try my luck. This was a ECG prior to the pacing. So I did a left bundle pacing here. So after the left bundle pacing, this was a ECG. I was okay with it, but I don't know whether this was a perfect ECG or not. So I tried an LV pacing. It was much wide, and this was the left bundle pacing alone. So I thought this was better compared to the LV pacing alone. Then I did an simultaneous pacing at 0 milliseconds. So then I got quite a wide QRS. I was not that happy much. Then I did a lot, left bundle to LV at a 30 milliseconds, and this QRS appears narrow, but not that better than, I don't know. I need your comments. So after that, the LV has improved, and she was symptomatically better. And after 2 weeks post-procedure, actually I was thinking whether what will happen to the patient, but after 2 weeks, the LV has improved from 62 to 40 and from 52 to 30, and EF has gone up to 50. And the echo was far, far better. And the MR has reduced a lot. And this was the ECG after 2 weeks with a 30 milliseconds left bundle to CS. And I think the ECG was far, far better compared to the previous ECGs. And as long as the patient is asymptomatic, I also was happy. So the next question, the next cases which I want to present is, it was a bicuspid valve with a severe AS and moderate AR, and the patient had a sinus valsalva aneurysm, right? So they did the CTOS team did a aortic valve replacement, and after the aortic valve replacement, they thought they'll repair the sinus of valsalva. So after repair of the sinus of valsalva, the first post-op, the 0 post-op, the ECG was like this, and subsequently the patient went for a complete heart block. So as you know, the conduction system zone, it goes through the right and the non-coronary cusp, and hence a patient has gone for a complete heart block. So I thought then I'll just try my same left bundle pacing for this patient, and I did a DDR Spera in October 2020. And prior to discharge, this was the ECG at a threshold of 1 and impedance of 540. So post-procedures, 2 weeks, just 2 days back, I took the ECG, and this was a ECG. So happy, I had a good, excellent ECG, that is what I feel, and at a threshold of 1.2 with an impedance of 542. So these were the 2 cases. And I did around 18 cases totally in this. One was the first is bundle which I've done. Afterward, all were the left bundle pacing. And overall, the impedance was, initially the impedance was around 720, and now the impedance is around 5 to 540. And the threshold we are maintaining around 1.2. Thank you.
Well done, very nice results. For the first 2 years when I was doing his bundle pacing, I was doing it without an EP system, 12 lead ECG, a Merlin programmer, and I found it okay. It was because when you do the thresholds, you see clear transitions in the QRS morphology and all. But LBBP, I think an EP system is better because you have very nice results there. But if you want to do precise measurements of R-wave peak times and so forth, that's very difficult with a standard ECG, even if you print fast paper speed and so forth.
Actually, I can get the transition. I had few ECGs where I had the transition where we can see it, but unfortunately I could not add it. But I had it because I have a small portable ECG machine. It's connected to the patient, and it's live always.
So that's very good. So if you have LBBP with a transition, that's great, because that is the gold standard to say that you've got conduction system capture. The thing is that we don't always have it because the thresholds between the myocardium and the conduction system are sometimes close. And so we don't always have it. And then you need to do all these measurements, right? And for that, I think some ECG or a portable ECG EP system or something is something which is useful.
Actually, I had one case. I finished the left bundle, and prior to shifting, everything was fine. But after shifting, I've taken a 12 lead ECG. I found the QRS to be very wide. But later on, I understood that the people in the cath lab has connected the leads upside down. So I had to re-explore and reposition this thing.
But Cherian, you know what? We chose this case is because I see in him and his technology, which is going to be adopted widely. No questions. There are purists like you, Dr. Shanmuga. We are actually looking at defining selective, non-selective. and then there are so many things, right? But at the end of the day, what we all expect is, the cute QRS and as normal access as possible. The criteria for, selective, non-selective, etc., it will remain for theoretical purposes, for research purposes, and for the follow-up. But in the clinical practice, this is going to be I think the gold standard. We should be encouraging, the non-EP and interventional, especially in India. I do not want to see any one of the paced QRS complexes wide in the country. That is only possible if all the implanters in the country, they try to do something better than the RV apical pacing. Because, hold a second. You are also getting a little emotional here. I understand. Now, you know what, actually, I look this way. This whole symposium is going to be, incomplete without the participation. Like, how honestly he was telling that he is non-EP, but look at the passion what he has. There are so many interventional cardiologists in the country who understands the importance of pacing-induced cardiomyopathy.
Yeah.
All right, so anyway, you are going to stay tomorrow too.
I had a case who had developed a pacing-induced cardiomyopathy. I changed the patient to a CRT with a left bundle, and he had even RV dysfunction. But now the RV dysfunction has improved. LV dysfunction is slowly getting improved.
All right. Yes, sorry. You know what? Tomorrow again, we are going to be exposing another newer technology that I think is absolutely great. It is going to be miniaturizing the EP environment. Mr. Greg, if he is around, he could. Yes. So tomorrow you are going to be starting off the introduction of your system. I'll take such a great pride that your system was used first time in the country, and the big guys around, and then how we will really make miniaturization of the elaborate EP system one has. So Greg, thank you, and then and we look forward to your presentation tomorrow, followed by actual demonstration. Having said that, this another one issue here. If you have a great CS anatomy, and you have a typical left bundle branch block, and if you have a CS lead there, and an RV apical, I think that's the best. And now, if it is not there, the tributary is not there, if you get his bundle there, or the left bundle there at the right spot, and if you get the QRS, I do not think we should be optimizing at all because it's a waste. Do you agree with that?
I mean, if you have his bundle pacing and you completely correct the left bundle branch block, then you don't really need to optimize. That's for sure. You've corrected it like that. And with biventricular pacing, then I think probably fusion pacing is something which is very important, where you can also get excellent results. But then I think it's useful to have algorithms and so forth which are able to help you with optimization nevertheless.
Yeah, please.
So I've probably, because of this problem, sometimes in my hospital, I had to go to other hospitals, my own hospital chain, to do these left bundle pacing without EP setup. Yeah. Done about 10 initially. I was doing only for Brady indications, then did 3 or 4 of CRTs. So as he said, continuous ECG, sometimes it's a wastage of so much paper. So we started taking mobile pictures at 50 mm, and then you zoom the screen. The two criteria which are practical if you're doing it in this setup is, one is the QRS duration, and then LVAT constant at different pacing this thing. So with these two, you can pretty much manage a reasonable without an EP setup.
Yeah, another addition is TMT machine. So TMT, so that even you can increase the sweep speed also.
So 50 mm is.
Yeah, so that is one thing in the non-EP setup. And regarding Ullah sir's question, like adding a CS lead, whether it's going to help when you have a complete correction with his bundle or left bundle branch pacing. That is, we have close to 100 patients with non-ischemic DCM, normal coronaries, LBBB with the dual chamber pacers. Almost 40% are normalizers, and super responders have not analyzed it, and majority of them are super responders. There are only meager of the patient who had a suboptimal response. So I think with that needs again to make it into the guidelines, we need to have a randomized trial. So once we have a randomized trial comparing a dual chamber pacer versus BiV pacing or a backup CS lead along with the left bundle, then we can probably get into the guidelines. But at least in India, where economy is a big issue, still we can have reasonably good results with the dual chamber pacer, at least in non-ischemic cardiomyopathy. Yeah, exactly. Dual chamber. Yeah, so you can put a lot CRT and dual chamber, keep the CS lead off and keep the CS lead on in some patients. That can be done with 2 groups, can be subclassified into 3 groups.
Dr. Harit, I want to know what is for the audience, in your center, what is your protocol for a patient with left bundle branch block, DCM? What do you do? Left bundle CRT, or what do you do exactly?
I still go with conventional biventricular pacing if he's got the typical left bundle branch block, simply because we have so much evidence that this really works well. Even though I'm also a believer with LBBP in these instances. With CS pacing, we may not only be correcting the ECG, but there may be other mechanisms with the pacing which somehow interfere and also improve the ejection fraction. So BiV pacing is great therapy. It's one of the big successes, I think, of device therapy, over the last decades. It's done a lot of good for our patients, and we'll have to see if LBBP does as well or better, maybe. But for the time being, I'm still sticking with BiV pacing in these patients.
So when you're doing a CRTP, do you put the CS lead first or the left bundle lead first? Or you put a CS lead and put RV apex and see what, and if not satisfied, then go to the lot? Is that
so? If it's a CRTP, then I actually put an LBBP in
first?
And then you can see, but there's going to be a CS lead, because with an ICD it's different, you can't do that. So, but with the CRTP, which is a minority of my patients actually.
That's
correct.
how
in your part of the world. Yeah.
Correct. Actually, by the way, you know what, the CSP, at least one thing it made obsolete, and that is the epicardial CS or epicardial LV. That's one thing which is now made redundant and obsolete. I do not think it has crossed any more limits than this. Yes.
What is your center's protocol for a classical LVVV?
Oh, this is conventional CRT presently. Yeah. You know what? We have CRT experts in our institute. For example, Ramkumar was here. You know what? You give him. You know what? He will give me the best of the QRS. He gives me the great follow-up. What else you require? It's not necessarily, you need to have his bundle pacing with the correction of the left bundle branch block buzz. It is just the cute QRS, which stood the test of the time. And the ischemic cardiomyopathy device therapy, it's not device implantation. It is the follow-up of that patient. It's just not the implantation. And you require, kind of a team to treat these patients, not just the implanters. Yeah, and for example, in my institute, we have the implanter who is also the best of the echocardiographer, who is the best of the, for the medical therapies also.
These questions are just to give a final message to the audience how it goes on. Shanmuga, I am sure it's going to be your answer is going to be different in your center, right?
I don't know why it should be different. He sets the standards.
No,
we follow
you. Got a question. Classical LVVB, NICM. What is your protocol for pacing?
So for that matter, any cardiomyopathy patients, our first thing is to get a cardiac MRI done before proceeding for any intervention. So based on that, if there is no septal scar, a typical non-ischemic cardiomyopathy, so we'll always go for a left bundle with a right atrial lead. So only if the LVAT is more than 100 milliseconds, that's our protocol. So we try to put a CS lead and optimize it. If the LVAT is less than 90 to 100 milliseconds, we'll accept it, put a dual chamber pacemaker. But if we find any scar, still we'll try our luck with a left bundle lead, because many times a patchy scar here and there will allow us to enter either into the anterior fascicle or posterior fascicle. So we'll try to capture it. So based on the LVAT, we'll decide. But if there is a scar in the anterior septum, like a case of a antral MI proximal LAD scar, then it's not worth attempting left bundles. Try to go for a conventional. That's what.
But Shanmuga, today's case, for example.
Yeah, this case, I don't know. I don't have an MRA.
I think
So
what happens is when you are going to be recommending the therapy for a left bundle branch block for cardiomyopathy, please do not recommend the patients, I will do a dual chamber pacemaker with a left bundle area.
no, it should be based on LVAT. It should be based on LVAT.
No, but then, see, the point here is, what is that you recommend? The patient gets into the lab with the preparation of certain funds in hand.
Yeah. Yeah, that's what.
So, you've got to be telling the patient that you are going to do CRT. It's cost double than your dual chamber. This is what we are requiring.
Yeah, exactly.
So irrespective of whether it's ischemic or a non-ischemic like what we saw, you've got to tell your patients with cardiomyopathy, typical LBBB, that you are a candidate for the CRT. And if you are lucky, you would save money because I am using a different technology. You will use only 2 weeks. But you cannot just recommend upfront.
Yeah.
But see, you do not begin with the discussion of the low cost. You tell them this is the best.
Yeah.
And most often another 1 lakh rupees somehow the patient will arrange. This is what my thing.
That's what I think. I think getting a cardiac MRI will help us in many of these patients. Yeah, so patchy scar, definitely we have to advise them, like they may need an additional CS lead. At least in majority of, I can say some 80 or 90% of a non-ischemic cardiomyopathy patient, they'll not have any scar. They'll have scar at the RV insertion site. That's the most common site to have. Otherwise, it will be scar-free. But if it is a patchy scar here and there, it's better to go with an idea of CS.
Thank you. I purposely gave to 3 people with Shanmuga's disclaimer that he's biased.
Yeah, so you know what, we'll probably follow it very blindly. Just wait for a while, he will bring in another paper. Yeah, sure. He is going to bring, by the way, for that reason, another applause for him. See, he is bringing the guidelines, he's bringing the research work, from India. Who did such an enormous job so far? I don't think anybody who actually influenced even the guidelines and the practices. So presently he thinks you are biased, but I am not biased that you are biased. You know what? I think your statements and your belief, I think it is going to win the arguments and the debates.
Yeah, whatever you're saying, I think I have to take it because everything started from your lab. Exactly, I can tell the date. It was, I think, on January 2019, 7th or 8th. You showed the photo yesterday. So before that day, I was not even aware what is Hispan pacing is. I've never seen a Hispan catheter. I've never seen a sheath. And I was witnessing the beauty of Dr. Parikshit Sharma. He has corrected one LBBB and he has corrected one RBBB. So there everything started, and so I think if I was supposed to get into my hospital work on that day, because they said like the case is going to get cancelled or something, they said. So I've cancelled my travel, and then Srirag pushed me, no, you should come. There is one case plan, you should come. I think that changed my whole AP career, thanks to you. And after that, I never miss any of your calls.
Ah, thanks.
So I think you called me for HT Grid launch also. So I could feel the difference. So I'll say everything is for you, and whatever you say, I'll take it, sir. Thank you.
We have came to the last presentation of the day. I may now request Dr. Kumar Narayanan, Senior Consultant Cardiologist and Electrophysiologist from Medicover Hospital, Hyderabad, to endure his experience in conduction system pacing.
Thank you, and it's an honor for me to be here. Thanks, Dr. Ullas, again for the kind invitation. So I shouldn't take much time at the end of the day. I'll just share a few interesting ECGs from some of the cases so that I can pick your brains and see what exactly I have paced in these cases. So hopefully the screen will come up now. Thank you. This is the first case. This is a 63-year-old female with complete heart block with a baseline QRS duration of 150 milliseconds, and you can see like a left bundle kind of pattern. And we tried left bundle pacing in this particular case, and this post pacemaker, I'm just showing you the ECG here. So I would love the thoughts of the audience about what site is getting paced here. We were happy at that point with this result, but now being wiser, I'm taking a more critical look at this ECG. So you can see that there is kind of, R wave in V1, and the QRS duration is fairly narrow, about 120 milliseconds. But the couple of points worth noting are the dominantly negative complexes in V5 and V6, as well as the negativity in lead 2. So just to share with you how the case went, this was the initial site. So we have a His bundle catheter to mark the location of the His, and this was the initial site where we attempted to go, and this was the paced morphology before screwing in. And we don't have a W pattern in V1, but if you, the rest of the things actually look fairly okay here. Lead 2 is positive, and there is some discordance between AVL and AVR. But we couldn't screw in here. We tried a lot, but so suspecting that there was some fibrosis at this site, we went a little distal, which is what Dr. Huang's guide kind of recommends, and say try a little more distally. And then at this distal site, we do have a W pattern or a notch in V1, but the thing to note here is lead 2 has become negative. So, but we could penetrate at this site, and as the lead was screwed in, we can see that we are developing a R wave, R prime in V1, and we finally get a good kind of R prime. And again, the noteworthy points are that you have a dominantly negative complex in the lateral leads and also negative in lead 2 at the final position, though and also here, the interesting question would be how to measure the LVAT when you have a dominantly negative complex, because if you take it to that very tiny R in V6, it's very short, but I feel that's probably not the right way to do it in these cases, but I'm not sure about that. So this is case 1. So to go back to the ECG, I'm not sure. We call it probably LV septal pacing, and I also wonder if some kind of the left posterior fascicle has been captured at a little more distal site. Case number 2, a 70-year-old female with complete heart block, but no bundle branch block at baseline with fairly negative, narrow-looking QRS. This is again the post-pacing morphology. Again, you can see an R prime or a RBBB kind of morphology in V1. Again, the similar issue. You can see very small R and dominant S and negative in lead 2. And this was again a relatively more distal site of screwing in. This has been, I wanted to highlight the issue in a few cases where we faced that when we tried to go more basally or superiorly, we struggled to screw in, and we moved a little more distally, and then we had this kind of a morphology. This is another case to contrast with the first 2 cases, a 58-year-old male with intermittent complete heart block, and at other times you have a very long PR interval with a left bundle-like pattern. And here there is no His catheter, but you can see from the apex of the temporary pacing catheter, we are a little more proximal in this case, and we could penetrate in. And here you can see that before we screw in, we don't have the W pattern, and we do have positivity in lead 2 and discordance in AVL and AVR. And so we ignored the W pattern, and then we went ahead and screwed in, and we have the RBBB kind of morphology in V1, and here we could find a QRS duration of 125 finally, and an LVAT of 76, which was fixed. And the post-pacing ECG, here we can see a fairly narrow QRS, about 100 to 110 milliseconds. And probably because of anodal capture here, we have lost the R prime in V1, and and to contrast here, now we have the, the positivity in the lateral leads, a short LVAT, and your lead 2 is also positive. So few points to ponder. Notch in V1, not always. I think we talked about it before. Wandering too distally, maybe an error in some of the cases where we are getting LV septal maybe rather than true LBBB pacing. But looking at some of those QRSs, the thought does enter whether how good is LV septal pacing. Maybe in some cases it's also reasonable. So this is the way LB left bundle pacing versus septal pacing has been defined. And just to summarize some of the points which was written up in a review article. So when you're capturing the proximal trunk or the fascicles versus just capturing the septal myocardium, and again, even in this paper, it seemed to indicate the issue that if you kind of tend to wander a little more distally, mid-level between apex and base, you may tend to end up more often with LV septal rather than with true left bundle capture. And you will not have a demonstrable left bundle potential, and your stim to LVAT will be longer. The only dilemma in those two cases was how to measure the stim to LVAT if you end up with the dominant S in the lateral leads. And the LV synchronization is suspected to be less than optimal. But I think it would be interesting to see some long-term data, because I have a feeling that a lot of cases would end up with LV septal pacing. Not a lot, but some proportion of cases would end up with LV septal pacing. A recent small paper which came out from a Chinese group comparing LV septal pacing to actual left bundle capture showed reasonable parameters, though of course the paced QRS duration was lesser with left bundle pacing, and the correction of QRS or the delta QRS was better with left bundle pacing, and the LVAT was shorter. But in this paper, they had an impressively short LVAT with LV septal pacing as well. So I don't know if, but this was a pretty small study, so I don't know what larger numbers would show. So, and also another recent publication, but this is where they paced the LV septal myocardium by putting an EP catheter from the LV side. And again, they showed reasonable hemodynamic and EP effects with LV septal pacing as well. So I think this is something which in the long run needs to be compared. So just with these few points, I conclude my presentation. Thank you.
I think the timing was perfect. So what you showed was actually the entire revision of all the things which we learned since morning. See, I just was wondering, usually when you are trying more and more, the lead tracks upwards. In one of yours, I wanted to know the RAO equivalent of that particular, you have that?
I don't have that RAO right now.
No, but it's very unusual.
For the lead to track down like that?
Yes.
Okay.
What is that? I'm curious.
Yeah, even I'm not sure of the reason why. We were trying to do all the recommended things, keep the sheath as horizontal as possible, try to get support, etc. But we did have, and I suspected it was an oblique tracking, and it was kind of going down.
It doesn't happen. I have not seen.
Okay.
And then it was like what, left posterior fascicle captured there?
That's what I suspect based on my ECG morphology and the fairly impressive, I would say, relatively narrow QRS I got. So I felt that some component of the conduction system was being captured. Probably it was close to the left posterior fascicle because I had gone rather distally and inferior. So that's what I suspect. But I do remember the fact that it tracked downward this way, and I'm not sure of the reason why that happened.
Right.
Yeah.
Do you remember in the RAO, it was actually not anterior, it was kind of going towards the apex even in the RAO?
Yes, yes.
All right, sir, thank you. Shanmuga, your comments? No, not that. You take some other same. Don't address this.
Oh, yeah, that's what the ideal starting point is always in RAO. The LAO should be used for only for deploying the lead, and the ideal starting point should be RAO. And another thing regarding this measurement of LVAT, if you go distally, the LVAT will get better and better, but that will be compensated by increase in the S-wave duration. So I don't know, probably Dr. Haran can describe like, so how good is LV fascicular pacing? I know Mila's study, a lot of patients ended up in getting a fascicular pacing, and Marek is very particular about getting into the fascicles rather than the proximal bundle. Whether there is any hemodynamic difference and long-term clinical outcome difference between a proximal bundle pacing and fascicle pacing, and it will be extremely difficult to digest that LVAT of 46, but the QRS will look bizarre because the SPA will be prolonged. So how to confirm that that we are really capturing the fascicle? Of course, if you have potential, it's okay. But in those patients with the baseline LB, maybe it will be difficult. Yeah.
Your cases are very good because we see this sometimes. Our deep S in V5, V6, and then how do you measure this R wave peak time? When you measure it, when you have a small R, it's sometimes almost too good to be true. It's like 40 milliseconds. So I don't really know if this really represents, lateral LV activation. You get this pattern when you are inferior and a little bit more apical. But in the end, the QRS duration itself is very nice. It's short. And if you also showed the study by Salden, that's the group from Maastricht, and they're of course pushing very much for LV septal pacing because they actually initiated this even before Wei Jianhuang introduced left bundle branch pacing. So sort of people defend what they introduced, which is a pity because you should defend in the end what really works. But I don't know, no one knows. We know that QRS width is important, right, from CRT, and we have several series that show it is. So probably a more physiological looking QRS. Now the axis is not physiological, but in the end the QRS duration itself is better than just the classic apical RV pacing. But how important it really is to capture the fascicles and so forth. We try because we're moving from, we come from his bundle pacing and now we're moving to LBBP. So we try to keep the same philosophy of capturing the conduction system. But I think that we need to stay open that maybe it's not an absolute necessity. And we will know in the years to come how important it is. But right now, I think if we can already get a nice QRS as you did in your cases here, that's already something that we can be satisfied with.
Thank you so much. So final couple of more comments from the experts before we disperse for the dinner. Chandra.
The appearance of S-wave in V5, V6, what does it indicate? Whether it is a main trunk pacing left bundle or going down?
I think it's just more distal and low. And I think that the R wave peak time there in V5, V6 doesn't really signify because it's usually really short, like 50 milliseconds and, almost too good to be true. So I don't think it has the same connotation as the studies which validated the R wave peak time that Marek did as well, where we are still more mid and a bit more basal. It's not the same significance.
Thank you.
Obviously reaching the lateral wall much too fast from the apex, so that's why the LVAD is short. It may not. I think so. And that's why you have all that debass.
But it doesn't necessarily mean that you've got the fascicular capture. Correct. Probably.
Correct.
Thank you everyone for expressing keen interest and cooperation on the day 2 of the symposium. We expect the same enthusiasm and participation in the following day also. Let's call off this day with dinner which was arranged on either side of the auditorium. Good night everyone.